Dear colleagues, distinguished speakers, ladies and gentlemen, good morning to everyone and thank you for joining us at the 6th International Hematology Oncology Colloquium. It is our great pleasure to have you all in this conference. First of all, I would like to present a special thanks to our Professor Dieter Niederwieser for his fundamental work in developing stem cell transplantation activities in our hospital. Professor Dieter Niederwieser has trained several physicians from different countries, including our hospital hematologists. Under the inspiration and leadership of Professor Dieter Niederwieser, the 6th International Hematology Oncology Colloquium is taking place again in Kaunas. We are very grateful to Professor for all activities, support, kindness, and goodwill. And now, with much honor, I would like to invite Rector of Lithuanian University of Health Sciences, Professor Rimantas Benetis, to say a welcome speech. Thank you, Professor. Please join us.
Good morning. Good morning, everybody. And it's a great pleasure and honor for me and privilege for the institution I am representing here today that you have organized such a nice meeting on hematology, oncology, and you will be discussing questions and issues in your field of research and clinical work of paramount importance. It is a real pleasure and privilege that this meeting is organized in Kaunas Clinic and Lithuanian University of Health Sciences. And when I looked at the scientific program, I saw this is exceptional and interesting presentations you will be sharing today and afterwards. And I also see the names of distinguished guests from Germany, Austria, Italy, and I had a chance, and by chance, I was able to sneak into the auditorium. You were sharing some news before you were connected to the meeting, and I could see nice smiling faces when you see each other and you communicate with each other. It seems like a very old group of old and very good friends. It means you are working in this field for a very long time, and it will be very interesting for our colleagues in Kaunas to hear your knowledge and experience and to benefit from it. Once again, I am very grateful for you gathering in Kaunas at this interesting time with the measures of telecommunication. And I wish you all the best in this meeting, and very productive meeting. And especially I would like to thank Professor Niederwieser, whom is a big friend of Kaunas, colleagues in our institution. Thank you very much, Professor. And I also thank others for coming to this meeting. All the best. The day is beautiful in Kaunas, so don't waste your time and productive work. Thank you.
Good morning, dear colleagues. Thank you, Rector, for such nice words for our conference and for great support continuous support for our program, hematopoietic stem cell transplantation program and cellular therapy program. And I would like to continue our program and would like to invite our distinguished person, Director of the General of Lithuanian University of Health Sciences Hospital, Kaunas Clinic, Professor Renaldas Jurkevičius, to join us. Please, Professor.
Good morning for everybody. It's a great honor for me to welcome this sixth already Kaunas Hematology Colloquium, and second time it's remote, virtual due to COVID-19 pandemic. Last year and the spring was hard for the hospital. COVID cases could not be avoided even in the hematology department. Nevertheless, allogenic transplants were successfully started last year. This year, 12 allogenic transplants have already been performed, which is almost half of all allogenic transplants in Lithuania. Congratulations to our cardiologists, to whole team of Kauno clinics, and of course to our leader, Professor Didger Niederwieser. We very much hope that this will be paid by state only, not only to Santora clinics, but also to Kauno clinics. As a young transplant center, we have ambitions not to stop. So far, we are jealous of how cell and gene therapy is being started in other countries. I think this conference will help us to better understand where we are in the context of the world, how far we are from cell and gene therapy, what we need to do to get it to Kauno clinics. Many thanks to the whole team of the hematologist oncologists led by Professor Didger Niederwieser. This is a big thank to him on behalf of Kauno clinics for this conference and for the progress of hematology in our hospital. We are glad that Kaunas Hematology Colloquia are becoming more and more good every year. As every year, Professor Didger Niederwieser was able to invite hematology leaders to attend to the conference and to deliver presentations and share ideas. Today, you will talk about very important things, not only in hematology, but also in oncology, but I can say even in whole medicine. And of course, I wish an interesting, successful conference. And I hope that next spring we all can meet safely and already in more usual way as we are used to be attending in conferences already in Kaunas. Thank you.
Yeah, thank you, Professor Renaldas, for such kind words and for everyday hard work for helping to implement with hematopoietic stem cell and cellular therapy program in the hospital, and for support of our team. We are very grateful to you. So thank you very much. And we will go to our conference program, and they see with their program is virtual. And next year, I'm sure we can meet in person in our beautiful city, Kaunas. This year, program covers all most important and burning questions in clinical hematology, experimental hematology, stem cell transplantation and cell therapy, gene therapy, and also it covers new findings in mRNA vaccine technology, and we hope that this technology will open doors to new treatment modalities in malignancy or even in autoimmune diseases. So just for general information, this day will be with many clinical and scientific talks, 4 scientific sessions scheduled for today, and with 19 speakers from 8 different countries, and we are very grateful for all speakers who agreed to share their knowledge with us. So thank you very much for them, what you are today with us. More than 400 attendees from more than 20 different countries are joining this colloquium today. So I think we are covering a broad spectrum of specialities, and we can discuss and share newest knowledge in hematology, oncology, and other fields, including COVID-19 situation, with our colleagues. And next year, I hope we will meet in Kaunas, all these people. On the conference website, you can see and view our online posters, the 3 best posters, and download the online poster abstract book. During the breaks, we invite you to visit our sponsors virtual exhibition, and please go to platform section Hangouts. So also we are very grateful for the support of this nice international 6th Kaunas, Lithuania colloquium, for all our sponsors. Without your support, we cannot organize such nice colloquium. And of course, this colloquium, we would like to be interactive, so don't be shy, ask questions, and in order to do so, please go to the platform questions and write questions, and we will try to respond to the questions and to discuss burning issues. And certificate of attendance will be sent by email to all registered attendees. So I think it's time to start our scientific program, scientific session. And for the opening of the first scientific session, I would like to invite Professor Elona Jozaitytė to join me. Good morning.
Thank you, Rolandas.
Yeah.
Now it is our great pleasure and privilege to have Professor Guillermo Sanz from Spain to join us for this conference and to have a presentation, What is New in MDS? I would like to say a few words about Professor Guillermo Sanz. He is a head of clinical hematology department, Hospital Universitario y Politécnico La Fe, Valencia in Spain, and he has published more than 300 papers and 32 book chapters. His main topics of interest are myelodysplastic syndromes, acute leukemias, and allogeneic hematopoietic cell transplantation. And he is co-chairing in the Innovative Medicine Initiative Alliances on the use of big data for better outcomes for hematological malignancies. And those projects are considered as the stars European projects in the field. Professor, we are indeed honored to have you here with us. So stage is yours. Thank you.
Well, first of all, I would like to thank the organizers of this exciting colloquium for giving me the opportunity to show you what are the new developments in myelodysplastic syndromes. These are my disclosures. And this is the content of the talk. I will first give a very short introduction and risk definition of MDS, and later on I will expand on the new developments of new therapies for lower risk and higher risk MDS. Now, I think that we, for defining higher risk patients, we should use the IPSSR international scoring system, and I would focus on the 3.5 points that hold for defining these patients, as published recently by the International Working Group on NDS. Starting with lower risk patients, the therapeutic options we have now are very limited. And mainly they include the use of lenalidomide in patients with del5q deletion, and in patients without these specific deletions, we rely on the use of erythropoietic agents and the use of GCSF. What are the new options for patients who relapse or are refractory to the use of erythropoietic stimulating agents? The first is lenalidomide. And in a work published by Valeria Santini and colleagues several years ago, lenalidomide gave a 27% transfusion independence in this kind of patients, and the median duration of response was about in percentage was 17.5%. The problem was adverse events, and this hematologic toxicity should be considered when using this drug for this kind of patients. Other compound that has been used in intermediate 1 patients with red blood cell transfusion dependency and thrombocytopenia is oral azacitidine. The first thing is that this is a very high risk subset of patients. They are not lower risk patients in reality. In this study, the 8-week red blood cell transfusion independence proportion was 30%, and the problem again was hematological toxicity. And for this reason, this clinical trial was stopped earlier than it was expected. It was good red blood cell transfusion independence, but greater toxicity, and in the end, no differences in overall survival. Luspatercept is a drug that has been recently approved both by the AMA and the FDA for the treatment of patients who are refractory or resistant to ESA and with ring sideroblasts or SF3B1 mutations. And you can see the design of this phase 3 trial that led to the approval of the drug, comparing luspatercept versus placebo. In this trial, 38% of the patients attained red blood cell transfusion independence, and this is higher than in the placebo control group. And the median duration of red blood cell transfusion independence in those responding to luspatercept was about 8 months. And 20 to 30% of the patients remain transfusion independent at 1 year. This led to the approval by regulatory agents of these agents for these specific patients, and now the company is studying the place of luspatercept in first-line treatment of lower risk MDS with red blood cell transfusion dependency, and is comparing head-to-head luspatercept and epoetin alpha. And this trial is ongoing, and we are waiting for their results. Another very exciting drug is the telomerase inhibitor imetelstat that has shown in patients with a high transfusion burden of red blood cell transfusion dependency to show a 42% transfusion independency. And the most relevant thing that was the median duration of this response, that was 20 months, and this has never been reported in this subset of patients. And now the IMerge phase 3 clinical trial is ongoing and recruiting very fast, and we also expect the results of this trial. Other agent that is now under investigation is roxadustat. That is an inhibitor of the hypoxia-inducible factor. In my opinion, the results that were presented at last ASH are not very good, in the sense that the proportion of patients responding was about 1/3, but the duration of response in this patient-naive population that have not been treated with erythropoietic stimulating agents was only for 4 months. Now there is a phase 3 trial comparing roxadustat versus placebo in this population, but lower risk transfusion burden. Coming to higher risk patients, the first thing that we have to say is that the therapeutic options we have now are very limited. And over the 15 previous years, there have been no drug approved for this specific indication, apart from the recent FDA approval of a new oral combination of decitabine that show we have only 2 options for these patients. For those who are transplant eligible, transplant is the best option because it's the only one that has shown a curative potential. But again, less than 15% of the patients are eligible for transplantation because of the risk of the procedure. And for the rest of the patients, we should rely on hypomethylating agents. However, what is happening with the use of hypomethylating agents in higher risk MDS? And this is a study from the SEER database that shows that in real life, the outcome of these patients has remained unchanged in every age group. And what are the reasons? As you know, in the trial that led to the approval by the EMA of azacitidine, the median survival of patients receiving azacitidine was 2 years. That was double the median overall survival of patients who receive what they call best standard of care. But however, the effectiveness of hypomethylating agents in the real world is lower. And the median survival in almost every series is between 12 and 17 months. And you can see here the results from the Italian, Spanish, and Dutch registry. What is really relevant is that the advances in our understanding of the mechanisms that are operating in MDS have greatly improved the armamentarium that we have now for this disorder. And I will concentrate on 4 specific drugs that, in my opinion, are the ones that may in the future be approved by regulatory authorities. And they include pevonedistat, sabatolimab, magrolimab, and venetoclax. Before start presenting the results of these drugs, I would like to open this section with the use of new schedules of all and new HMAs. You all know that the cytarabine in a greater dose than usual in patients with TP53 mutations has shown an excellent response rate with a median overall survival above 1 year. But these results, I have to say, that have not been reproduced by anyone. And the other compound is this new formulation of oral decitabine with cedazuridine that inhibits the metabolism of the cytarabine and the destruction of the drug in the gut. In this study that led to the approval by the FDA, what they were shown is that this combination show a similar overall response rate to the cytarabine, but again with a very good follow-up. The median overall survival for all patients was 18 months. That's to say that we do not expect that this drug will increase and the outcomes of patients with MDS. Other drugs are wadecytabine and oral azacitidine. For the last, we have no data, and for wadecytabine, the data we have is that it's likely that will not be better than azacitidine. Now, most of the clinical trials that are under investigation in MDS is the combination of the novel agents with HMAs. And I will start with magrolimab. Magrolimab is a monoclonal antibody against CD47. And CD47, this receptor, that is a macrophage checkpoint and do not eat me signal, is overexpressed in leukemic stem cells, and this avoids the killing of leukemic stem cells by macrophages. Blocking CD34 could be a potential way to again restore the phagocytosis of leukemic cells by macrophages. This is a study design of a phase 1 trial of the combination with azacitidine in 39 patients, and finally the combination of magrolimab plus azacitidine use escalating doses of magrolimab because of the presence of an increase in anemia in the first cycles, and the standard doses of azacitidine. The follow-up of this study is very short, is only 6 months, but the overall response rate is quite high, 91%, and 42% of the patients attain CR, and the overall survival, the median overall survival has not been reached. Coming to safety of this combination, it is important to say that it does not appear, with the exception of anemia, it does not appear to increase the cytopenias we see with azacitidine alone. And one relevant finding was that no autoimmune adverse events were observed. Obviously, magrolimab is now in phase 3 trials. The second drug is pevonedistat. Pevonedistat is a selective NETD8 active enzyme inhibitor, and it is able, when blocking this enzyme, to inhibit DNA replication, cell cycle, and NF-kappa beta signaling and lead to apoptosis and cancer cell death. We have now the results in 67 patients with higher risk MDS of a phase 2 randomized open-label multicenter study comparing the combination with azacitidine alone. And I have to say that this study was powered for showing differences in event-free survival, but not in overall survival. That was finally the primary endpoint that the regulatory authorities suggested to the company. As you can see, there was no statistical significance in differences in overall survival between the two arms, but event-free survival in these patients was better for patients receiving the combination. The median time to first response was not different for patients receiving the combination or azacitidine, and the median time to transformation to AML was double in patients receiving the combination. And regarding toxicity, what we can say is that there was an increase in the toxicity we usually see with the use of azacitidine alone, and using normalized ratios according to the number of cycles that the patient received. Even the combination arm have a lower incidence of adverse events than patients receiving azacitidine alone. So in this slide, that is a summary of the results. There was a very good overall response rate and CR rate, a better but not statistically significant difference in overall survival. The median duration of response in patients receiving the combination was the largest reported till now, 34 months, and the number of grade 3 to 4 adverse event was similar in both arms. Now, using the combined Cleveland Clinic model formula that incorporates not only clinical and hematological variables, but also genetic variables, what they were able to show is that for patients that they consider as high risk category, patients receiving the combination show a superior event-free survival, and there was a trend for a better overall survival in these patients. The next drug that all of you know is venetoclax, that inhibits BCL2 and restores the normal apoptosis process. The combination with azacitidine of this drug is very attractive because, as you know, azacitidine also inhibits MCL1, so there would be a potential synergy between both drugs. After a dose escalation study to show what was the best dose for the combination of azacitidine and venetoclax, finally they decided on a standard dose of azacitidine and the dose of 400 milligrams of venetoclax days 1 to 14 of the cycle. The overall response rate was excellent, with almost 40% of the patients achieving CR or marrow CR, and with a median duration of the response of 13 months and a shorter time to CR than we usually see with azacitidine. In the end, the overall survival for patients who receive the combination of venetoclax at 400 milligrams has not reached the median overall survival, and these are very, very good news. However, what we have also seen is that This combination increases the hematological toxicity that we see with azacitidine alone. There were 45% of patients who have febrile neutropenia, and cycle delay was required in almost all patients. More than half of the patients have more than 2 dose interruptions of venetoclax, and 35% of the patients require dose reduction for venetoclax and for azacitidine. So the problem that we see is that this combination could be very effective with very fit patients with higher risk MDS, but we will wait to the results of the phase 3 trial of this combination versus azacitidine to know if there are relevant differences between the two arms. The next drug is sabatolimab, and sabatolimab is an immune myelotherapy that targets TIM3 on different cells, including immune cells, leukemic stem cells, and blasts. And by targeting these different cells and inhibiting TIM3, they could allow the stimulation of the immune system to kill the leukemic cells. The results we have with this drug are very limited and are available both for decitabine in combination with sabatolimab and azacitidine. And in a global study, what we see is that the overall response rate was 60%, but marrow CR was seen in almost 30% of the patients, and 23% of the patients attained complete remission. Here again, like with venetoclax, the median time to response was shorter than expected, and with a very short follow-up, the estimated percentage of patients that can be in response is 6 months. And it's interesting to see that 1/4 of the patients that received the combination were able to go to the transplant. Regarding toxicity, the most common adverse events were consistent with those that had been reported with azacitidine alone, and the discontinuation rate was 0. And this is relevant because it is important for all the patients with comorbidity and high risk MDS to being able to receive the let's say 3 first cycles of the drug to see a response. Coming back to targeted therapies, the first is erenetapopt, previously known as APR-246. This is a drug that reactivates mutant TP53 and finally result in the apoptosis process that we normally expect from wild-type TP53. The drug has been studied in phase 1b and 2 clinical trials in combination with azacitidine. And in 2 different studies by the US and the GFM European group, the overall response rate was above 75%, and the CR rate was above 50% in both studies. However, the median duration is still short. And regarding the toxicities, apart from the hematological toxicity that was not higher than with azacitidine alone, this drug produced neurological toxicity that is usually reversible, but is evident in 22 to 40% of the patients. However, the company has very recently released a statement of the results of the phase 3 study in patients comparing the combination with azacitidine alone in this very high-risk population, TP53 mutated, high-risk MDS, and the study did not meet the primary endpoint that was complete remission, 33% versus 22%, and the difference was not statistically significant. And the analysis of other secondary endpoints is now underway, but at present there are no significant differences between both arms in these terms and also in overall survival. The other target drugs that are used in patients with MDS are the IDH 1 and 2 inhibitors, and enacidimab is the one that has, let's say, more data. And in combination with azacitidine in patients untreated and after failure of azacitidine, the overall response rate was very good, with almost 1/4 of the patients in both arms showing a complete response. But again, the median follow-up is very short, and event-free survival is between 4 and 8 months. Regarding toxicities, apart from the ones that we usually see with azacitidine alone, there was the expected differentiation syndrome that was present in more than 15% of the patients. In this slide, I have tried to summarize what are the potential future combination strategies for these patients. The one that is usually under clinical trials in phase 3 is the combination of an hypomethylating agent, mainly azacitidine, plus the investigational drug. There are now, and there will be more in the coming years, studies with a triplet of azacitidine and 2 different investigational drugs. And in the future, it is possible that we will see combinations of effective drugs in phase 1, phase 2 studies, but without the hypomethylating agents. And from my point of view, this is a way that we should explore. Finally, you all know that the outcomes after failure of azacitidine are very poor, with a median survival between 4 and 6 months. And for these patients, the best is allogeneic transplantation or investigational therapy. But at present, we have no drug that has been able to show an improvement in the outcome of these patients. So, to conclude, we think that there is an unmet need for these patients, that with the emergence of these new treatments that are based in our knowledge on the cellular pathways and gene mutations that drive MDS, we think that in the future we will have a way to improve treatment outcomes for these patients. And finally, my main recommendations is that if we want to improve the outcomes, we need to include this kind of patients in clinical trials whenever possible. And with this, I stop here and are ready for questions. Thanks a lot.
Thank you very much, Professor. We are indeed honored to have you here with us. And maybe some questions from audience.
Yeah, until now we not have questions. I just would like to ask, dear Professor, thank you very much for such nice lecture and perspective. And how do you think HAM agents, the future, it will be IV or oral or combination of them?
Well, my view is that oral combinations are clearly better for the patients, and especially in this COVID-19 pandemic, because we can avoid that the patients have to go to the hospital, and obviously they are. I think they will increase the quality of life of this kind of patients. So when we are using an hypomethylating agent alone, I think that the new oral formulations could be the best option.
And how you, Professor, envision, for example, reimbursement of these new drugs, and in Spain, for example, how you will expect in time frame? It's because it's not so easy to get access fast.
Yeah. Well, one thing that I have to say is that now for pevonedistat, there is a patient name program, a compassionate use of the drug that is accessible to every patient, and the only condition is that the patient should have received less than 2 cycles of azacitidine alone, and the drug is given for free. So I think that in many patients in our country now, the combination of azacitidine and pevonedistat is being used in many patients. Another interesting thing is that 3 or 4 days ago, the FDA has given the fast track designation for higher risk MDS patients to sabatolimab. So we expect to have results in the near future. And another relevant thing is that the results of the combination trial of pevonedistat plus azacitidine versus azacitidine is expected to be presented at the American Society of Hematology meeting in 2021.
Thank you very much.
Thank you very much, Professor, for excellent presentation, and it was very informative and interesting. Thank you very much.
You're welcome.
Yeah. So we continuing forward, and I would like to invite Professor Dieter Wieser to give lecture how many treatment options in acute myeloid leukemia we have now. And of course, Professor Dieter Wieser is professor in hematology oncology in Leipzig University, chief of our transplantation program in Kaunas clinic, founder and president of worldwide network for blood and marrow transplantation, and former president of EBMT, also president and did a lot of work in acute leukemia. So Professor Dieter, please, we are waiting for your lecture.
So thank you very much, Rolandas, and welcome everybody to the meeting, and good morning. So I would like to start by just speaking about AML pathogenesis and how this works, because this is very important for understanding also the disease and also the treatment by the end. So we know now since many years, since 2014, that we have, of course, somatic mutations in elderly patients, and almost 30% of the healthy patients have these somatic mutations, which doesn't mean that they have leukemia, but we know that we have this kind of development on clonal hematopoiesis in this patient. So this means today that we know that we have these mutations, which you know all tied to DNM3A, IDH1 and 2, and then it takes another hit, which is important to develop leukemia. And this other hit, it's usually an FLT3 ITD or others, as I will show you in the next slide. And after the second mutation, you will have then AML+. So that means that we don't have only 2 mutations, one here and several years after here. But at the end, we have more than 70 mutations in median in acute myelogenous leukemia. And you can see these several mutations here on this slide. You may have seen this here. Here you have these pre-leukemic mutations, DNM3A, IDH, which is a deregulation of DNA methylation. So this is epigenetics. But you have here mutations in signaling genes. You can see the FLT3 here, which is activated if you have this mutation into many different segments of FLT3. But you have also here changes in tumor suppressor genes. As you can see here, the TP53 may be deregulated. And you have also chromatin modification deregulations, as you can see here, by these different mutations, possible mutations. But you have also RNA processing mutations in AML. And you have here NPM1 deregulations or mutations. And finally, you have transcriptional deregulations and impaired differentiation. So this is what we know in what we did know in 2015. And this is important because for all these mutations, you may have a drug which can block it, which can try to stop the disease, not cure the disease, because as you know, we have many of them. So with one drug or two drugs, you will never be sufficient treatment. You will never have sufficient treatment to cure this AML. So as you know, azacitidine is mainly working on demethylation. So you can still modify this, but you still have the other mutations which are still around and needs to be treated. And as you have heard in myelodysplastic syndrome, we have also the BCL2 proteins. So these are activations and mutations which are pushing proliferation and also impairing differentiation. But in AML, you have also a stop of apoptosis. And by using an antagonist against the BCL2 protein, like venetoclax, as you just heard in myelodysplastic syndromes, you can have in the mitochondria the go to die for these blast cells. So this is blocked because BCL2 protein is overexpressed in many of the AML patients. But if you are stopping the BH3 only, you can go or you can induce to die for AML blast cells. Now, this is a figure which shows you how many of these translocations do we have, FLT3, NRAS, KIT, and so on. So this is important because you know that of every of these mutations, you can have a drug. But of course, this is theoretically. For the moment, we have only a few blockage, like for FLT3 and for IDH, but we don't have it for all. So if we want to cure an AML, we cannot just block everything here. We can, of course, replace everything by making stem cell transplantation. But you can also hope that in low-risk patients, you can suppress the clone so much that you have just normal hematopoiesis. So the other big success in the last year is the detection of alterations. So you know that we have morphology, which is looking for one cell in 100 cells, and cytogenetics, which you have one cell in 100 cells. With the flow, you can go to 10,000 cells, and with the 8-channel flow, you can go up to 10 to the 6th even. And with PCR, you can go up much more. And as you know, we have now the differential or the digital PCR, which is quite important because it's standardizing the measurement, which otherwise could be a problem, as we know from the EML story. And of course, we have next generation sequencing, and these are just a few of these machines which are now 4 years old. Now we have much bigger machines which can do the whole genomes, and these are quite affordable. The cost of MySeq is about 100,000 per example. Now, what is also important is the surface of the AML cells, not just the inside. The surface is important because you can target these different antigens on the AML cells. And you can see here CD123, CD33, and so on. These are the most important ones. The problem in AML cells is that these are expressed also in normal cells, not like in other cells in lymphoma or in other things where you can you can deplete all CD19 cells if you want. And so this is a challenge which we have, especially for CAR T cells. So these are all the drugs which in 2020 are available. Some of them are approved and some of them are in the pipeline. Now, this is very good news. Good news because conventional chemotherapy we have now for 30 years, or for 35 years. And there was not really improvement on conventional chemotherapy, as I can show you just in a few seconds. We have here the liposomal formulation of the chemotherapy, but we have also FLT3 inhibitors, which are approved. I will tell you about this. We have some in the pipeline. We have the IDH inhibitors, as you can see, approved, but I think this is not something where we can, where we have some problems at least in the newly diagnosed. The BCL2 inhibitor, I will show you some of the data. We have the hedgehog cell signaling pathway inhibitor, and we have, of course, the immunological part. And this is developing here very fast. You can see that we have here therapies like antibodies, like B-specific antibodies, like CAR T cells, and so on. So the question is, what are we going to decide here if you have the access to the pipeline in clinical studies or for the approved therapies? So just to give you the general principles of AML treatment, as you can see and as you know, we have the induction chemotherapy, and we hope to reach a complete remission. And then we have a consolidation chemotherapy, and you have then possibilities with chemotherapy maintenance, autologous transplant, allogeneic transplants, and to have then the cure. Now, important is to know that we are starting with 10 to the 12 plus load at diagnosis. And if you are reaching hematological complete remission, we have just a 2 log reduction. And this doesn't mean that the patient is cured. And we are now speaking also about molecular remissions. In CML, it's the big the disease which is learning us how to manage this load. Then with the consolidations, we are going down to 3 logs lower, and with MRD, we are able then to make a cure with chemotherapy and autologous transplantation, whatever the risk is of the disease. So what are the treatment milestones? Achievement of hematological complete remission, consolidation, achievement of MRD negativity. This is the problem that this is not standardized around the world. We are working on this, and long-term remission, and of course the reduction of treatment mortality. Now, if you start a treatment in a patient, you have to be sure what you want to reach, and this from the beginning and not just in the middle of the therapy. So I told you about chemotherapy. This is a paper we have published in 2013 where the 5 different study groups in Germany just entered the patients and randomized 10% in a common standard arm. You can see that there is no difference. So the standard arm was a therapy which was published 25 years ago. So there was no real advantage. And I'm working now on this same paper or same on a similar study which we did for patients over the age of 60 and also over the age of 60 with chemotherapy, depending if it's high intensive or low intensive. There is no difference in comparison to the 3+7 treatment. So what we did in our study group, and I have submitted this paper and will be published soon, our experience in AML under the age of 60 and over the age of 60, you can see 1,621 patients. And what is here important is the median age is 62 years. And the point is very important because these are real world data. Usually if you're looking at data from AML, you can see a lot of patients which are younger than 60, but only a very few over the age of 60. So there is a big selection, and here we did not select patients, so we entered every patient in these 2 studies, and you can see the different characteristics. I don't want to go too much in detail, but you can see that you have 70% of complete remission by using chemotherapy in all patients, and this is different for patients which are younger. It's about almost 80% just with chemotherapy, and in patients over the age of 60, 63%. So there is a high possibility to go in complete remission, and you have to check this always with new treatment modalities. Now, the other point which I want to say here is that 59 patients which were considered refractory after 2 intensive chemotherapies went into complete remission. So you still have, in about 10% of the refractory, you can have a complete remission even by giving a third or a stem cell transplantation with So the first big influence on survival is age. We have shown here the different decades in overall survival, and you can see that over the age of 60, we have a big difference between the survival. Here it's after relapse, but you have the same after diagnosis, but higher. So we changed, or we used the patients now for 14. We looked at the survival, overall survival after 14 years. And you can see that all the patients, irrespective of age, have an overall survival, which is around 31% at 5 years, 26% at 10 years. But if you're splitting then over and under the age of 60, you can see that there's a huge difference. The 10 years overall survival is 41% for the younger one and 10% for the older one. And so this is important to know because it has also some reflections on the treatment and on different things. So what we also did, we looked if the patients have a complete remission after 1 induction or after 2 inductions, or after complete remission. So I mean incomplete recovery. You can see that there is no difference in our hand over the age of 60. Under the age of 60, there is also no statistically significant difference. And here you have the partial remission patients. The partial remission patients have, even if they are in partial remission, you should just treat them in a curative way if you can, especially the younger patients, which have 30% at 13 years of overall survival. The patients older have survival in around 6 years, you can see, of 10%, and the non-responder have a very bad survival, of course. Now, FLT3 is another important risk factors for relapse-free survival, you can see, but this is just in younger patients and not in elderly patients. That's important to know because you may not see in elderly patients, you don't have to expect some survival because the survival is very bad anyway. So what is important is that the transplant-related, the non-relapse mortality, the treatment-related mortality, it's not different between the elderly and the younger patients. As you can see here, it's about 14% total, it's 12% in the younger and 16% in the older. But what is very different and what is quite high is the relapse incidence. We are speaking about 43% at 5 years relapse incidence, and this is about 63% relapse incidence in the elderly patients. So this is very important to know because we have to be better here. So the problem is not, of course, it's always higher non-relapse mortality of 40%, but the major problem is the relapse incidence. So if you're looking how good are we doing with the transplant, you can see there are 1,621 patients here, 1,144 went into complete remission, and we did transplant in 37% of these patients. Of course, not everybody should be transplanted, but you can see that 1/3 of the patients, so this is about the high-risk patients. Here, below 60 years, we are speaking about 46%, and here in elderly patients, about 1/3. So we are still not quite good here. So we can improve this in the future. And here, the refractory patients, you have 30% and 69% in the younger and 33% in the elderly patients. So patients are relapsing. What happened with the relapsed patients? I don't want to go to the whole table here, but I'm just telling you what are the treatments. Here, intensive chemotherapy, transplant, and chemotherapy before. So we are talking about 28.9%. Hypomethylating agents 10%, and the DLI 5.2%, and so on. But we still, with all these methods, we reach 40%. So this is something we can improve, a CR2, and you can see here that below 60 we have CR2 in 55%, which is not very bad, but could be improved. And for patients over the age of 60, 28%, which is significant less, of course. So what is important for CR2? You can see it here. In all patients, it's important in the multivariate analysis, the interval, if a patient is relapsing before 6 months or between 7 and 18 months and more than 18 months, this is important for the reaching of complete remission. And here you have the treatment. If the patient got a transplant, he will he will have a higher probability, even if it's not in complete remission, to have a CR2 in all patients. And this is, of course, important also for elderly patients. So the question is here, again, what is influencing the outcome in refractory AML patients? You can see the age is very important. You can see here the younger are doing better than the elderly, but overall this is not satisfying. You can see that the type of AML is important, is significant. You can see that the cytogenetics are important, and the interval between CR1 and relapse is also important. This is the key message of the talk. And for the first time, we looked at all ages here, depending of the patients had an allotransplant and before intensive chemotherapy. You can see that there is no difference in the survival depending on age. So we can equalize the results by using stem cell transplant. Patients which got just intensive chemotherapy have a survival of only a few percent after 4 years. So this is the first time that we can show that. And I think this is very important, especially in relapsed and refractory AML. So if you're looking at the data, what we did and what we are doing, you can see that for the relapsed patients here in CR2 and allergy and transplant, you have 68%. For all patients, you have 84% below 60 and 50% in the above 60. So we are doing quite good, but there is room for improvement. And if you're looking at the non-relapse mortality and relapse incidence, we still have here a little higher. It's 20% now instead of 14% non-relapse mortality. And you can see that relapse is almost the same. It's 40% and it's 60%. So I don't want to go too much in detail, but the very important things are in yellow here for overall survival. It's the karyotype, monosomal or non-monosomal. It's the CR1 and relapse time interval, and it's the use of stem cell transplantation for overall survival in younger and older patients, and also for I think this is the most important message. And we don't, for non-relapse mortality, we have just the type of AML and the use of stem cell transplantation. So I want to skip this. No, I want just to point to this here. So in elderly patients with palliative and supportive therapy alone, we split the intensive chemotherapy with the palliative supportive therapy because we don't want to dilute the results. And here you can see that HMA versus low-dose chemotherapy and palliative, it's very important for survival for patients which are not treated with intensive chemotherapy. So we are back again to our options today, and I just want to go quickly through the whole thing, just that you know. The first FL3 inhibitor, midostaurin, it's a first generation midostaurin. We published this in 2017, that midostaurin is increasing the survival, the use of midostaurin in comparison to placebo. But you can see here that this is only true for patients which got a transplant. So this is not something, if the patient is not getting a transplant, you cannot see this, and especially if it's getting the transplant after the CR1. So today we have many other options. You have seen the second generations of TKI. You can see here the quizartinib, you can crenolanib, the gilteritinib. So all of these have inhibitors action, but they are working on different locations in the FLT3, and some of them are also working on other mutations like AXL, and you can see it here. AXL has also different targets like proliferation, migration, and survival of AML cells. Now, you have seen this data. These are just for refractory, and these are monotherapies. So this FLT3 inhibitor is better than every salvage chemotherapy you can give. And also here you can see that quizartinib was better than any possible salvage therapy you can give as monotherapy, and this is fantastic. So we are talking about an action which is putting in complete remission at least 30 or 40% of the patients as a monotherapy, and we are excited about this. But you should also know that at the end, you will have only a few patient survival, so that will not be enough for curing a patient. I think what we did, or what we tried to do, is a responsive treatment in AML patients. You can see this trial, which is now submitted to Hematology from the OSHO. We just use azacitidine in patients which are in complete remission. They went on to a second course and then to transplant. So, and patients which were not in complete remission got first induction after 17 days and then went to transplant. So this is showing us that this treatment is just adapted to the response, and we had only a few percent of treatment-related mortality and very good results. The next the next study, which we are trying to start now in the OSHO, is the combination of azacitidine and venetoclax, and this is something which I think is very interesting. And then go again after the complete remission to transplant or not. So this will be quite interesting to see. But I just told you that azacitidine and venetoclax is one of the major news which we have, has been published by Dinado in New England Journal of Medicine. We are getting in patients which are not eligible for high dose therapy, 64% of complete remission. So this is quite good, and with that alone, 22%. So we are increasing 3 times the success of complete remission. And you can see here the results. You have to acknowledge that this is not curative. So when you can make a transplant to make it curative, but this is just a big advantage. And as Guillermo told you before, this was not per os, but usually you can do this as a combination per os. But this doesn't mean that it's not very toxic. So you have to admit the patients. You have to look for tumor lysis syndromes. You have a lot of infections and so on. So this is a price which we are paying for these results. What is the last very important situation? It's the use or the measurements of MRD. MRD patients have much better results if they are patients which are MRD negative at the first or second point. That means at the time of complete remission and then after consolidation. They have a lower incidence to get in to have a relapse than patients which are positive. And this is also important for the overall for the relapse-free survival, as you can see here. The best one, if they are negative already after the first time point, and then you can see the next one, which is negative after the first and positive after the first and negative after the second. So this is not significant, but it's significant if they are remaining positive. And what is the most important thing is that this is in this multivariate analysis, the MRD, it's determining overall survival, as you can see here, together with the use of stem cell transplant and also together with the cytogenetic risk. So for the first time we have here in this paper which just came out 3 days ago, we have the sign that we can improve survival. So many treatment options in AML. I think the take-home message is we have to have a fast set of genetics flow and molecular diagnostics at the beginning. We have to make a decisions on therapy aim involving the patients, of course. Do we want a cure or do we want a palliation? aiming at complete remission if possible, the use of MRD if possible, but of course this is a problem because it's not standardized around the world and we have to work on this. The effect of molecular therapy is time limited and should be followed by stem cell transplantation. But this is very important because many of the patients will get in complete remission and perhaps even in deeper complete remission, and may also improve the overall survival of stem cell transplantation. The stem cell transplantation according to cytogenetic use in younger patients, and in relapsed and refractory patients, we have to do stem cell transplantation anyway. I'm looking forward to the combination of molecular therapies, and of course, we have immunological approach in the pipeline. Thank you so much.
Thank you very much, Professor. It's really great pleasure to hear your presentation. And now I would like to invite Professor Andreas Hochhaus for next presentation. I would like to say a few words about Professor Andreas Hochhaus. He is the head of the Department of Hematology and Medical Oncology and coordinator of the University Tumor Center at the Jena University in Jena, Germany. He is a full professor for internal medicine, hematology, and oncology at the Friedrich Schiller University, and he has been interested in optimization of treatment for CML and has been involved in the management of randomized CML studies of the German CML study group for more than 30 years. Professor Hochhaus has published over the 580 peer-reviewed papers. He is editor-in-chief of Leukemia Journal, and he is regularly invited to speak at national and international symposiums. So it's a great pleasure and privilege to have Professor Andreas Hochhaus in our conference, and he will present a very interesting topic. Do we know all about CML and how to start and when to stop? So, Professor, thank you for your presentation in advance.
Thank you very much for this very kind introduction, and thank you for the invitation to Kaunas. I'm very happy to join this important meeting and to meet all of you. Only virtual, but I think it's important that we exchange our data. And you asked me to talk about how to start and when to stop in CML. And I think these are the two most important questions currently. We have so many drugs available to start, and we have many studies, data from studies available if we can stop and how to stop. And there's a lot of confusion, I think, in the literature. Therefore, I'd like to clarify a few points. And of course, for clarification, we need recommendations, and these is the evolution of the ELN recommendations here over the last 14 years. And in 2020, we published the 4th edition of the ELN recommendations, and you see the evolution of the different treatments here, of the different points. In 2006, when the first ELN recommendations were published, we had imatinib only. Now we have 4 drugs available. We had no real second-line treatments. Then, of course, nilotinib, dasatinib, and later bosutinib came on the market, and we have now 5 drugs for the overall management of CML patients. The salvage treatment had been in 2006 allogeneic stem cell transplantation, which is still the case. And it's not only salvage, that means we have to check the patients who are at risk early enough to transplant the patients in chronic phase if they need a transplant, and not in advanced disease, because outcome in advanced disease is disadvantageous, of course. The major milestone in 2006 was complete cytogenetic remission. Now we defined major molecular remission with the standardization of quantitative PCR, and now we come to the deep molecular remission when a patient wants to discontinue treatment. Our current concerns are still the side effects of the drugs, the long-term side effects, which needs to be considered in the initial decision-making with our patients. So, and I just want to introduce the colleagues who participated in our meetings for the ELN recommendations. 34 experts from Europe, America, and the Asian Pacific areas were present, and we sent out questionnaires. The questionnaires came back, and we aimed to achieve a 75 to 100% consensus. If this was not the case, this is mentioned in the publication, and importantly, there was no financial support from the industry for this meeting. I want to start very simple with the diagnostic follow-up, and here we still need, in addition to the blood count and the physical examination, a bone marrow aspirate, in particular to detect for additional cytogenetic aberrations which might be prognostically important. We need a banding analysis, not only FISH. FISH is only needed if the PCR and the cytogenetics fail. We need a qualitative PCR to detect the dominant BCR-ABL transcript for later discontinuation. That's very important. We don't need a quantitative PCR at diagnosis. And for prognosis, we need clinical parameters, which are age, spleen size, blast count, and platelets. These are actually identical to the parameters which were defined by Sokal a long time ago in 1984. However, the endpoints are of course different. Now we calculate for CML-related deaths, not for overall survival, and we have of course different drugs available with imatinib and others, and therefore the way of calculation is now different, but we still use the same clinical parameters. But in addition, here, and you see the advantage of the ELTS score over the so-called score. For instance, here in the high-risk cohort, we have more patients in the 6-year leukemia-related death cohort. That means the ELTS score is more stringent, not only for the high risk, but also for the low-risk patients, and therefore we prefer this way of calculation. And in addition to the clinical parameters, we use cytogenetic parameters. I mentioned already the additional cytogenetic aberrations in addition to the 922 translocation. Most importantly, it's a definition of the high-risk aberration, trisomy 8, second Philadelphia, derivative 3, 7, 17, 19, and 21. A simple 3-way translocation or a simple loss of chromosome Y is not prognostically relevant. Therefore, we need the definition of the relevant aberrations, and you see in the pink curves the survival of patients who had these aberrations at diagnosis in combination with the 922 translocation. And it's obvious that this is an unfavorable survival, and therefore these patients should be considered candidates for early allogeneic stem cell transplantation. And in addition to the chromosomal aberrations, we of course collect, as in other diseases, also molecular clones at diagnosis. Here you see the results from 100 patients who were investigated with next generation sequencing at diagnosis, and we found additional clones in 26% of them. And most frequent is A6L1, but also DNMT3A and others. However, since the data is limited for these additional aberrations, we don't know the outcome of these patients, and we need to collect this internationally with the Genomic Alliance founded by the International CML Foundation. And I think that's a good way to collect next generation sequencing data from the global assessments. 5 drugs are available, and you'll see here on these dendrograms the activities very similar to what Dietger Niederwieser showed for the FLT3 aberrations and other inhibitions in AML. That's here for CML. You see that not only BCR-ABL is inhibited, but many other kinases in the multi-kinase inhibitors, dasatinib, ponatinib, and bosutinib. Nilotinib and imatinib are more stringent more towards ABL, but you may acknowledge that also other kinases are inhibited, and this off-target inhibition may be the cause for the side effects, the specific side effects of these drugs. When we compare second generation inhibitors with imatinib for survival, we see no difference. That means we can use any of the licensed drug. When we look for survival only, there is no difference at all. However, we see a major difference in the speed of molecular response and the level, the proportion of patients in molecular response. The 3-month response, early molecular response, has an advantage for the second generation drugs, and also major molecular response and deep molecular response by 5 years. That means for a patient who aims at TFR, very early, young patients who want to start a family or other reasons, then of course a second generation drug has an advantage. Actually, in the global view, we have 3 considerations. Some colleagues aim for imatinib for everybody and change treatment only in case of failure. This is of course important when we look at the costs, because for imatinib we have generics which are less costly. However, we have the high-risk patients who may have a risk for early acceleration and blast crisis. These patients benefit from the use of a second generation drugs. This has been shown in clinical trials. But overall, I think we should discuss all the aims, all the goals of the treatment in the individual patient. We need to consider the comorbidities when we look for one specific drug, and therefore I confirm here that I'm part of the cohort number 3 and choose the first-line treatment according to the comorbidities and the aim of this treatment as shared decision-making with the patients. Because we need to consider the potential side effects. This is here the example of nilotinib. We know that nilotinib may produce cardiovascular side effects. Here you see in gray the 400 milligram twice daily, in blue the 300 milligram twice daily cohorts in comparison to imatinib. But it's important to consider, that's too fast here, it's important to consider that we have an accumulative side effect profile here. That means even after year 6 to 10, we still see an accumulation of nilotinib-related side effects. Therefore, we could, of course, start, but then if we are not able to discontinue treatment, we should change to alternative treatments. Otherwise, the patient will be at risk for these side effects. And we can use such scores to evaluate the risk for the individual patient. Here, the example with smokers, men and women, the blood pressure, the cholesterol amount levels. These scores are important to select specific treatment. This has not been done in the NSND study, and therefore we see this accumulation of side effects when we calculate the individual risk and select patients who have a low risk for cardiovascular diseases. Then we are on the safer side. And we have endpoints, and these endpoints were changed a little bit here. We have now in the new ELN recommendations the 3 months more than 10% level defined as a failure if this is confirmed in a second test. And we have the optimal response now as a definition after 12 months or later, the major molecular response. Only for patients who aim at TFR, the optimal response is defined as a 4-log reduction. That means less than 0.01%. And we need a very precise definition, a standardized definition of the PCR results. This has been achieved in Europe within the UTOS collaboration. That means in most countries in Europe, we are able to detect the BCR-ABL transcript levels on the international scale, and this should be the preferred method for the monitoring of the patients. What about the dose? With imatinib, we started with 400 milligrams, and we learned over time that a higher dose may have an advantage when it comes to the response level and speed of response. With all the other drugs, we started with a rather high dose and reduced the dose over time with nilotinib to 300 milligrams twice daily, with dasatinib at MD Anderson 50 milligrams per day. We do a study here in Germany with 5 days per week, which is possible with dasatinib because it has a short half-life. With bosutinib, now the standard dose for first-line treatment is 400 after the before study. And with ponatinib, there is an interesting situation because ponatinib 45 milligram produced cardiovascular side effects as well. And this was a concern for the agencies, but also for us as doctors, treating doctors and the company. And therefore the OPTIC trial was introduced considering 45, 30, and 15 milligrams per day in comparison. But the 45 and 30 milligram cohorts were asked to reduce their dose to 50 milligrams in case of BCR-ABL levels less than 1%. And with that, the side effect profile could be improved. That means with less cardiovascular side effects. And the efficacy is shown here. That means still the 45 milligrams has the best efficacy for the 315 mutation, but also for patients with other mutations and patients with no mutations. Therefore, the recommendation is now to still start with 45 milligram, but to reduce the dose as soon as possible if molecular response level less than 1% was achieved. The only exception are patients with a cardiovascular risk profile. They should start treatment with 30 milligram once daily. That means we have now a multitude of options available for second-line treatment with all the alternative drugs. But as already mentioned, we still need to consider allogeneic stem cell transplantation according to the risk profile. Beyond second line, we don't aim for major molecular response. We aim for a transcript level of less than 1%. We know that these patients are on the safe side. And however, if this is not achieved after 3 different drugs, it's time for allo transplant, definitely. So because as I already mentioned, we transplant in Europe currently more patients in advanced disease compared to early chronic phase. And this is, of course, a problem since we know that the outcome after acceleration of blast crisis or in second chronic phase is disadvantageous compared to a transplant in chronic phase. Therefore, we should use all the prognostic parameters available to select patients who need an early allogeneic transplantation. Now, how to stop treatment? The ELN panel agreed that TFR is an important new goal of CML management, and we should discuss this with appropriate patients very early, ideally immediately after diagnosis when we plan first-line treatment. We know from EuroSki and from other studies that according to the selection of specific patients, we achieve about 50% stability of treatment-free remission after discontinuation. Patients who relapse mostly very early after discontinuation. And we know from EuroSki that when we wait a year in deep molecular remission, we can improve the outcome by 3% per year. That means the stability of the treatment-free remission is improved when we don't stop too early, when we wait another year for the stopping. And this data, which has been published by many groups worldwide, has been summarized in recommendations for the requirements for tyrosine kinase discontinuation. CML in first chronic phase, motivation of the patient, of course, access to a standardized quantitative PCR, and the agreement of the patients to have a frequent monitoring. There are minimal requirements, TKI therapy for 5 years at least when it's imatinib, or for at least 4 years for second generation drugs, and the duration of DMR of at least 2 years. And we have now introduced optimal requirements. That means here we recommend a stop because the long-term side effects may be disadvantageous compared to the risk of discontinuation, which is minimal. The duration of TKI therapy more than 4 years, with a DMR more than 3 years if we have a 4-log reduction, or more than 2 years if we have a 4.5 log reduction. And we need, of course, the proper assessment of the transcript at diagnosis, as mentioned. If we have atypical transcripts, the official recommendations now don't recommend a stop, but we can, of course, bridge this if we have a method available which can sufficiently measure the deep molecular response here, and we recommended this individual molecular response for patients with atypical transcripts based on the UTOS group assessment, when we start at baseline with a quantification and then look for the log reduction on the individual basis. Pregnancy for men, there is good news. Men planning fatherhood do not need to discontinue treatment with imatinib or second generation drugs. The data for ponatinib and asciminib are not mature, therefore these are excluded. For women, the TKI treatment should still be discontinued in case of pregnancy. How can we improve the TFR, the deep molecular response? These are some experimental proposals. One is the assessment of the persisting stem cells, and I think most importantly is genomic PCR here, because we know that persisting stem cells don't express BCR-ABL on a higher level. Therefore, we need the genomic assessment from the bone marrow. And with that, we can select patients who still have a higher level of persisting stem cells and can introduce experimental therapies for these patients. For instance, BCL2, venetoclax again, or BTK inhibitors, or JAK inhibitors, or use TKIs in combination. Such studies are ongoing, but I think in addition, we need a stem cell surveillance with immune activation, and the standard drug here is, of course, interferon, which is in clinical trials as well. And my final point is asciminib. With asciminib, we imitate the autoregulation of ABL with the myristoyl and terminal in the myristoyl pocket, which is not possible if we have BCR-ABL, because in case of BCR-ABL, BCR is substituting this myristoyl tail here, and we need a drug to bind to the myristoyl pocket, which is asciminib. And asciminib was used now in a phase 1 and also in a phase 3 study in third line. And you see here on the right side that there is no overlap in the resistance profile with the traditional tyrosine kinase inhibitors. And in the third line study, in comparison with bosutinib, there was an advantage of early major molecular response compared to bosutinib. Therefore, asciminib may be a good choice for a third-line treatment. The side effect profile has improved, except for cytopenias. Thrombocytopenia and neutropenia is a little bit more frequent with asciminib compared to bosutinib. This is part of the efficacy of the drug when we have a slow recovery of the normal hematopoiesis. In summary, I think what we want to achieve is for the long term, because we treat our CML patients now at a long term, preserving the quality of life for all our patients. We should consider the comorbidities, and we should reduce the financial strain associated with the CML management for the patients, but also for the societies. Therefore, a very precise check of the available drugs, of the aims of the treatment, and the use of the treatment-free remission option is important, most importantly, of course, for our patients to reduce their burden of the disease. With the final slide, I thank all the panel members who participated in a very fruitful discussion and in the publication of the fourth edition of the ELN recommendations. Thank you very much for your attention.
Thank you very much, Professor. We are indeed honored to have you here with us, and it was very important presentation for hematologists. Maybe some questions, maybe Rolandas.
Yeah, thank you, Professor. Very nice and clear presentation. Just I would like to ask, in your opinion, how many patients are aiming for treatment-free remission, and how many patients would be benefit from interferon alpha, for example, just in Germany?
Yeah, two very important questions. I think the aim is very high. I think more than half of the newly diagnosed patients have this intention when we discuss the options. But the reality is different. We have now, with the second generation inhibitors, only 40% who are eligible because they have a deep molecular response. That means we need to focus on the increase of the deep molecular response proportion of patients in deep molecular response. And interferon, I think several studies, for instance, the French group, have shown that the addition of interferon to a TKI brings an advantage of the early molecular response, but over time, I think this is leveled up with the long-term TKI treatment. I see interferon as a maintenance treatment after TKI discontinuation. These studies are ongoing. We have only pilot data available, but the pilot data are very promising. That means with a half year or 1 year of interferon treatment after TKI treatment, we may induce an immune response to the persisting stem cells, but these studies are not closed yet. And but in this situation, I just want to motivate all companies producing interferons to continue so. We know that Peg-Intron is now off market, and Pegasus was close to be off market. Fortunately enough, Roche decided to continue with Pegasus, and we have, of course, the new ROPEC interferon from AOP. That's promising. We need these drugs for our continuation of immune activation in CML patients.
Yeah, thank you, Professor Hochhaus. Just for the sake of time, we must continue conference. Thank you very much. And
thank you.
Just yeah, I would like to, at the same note, to continue myeloproliferative disorders and invite Professor Tiziano Barbui from Bergamo. He is director of Scientific Foundation of Clinical Research at Ospedale Papa Giovanni Hospital Bergamo, Italy. He very well known for us in the field of chronic myeloproliferative disorders and teach us a lot in this. So, Professor Tiziano Barbui, we kindly invite you to give lecture on unmet clinical needs in the management of classic chronic myeloproliferative disorders. So we are grateful that you are joining our conference. Thank you.
Thank you. Thank you very much for this new invitation. And thank you also for asking me to talk about this topic. The myeloproliferative neoplasms include 3 diseases: polycythemia, essential thrombocythemia, and myelofibrosis. That these diseases were grouped by William Dameshek many years ago in '51 as a unique spectrum of chronic bone marrow disorders. Characterized by an excess of proliferation and abnormal maturation. These disorders have some characteristics. I'm sorry, but okay. Three main diseases have overlapping features, I have to say, because polycythemia can transform to myelofibrosis, as well as essential thrombocythemia may transform. Sometimes you have some difficulties in recognizing each of these entities, and you have to follow the WHO diagnostic criteria that were released in 2016. Mutations are characteristics of these diseases, and you have three types of mutation. The first are mutation phenotypic driver mutation. Basically, all patients with EPV have JAK2 positivity. PMF and ET JAK2 mutation is in around 50–60%. Typically of PMF and the ET, you can have a CALR mutation and the MPL mutation. These are called phenotypic driver because without this mutation, you cannot induce in the animal the phenotypic of these diseases. But you have also to consider, especially in this area, next generation sequencing, the mutations that are involved in the progression of the disease, initiation and the progression. As Professor, as the other speakers told us, starting from Dieter and also Professor Hochhaus. Well, the clinical manifestation of myelofibrosis are different from ET and PV, polycythemia vera. In myelofibrosis, the survival is 6 years, median survival is 6 years. And the clinical course of the disease is characterized by anemia, symptomatic splenomegaly, constitutional symptoms. However, in a small fraction of these patients, you can have infection. Infection is a very important issue because the infection, especially in myelofibrosis, can be a cause of mortality, especially in this era of the pandemic. During COVID-19, the mortality in myelofibrosis reaches during the acute phase 50% of these patients, independently on the stage of the disease, can have mortality due to many reasons, but especially due to the severity of the disease. So you have more diseases, more patients with MPN who can get COVID-19, and the mortality in these patients is exceedingly higher than in ET and PV. On the contrary, in PV and ET, the main problem, at least in the first years after diagnosis, is thrombosis. Later, in the second decade, you can have myelofibrosis, as I said, or transformation in acute myelogenous leukemia. Of course, independently of the risk of these two diseases, and the risk is calculated according to the propensity to have a thrombosis. Independently of that, you can have symptoms. Symptoms are bound to cytokine or vascular microdisturbances and of course also to disease evolution. So the purpose of my lecture today is to point out especially thrombosis. Why that? Because I think this is really a great unmet clinical need that can be modifiable, so that we have to invest our research, especially in thrombosis. And the first point I would like to point out for you is the prevalence of thrombosis. The prevalence of thrombosis and the incidence as well of thrombosis can be calculated in two periods of the disease, at or before the diagnosis. In these cases, you have about 30% of patients with diagnosis of PV, they can present with severe thrombotic events versus 20% in ET and 10% in MF. Arterial thrombosis is threefold higher than venous thrombosis. And this is important because the physiopathology of thrombosis can be different in these diseases. The second point I would like to mention for you is the incident. Of course, you can influence the incident by therapy, and you have to recognize, and this study is very, very important for that. You have to recognize that arterial thrombosis, that is this, at the beginning of the disease, in the first 3 months and the first year, the hazard ratio is about 3 or 2. Hazard ratio meaning that if you consider almost 10,000 patients with MPN versus 30,000 patients matched controls in this registry, published results in the Annals Internal Medicine by the Swedish investigators, you see here that you observe a decline of the curve of the arterial thrombosis in the first years, but this curve still remain elevated, so that over time you still have 3% patient per year of thrombosis. This is unacceptable in a disease like this, because 3% patient per year means 3, 4, 5-fold higher than in normal population. This is particularly evident for age over 60 and patients with prior thrombosis. But another important finding is the venous thrombosis. Venous thrombosis, the hazard ratio. Hazard ratio means the probability to have these events in comparison with the matched controls is almost 10 higher than normal population venous thrombosis. But of course, in absolute terms, the venous thrombosis is less, as I showed you before, than arterial thrombosis. But this is very important. This could be a target of our therapy. This comes from meta-analysis, from registry, and what happens in the real world clinical practice. In our patients, we have similar these results. We have more than 3,000 patients observational studies or clinical trials in PV, ET, early PMF, or PMF. This corresponds to the classification, WHO classification, current WHO classification. You see here the rate percent patient per year is about 3% in spite of therapy. And this is seen total thrombosis, but also in arterial and venous thrombosis in the different situation. So still elevated rate of thrombosis. How to do? Which strategies can be used to reduce the vascular risk? Of course, prevention of cardiovascular risk factor. I have no time to spend some minutes about that, but just I wanted to point out that hypertension is very important, especially in patients with polycythemia vera. Of course, you have to use disease-directed strategies. Disease-related strategies mean drugs against the disease. You have to use phlebotomy for hyperviscosity, but the aim of the drugs that are used is to reduce what is the main pathogenesis for thrombosis. Main pathogenesis is related to leukocyte platelet abnormalities and the consequent inflammation. And the inflammation is driven by the mutation status of the disease. Of course, when you have the event or before, you can use as a prophylaxis antithrombotic drugs. I will spend some minutes talking about the anticoagulants. So the first unmet clinical need is aspirin. Should we use aspirin in thrombocythemia? This is important issue because as you know, in polycythemia vera, we produce a clinical trial. Is a placebo-controlled clinical trial showing that you reduce cardiovascular death plus major thrombosis with 100 milligrams of aspirin without enhancing very much the risk of bleeding. But we don't have studies, clinical trial in ET. This is an unmet clinical need. But if you use this scoring system that we published some years ago, and this scoring system is now adopted by all the organizations that produce guidelines such as ELN or NCCN, that are guidelines produced in America, North America. In very low risk patients, you shouldn't use aspirin because the risk of bleeding of aspirin is superior to the risk of thrombosis is if a patient doesn't have history of thrombosis, is younger than 60, does not have JAK2 mutation, and is without a risk factor. This patient should not treated with aspirin because the rate of thrombosis is 0.4% patient per year, and the risk of bleeding of aspirin is clearly superior. In other situations, the aspirin should be used, but especially in high-risk patients. We are discussing now whether we need 2 aspirin a day, twice a day, because for pharmacogenetic problems for that. I have no time to go into detail about that. But what is important is to consider the randomized clinical trial in ET. 3 are the randomized clinical trial using hydroxyurea as a standard in each of these. This is the first trial we produced almost many years ago, decades ago. And you see here, the rate of thrombosis is 3.6% patients, is the same in the more recent trial by PT1, 4%, and in the trial enrolling patients classified according to WHO diagnostic classification is still 3%. So with the standard treatment, you have still in ET, in all these patients treated with low dose aspirin, you have 3 to 4% patient per year. It did not change over time from 95 until now, say. So something should be done here. Another point important is what to do when you have a patient, 1.5 million of platelets without any preceding risk factors, without thrombosis. This was the subject of a clinical trial just produced, and you see here, if you give the combination of hydroxyurea plus aspirin versus aspirin, you don't have any advantage in terms of thrombosis. So this is again the demonstration that there is no correlation between the number of platelets and the thrombosis. Bleeding is important, and bleeding in ET should be considered especially in prefibrotic myelofibrosis. In patients with prefibrotic myelofibrosis, in comparison with those patients classified according to WHO as a true ET, is superior. So careful in giving aspirin here. So you need a good pathologist to differentiate these two entities. We had patients with cerebral hemorrhages with aspirin in prefibrotic myelofibrosis. So guidelines accepted, as I said, the classification of the risk according to the IPSET thrombosis. This is the last version on the NCCN guidelines for essential thrombocythemia. They reproduce exactly what I told you so far. The second unmet is phlebotomy. Phlebotomy is the standard of therapy for patients with polycythemia vera. But in low-risk patients with polycythemia vera, you still have an enhancement of the rate of thrombosis. This is what happens in the general population. You recognize that you have 3-4 times higher the risk, especially in high-risk patients with PV. One of the problems that could be taken into consideration is that you have to keep the hematocrit less than 45% steadily over time. not in a point, but over time, a patient should keep the hematocrit less than 45. In this case, you can reduce the incidence of thrombosis of fourfold as compared with those patients who cannot maintain the hematocrit less than 45%. This was in a clinical trial. But what happens in a low-risk patient? Should we be able to keep the hematocrit less than 45% by treating this patient with only phlebotomy? We examined this point in our ECLAP study. Only 50% over time, 12, 24, 36 months were able to keep the hematocrit less than 45% by phlebotomy alone in the real world clinical practice. Is difficult. So if it's difficult, there is another point to be considered, that there is a correlation also in low-risk patients between leukocytosis and thrombosis. And you see here, for patients with more than 11,000 leukocytes before the event, this is a time-dependent analysis. The risk of thrombosis is fourfold higher than in those patients with normal leukocytes. So you need two things. First, you need to keep the hematocrit less than 45, and possibly to keep also the leukocytes less than 11,000 to reduce the risk. And we try to do this by a drug. Ropeg interferon from AOP was used in a clinical trial by comparing a strict phlebotomy program with Ropeg interferon. We just published the first interim analysis of that, showing that even though you see a patient in a clinical trial every month and you do phlebotomies as soon as a patient presented with hematocrit over 45%, in this case, the best performance is to maintain the hematocrit over 1 year in 60% of your patients. On the contrary, if you do Ropeg interferon, this maintenance of the hematocrit is reached in 84% of patients. Another important thing is that in those treated with only phlebotomy, you get some events, one thrombosis and other microvascular symptoms due to thrombocythemia. So that, what about white cells? White cells were normalized, platelets were normalized as compared with the standard phlebotomy arm. And we realized that since EMA accepted now the Besuremi, that is the name, a commercial name of Ropeg interferon, approved this drug. But we were quite reluctant to accept the indication of this by EMA. This agency, the indication is all patients with PV, except those who present big splenomegaly. I think this should expand too much the use of interferon in many patients, so that we have a study now. This is an European Leukemia Net project, and we try to reach a consensus on the treatment in some specific subgroups of low-risk patients in need of treatment and some specific high-risk patients, keeping in mind that the standard of treatment is always the hydroxyurea in these patients. So the third unmet clinical need could be whether the new oral anticoagulants are better than the VKA warfarin vitamin K antagonists. And we did that in a study. This is another ELN study, and just published in Leukemia in May, 1 week ago, in these patients, 442 patients treated with DOACs. There were participating 19 centers from Europe, US, and also Canada in atrial fibrillation or in venous thromboembolism. This is an observational study, just to have the perception whether this can have some performances that could be higher, most favorable that we have observed before with warfarin. And things are the same in terms of recurrent of thrombosis for atrial fibrillation and also bleeding, and especially for venous thrombosis. We observed in these patients 9% of recurrences and 5% of bleeding. If you compare historically from our ELN data on DOACs, you have 4% of recurrences. On warfarin, you have the same, 5%. What is important? You should not stop the drug in venous thrombosis. Otherwise, almost 10% of patients can have recurrences. Of course, you have to consider also the risk of bleeding. So, in summary, we concluded that the same as reported with warfarin, but we need a clinical trial, as it is difficult to convince a company to invest in a clinical trial in rare diseases such as MPN. So, in conclusion, ladies and gentlemen, major cause of mortality in PVM and ET is thrombosis. Still now, 3%, 4% according to the risk. So the current therapy is unsatisfactory. There is no demonstration that a drug is better than another drug. We don't have a demonstration that ruxolitinib can be better than hydroxyurea to reduce thrombosis. On the other side, we have to change the way of approval of the new drugs, because the new drugs are approved on the basis of surrogate biomarkers, such as hematological response. But this should be validated. We don't know whether hematological response is really a surrogate of thrombosis. So we need a randomized clinical trial for antithrombotic drugs. With that, thank you very much again for giving me this opportunity to talk for you. Thank you.
Yes, thank you very much, Professor Tiziano Barbui, for such clear coverage of such complicated topic and your personal input in the field of chronic myeloproliferative disorders. I just hope that you will lead us forward to investigate and answer all of these questions in the future. Just of the sake of time, we must continue, and maybe we'll have time to discuss later. Thank you again. We are honored what you joined us.
Thank you.
Thank you very much, Professor.
See you.
Great.
And I would like to continue our conference, and my privilege to introduce Professor Sergei Klimenko from Kiev, Ukraine, and he is head of the Department of Medical Genetics, National Research Center for Radiation Medicine of National Academy of Medical Science of Ukraine, professor and chair of internal medicine, #1 of National Bogomolov Medical University, Kiev, and he did great research in London, UK, and in Germany, and he obtained his PhD in radiation biology, and he is well known on research in this topic. So I would like to ask Professor Sergei Klimenko to give his talk about chronic myeloproliferative neoplasm in patients exposed to ionizing radiation after Chernobyl nuclear accident. Please, Professor, floor is yours.
Good afternoon, ladies and gentlemen. Thank you very much for nice introducing me. It's my privilege to present our data on chronic myeloproliferative neoplasms is developed in person exposed to ionizing radiation due to Chernobyl accident at KIHOC 2021. First of all, I would like to acknowledge the colleagues which took part in this study and contributed a lot in data generation and analysis. This year we have already 35 years after 1986 Chernobyl accident, and it's probably time to draw some conclusions. And what we know is that Chernobyl accident significantly increased the leukemia incidence in Ukrainian cleanup workers. Thus, the molecular signature of preceding ionizing radiation exposure might be detected in affected populations and in myeloproliferative disorders as well. So we hypothesized that DNA from the blood cells of exposed MPN patients might exhibit a different rate of 3 common driver mutations, and novel alterations of copy number and mutations might be found, which contribute to the evolution of radiation-associated disease. To answer these questions, we collected blood samples of 90 myeloproliferating neoplasms patients which were exposed to ionizing radiation due to Chernobyl accident, and compared them with 191 samples of, let's say, spontaneously developed myeloproliferative neoplasms. First, we studied these samples for usual driver mutations, JAK2, color, MPL, but then we extracted some special group of interest. These were 13 primary myelofibrosis cases developed in radiation-exposed patients, and 17 unexposed patients, and studied them for additional genetic variants, whole exome sequencing and copy number alterations, and copy neutral LOH. Based on the results, the panel consisted of 309 cancer-related genes were created to perform target sequencing in triple negative cases, which we had in our MPN patients group. First, I will mention the clinical data of our patients, whether they were different in clinical parameters. In fact, they were rather similar, at least in terms of thrombosis history, in terms of transformation to acute leukemia. However, ionizing radiation exposed patients more often were transfusion dependent and more often exhibited splenomegaly compared to spontaneous MPN cases. The burdensome of symptoms evaluated by MPN sub-TSS score also demonstrated some differences. Radiation exposed patients had more pronounced symptoms burden compared to spontaneous cases, as in the whole group and in different subtypes of MPN as well. The study revealed that the frequency of usual driver mutations is somehow different in exposed and unexposed MPN patients. Chernobyl victims were characterized by JAK2 mutation less often compared to spontaneous cases. However, they exhibited type 1 color mutation more often compared to spontaneous cases. Colloquium sequences identified a lot of different previously reported and unreported non-synonymous nucleotide variants in radiation-exposed patients, and the mean number of these variants were 4.8. However, the mean number of non-synonymous nucleotide variants detected in ionizing radiation unexposed patients was lower, 3.8, and difference between the groups was statistically significant. There was no significant difference in the rates of copy number loss, copy number gain, loss of heterozygosity, or multiple chromosomal alterations between exposed to ionizing radiation and unexposed primary myelofibrosis group. However, you can see here that it seems that unexposed primary myelofibrosis patients has more frequent deletion at 20q, deletion at abnormalities at chromosome 13, which we consider usually as more favorable. However, there was no statistically significant difference between group on these parameters. We tried to reclassify our cases using the data generated according to genomic classification and personalized prognosis in MPN created by Greenfield several years ago. We failed, in fact, to find the statistically significant difference between the group of patients with primary myelofibrosis exposed and unexposed to ionizing radiation. However, there was a trend on the border of statistical significance for MPN with chromatin and splicetome mutation. Probably we need more effort to increase the number of cases to reach the statistically significant conclusion. When we compared most common genes with variants being pathogenic or potentially pathogenic between the group of study, for the cases negative for usual driver gene mutations, we didn't find the pronounced difference between the groups. However, when we concentrated on 3 genes which are usually described as DTA genes, DNM T3A, TET2, and ASXL1, we found that mutations in these genes were detected more often in patients with a history of radiation exposure than in patients with spontaneous disease, indicating possibly that these cases were characterized by precedence of clonal hematopoiesis of unclear potential, which we knew from literature as the characteristic of older population. And mutations in the DTA genes were not found in any of the cases of spontaneous triple negative MPNs, whereas the group of radiation-associated triple negative MPNs was characterized by mutations in DTA genes with high incidence and significantly higher frequency compared to spontaneous cases. I've already told that we haven't found any difference in thrombosis history between the group. However, from the data of literature, we know that DTA genes mutations are usually increasing thrombotic risk in PV patients. Probably we should look closer at our group and try to find the missed difference in thrombosis prevalence. We also compared our data to recently published manuscript by Professor Ernst, which described the mutational pattern of chronic myelogenous leukemia patients affected by radiation due to the Chernobyl accident. And we also see here that mutations in DNM T3A, ASXL1 are rather prevalent in Chernobyl victims, which is rather similar with our finding in Phe-negative myeloproliferative neoplasms. We also compared the gene functions in genes affected by mutations in either radiation exposed and unexposed group. However, there were no so pronounced difference between groups. However, several non-canonical mutations in JAK2 were also found. Another point to mention is that with such a huge data generated by this study, we also managed to find several rather interesting mutations, like ATMS1691R missense mutations, which was not described in primary myelofibrosis before, and EZH2 missense mutations, SUS12 missense mutation, which are also rather rare in myeloproliferative neoplasms. To conclude, I would like to mention that, of course, we identified a wide spectrum on non-synonymous sequence variants among ionizing radiation exposed and unexposed MPN patients. However, difference was not that pronounced in prevalence of different types. But what was What took an attention is that mutations in DTA genes were detected more often in patients with a history of radiation exposure than in patients with spontaneous disease, indicating possibly frequent precedence of MPN by clonal hematopoiesis of unclear potential. Thank you very much for your attention.
Thank you very much, Professor Sergei Klimenko, for your presentation, and it's of course very huge database and very interesting findings, and huge job. And how you envision maybe different treatment can be applied algorithms for these patients who are radiation exposed versus spontaneous NPN, or in any way, or
we've seen in our clinic a lot of cases with MPN, both in radiation exposed and unexposed cases, and treatment is usually the same. Of course, patients which were exposed, based on our data, are having more symptoms, and probably we will just start some treatment modalities earlier, or we'll finish some modalities later, but the approach is the same.
Okay, thank you.
Professor, thank you. Now we will have a short break till 12:45, so it's a very short time. Thanks for all presentations, and we will continue after 5 minutes. Thank you.
Thank you.
Thank you.
Yeah. Bye-bye.
Hello, everybody. It's my great pleasure to be the co-chair of the session on cellular therapy, gene therapy, and mRNA technologies. And I would like to introduce Professor Dietger Niederwieser. He's the chair emeritus of the University Hospital in Leipzig, and he was the past president of the EBMT and the WBMT. And it is now my pleasure to listen to his talk on cellular therapy, gene therapy, and mRNA technologies. Are we improving? Dietger.
Thank you.
Yeah, thank you so much. This should just be a short introductory talk to the two next presentations, and I hope I can give you or can show you my exciting about these new possibilities. So let's start with cellular therapy, and I just want to show you that this is not a new thing. Cellular therapy Don Thomas in 1957 has published his first paper on the first successful transmission of bone marrow to another individual. Of course, we had for 20 or 30 years earlier, we had some tries to just inject bone marrow to people, but these were all non-successful. And today we are speaking about 1.5 million of cellular therapies, transplants in the world. So this is quite a big success for cellular therapy. And I think this is this saved the life of many people around the world. The other point which I just want to mention is the virus-specific T cells. We had a talk last year. This is something under development, and you can see from this slide that 246 patients have been treated with virus-specific T cells, and we had and the people lead it from the unit in Munich had 181 responders with a very high successful rate. So this is something which will be developed further during the last years. The gene therapy, it's also not very young. The first publication is from 1973, and you can see that at that time already they have made some gene therapy, and they describe it in the way that the cells ingested chromosomes which replicated in another host. So we are talking about 1973. And just to give you a short introduction how that works, the usual way how it works, but this is not the only one, has been published by Martin Klein in 1985, and you can see here that what they did is they used a virus which was empty, and in this empty virus they put the vector which then should have given or should have started to work in the new cells and infect also the other cells which wanted to be infected. The first in vivo treatment was for Steven Rosenberg, which used this gene therapy as a marker for donor lymphocyte diffusion. We also worked on this on canine keratinocytes when I was in Seattle in 1986, 1987, where we used the G418 resistant vector to infect keratinocytes of the dog, and we transplanted them in the dog, and we found that these were not immunogenic, and they resided there for more than 6 months. Now, going to humans in 1980, the people was thinking that knowing the genes which were debilitating, they can think about cures. And the problem was that some of these patients had actually oncogenesis. So that means that 9 of 10 patients were treated successfully after they got leukemia. But I think this is a problem, and you should distinguish, if you are looking about gene therapies, about insertion in stem cells and insertion in mature hematopoietic cells like T cells and so on. So this was the problem in the 80s, and then in the 90s there was a reaction, and actually it was an allergic reaction against the virus, and therefore in 2000 they came back and to the drawing board, and were thinking about how to make less harmful viruses, or how to use less harmful viruses to create killer cells. And one of the very important publication was from Ayuti, which showed that by using lentiviral vectors, you have an insertion just on one place of a gene, here on chromosome 3 and chromosome 11, and with usually retroviral insertion, you have multiple insertion in the genes, and this was something which helped to understand how what was the problem with these leukemia patients. Today we are looking. We need to have gene therapies in thalassemia, and these are work which is ongoing. And you can see that we are looking at not only a gene correction, which is much more difficult, but at more, I would say, other way to insert gene in addition, or to disrupt genes and so on. So these are all possibilities which we have today. Now, what about the CAR T cells? Just shortly, the CAR T cells are gene therapy, and this is the success of gene therapy. You can see that this is not very new. It's the first idea came from 1987 in Aichi in Japan, and von Selig Escher in Israel in '89, where they were seeking to put a gene which was expressing an immunoglobulin receptor, which was able to recognize tumor cells. And since then, we have a lot of antigens which were used in different kinds of situations, leukemia, lymphoma. You can see here in the US and in China, different antigens. And these are the trials which are going on at the moment. The problem with this is that we need some time to produce these T cells. And we are also working on the possibility to use unrelated CAR T cells. That means that the CAR T cells are already with a specificity against an antigen, are already in the shelf or are in the are prepared, and we can treat the patients with this kind of unrelated CAR T cells. And here's some of the possibilities: the UCART1 to 3 for acute myelogenous leukemia, for example. So these are studies which are going on and hopefully will be finished soon. Now, what about mRNA? You can see it here, technology. You can see that also the mRNA story is not very young. The discovery of mRNA was in '61. You can see that the first experimental studies were already in 1990, and we have a lot of experiments which were done. And lately, we have, of course, the the exciting story about the vaccination of COVID, which is also based on mRNA technologies. Now, why mRNA? So usually the idea to use mRNA, it's not very, it was old, but the problem was always that this 5 cap was very unstable, and they designed this cap in a way that it can be used and it can be introduced also in cells. There was a problem of delivery of this RNA, and we have different possibilities like NACT, electroporation, nanoparticle formulation, protein formulation. And this is the way how today mRNA is looking to use to be infected. And the exciting story about this is that the formulation of this mRNA can be used not only to inject it intramuscularly, but it can be manipulated so it can go in different cells of the body. They may be specific for liver cell types, as you can see here, for hepatocytes, and that's depending on the surface of the delivery point. So you can see here how this delivery can be done. Intravenous, subcutaneous, you can see here intranasal even, and local in the knee joints and so on. So there is a lot of development here, and perhaps we can have some excellent news also for the vaccination against viruses. So what are the mRNA technologies for? So the first point, it could be to protein replacement. That means you can put in mRNA, which is then producing polypeptides, and you can use you can produce a protein which is not produced usually in the cells because of deficiencies and so on. So this is one possibility. The second possibility is the vaccination. And this is quite exciting for me because here you can put antigen mRNA, and then you can produce peptides, epitopes, which are restricted by MHC class 1 or class 2 antigens, and they are presented by CD4 and CD8 cells. So as you may know, we worked for 20 years to produce these peptides and try to give it to the patient, but these were only restricted to certain HLA antigens. So this is a smart method to introduce this, and that the cells is doing itself the work to present these antigens and then stimulate the T cells. So the other point is the mRNA-mediated CAR T cell production. Dr. Hudicek will speak about this. So where the CAR T cells is introduced, and you will have the CAR T cell produced. And of course, we are using mRNA and CRISPR-mediated gene editing to fix some genes which are deregulated or are for genes which are important or causing diseases. So this is, I don't know if you see that. This is, I think it's very important that now not only for virus infection, but also for vaccinations against tumors. You can see here different diseases like solid tumors, like melanoma, like whatever it's possible. There are studies which are in the where the protocols are recruiting patients, and I guess that this is excellent news for the future, not only for hematology but also for autoimmune encephalomyelitis. So if you are introducing with mRNA technologies some modified myelin oligodendroglycoproteins, you can even have an excellent response in an experimental autoimmune encephalomyelitis. So we are at the beginning of a new era here, and I could even envisage this kind of thing where you have a patient with a tumor, you can collect the tissue, you can isolate from the tumor tissue the differences between normal cells and tumor cells, and then you can use these tumor-specific antigens to deliver within a nanoparticle mRNA, which then could use for treatment of tumors. So this is almost reality today. I'm happy and I'm curious to hear what Dr. Hudicek and Selim will talk about, and I'm really excited about these new possibilities. Thank you very much.
Thank you, Dietger.
Thank you.
Are there any questions?
It looks like from the audience we don't have questions.
Here we are.
We have no
discuss this
questions
later
from the
after the
audience.
talk.
Yeah. So maybe if Professor Gorbachev doesn't have a questions, maybe we can move forward.
I have one question, Rudita, with regard to MRI technology. How do you think can this technology be translated in developing countries and middle-income countries? I think it is a technology that could be applied there because I think they are also in need of these kind of therapeutic options.
Yeah, that's a great question, and I think this will help perhaps even to make the CAR T cells hopefully cheaper, because today, you know, we are speaking about a lot of money for treating patients in Europe and in North America, and the major part of the world has no CAR T cells. So I hope that Michael Hudicek will help us in this, and also we have patients with, as you well know, with sickle cell anemia, where we perhaps can find a way to fix the one mutation which we have and not make stem cell transplants. So I think we have a lot of possibilities here, and I'm really happy to live in a time where we have these possibilities.
And Professor, what do you think about the safety of these technologies? As you mentioned at the beginning of the first tries of doing the gene therapy, there was some leukemias and not expected adverse events. What do you think about this technology?
I think that Selim will talk about this later.
Okay.
No, but we have problems only if we are talking about gene stem cells, hematopoietic stem cells. In T cells, we have a lot of experience in CAR T cells, more than 4,000 or 5,000 people treated, but we don't have these problems. So this is the special problem in infecting hematopoietic stem cells.
Okay, thank you. So we should move forward with Professor Michael Hudicek from Germany, from University Hospital of Würzburg. I'm very happy to introduce you and thank you for joining our conference. Professor Hudicek is a director and research group leader in the Translation and CAR T Research Group, and his fields of interest is in immunology, hematology, and also oncology. So we are very welcome to hear your presentation.
Yeah, thank you for the kind invitation and the introduction. So I first need to learn how to navigate the slides. So thank you, that works. So it's exciting to be part of this symposium, and for disclosure, I should say that my scientific interest in cellular therapy was awakened by Professor Dietger Niederwiese. So when I was a medical student in Leipzig, I was allowed to join his lab and do first experiments with T cells that recognized minor histocompatibility antigens. And let's take a look of how far we've come in gene engineering these immune cells to make sure that they are available much faster and with more potency and in more consistent quality. So I'm very grateful to be part of this symposium. So this is the agenda. I will give a short overview again of where we stand with CAR T cell engineering, the experience with CD19 CAR T in B-cell malignancies, which has taught us some lessons also for treating multiple myeloma, which is the topic that I was asked to speak about. I'll mention the BCMA CAR T experience and then take a look at our own clinical trial pipeline that we have at our center, where we focus on this SLEMF7 antigen. And I will feature briefly a few EU projects that should allow us to keep up with the rapid pace that this translational research field has in a global level. So this audience is familiar with CAR T technology. These are immune cells that are reprogrammed by genetic engineering to recognize surface antigens on tumor cells. The gene transfer techniques are typically stable gene transfer techniques with viral vectors, and I will show that we are indeed now using mRNA and minicircle DNA for transposon technology as a virus-free system for stable gene transfer. A few years ago, these few case reports were published that illustrated the potential that this treatment has, and now, almost 10 years later, there are approved products targeting CD19 in B-cell leukemia and lymphoma, and BCMA in multiple myeloma. In particular, in multiple myeloma, there is an encouraging clinical signal. So the promise holds true, but the mean progression-free survival of 12 months on average, when you look at all myeloma patients, also indicates that there is a need for continuous innovation and improvement. The science behind the synthetic immune receptors is relatively simple, and we've seen the publications that originate from the late 1980s that introduced that concept of fusing an antibody-derived targeting domain to components of the T-cell receptor signaling complex in order to confer reactivity to surface antigens and couple it with the therapeutic potential of a cellular immune response. So the CAR constructs that we see in clinical development are all second-generation constructs that have one co-stimulatory domain, and there's a certain preference for using 4-1BB. The mechanism of action is illustrated here. So the CAR T-cell C antigen, they get activated and release, for example, cytolytic granules that contain perforin and granzyme that damage the tumor cell wall. They also release cytokines that either have a direct anti-tumor effect, like TNF-alpha, or other cytokines that engage endogenous immune cells into this response. And ideally, when antigen is cleared, these T cells then revert to the memory pool and can provide protection from relapse if the antigen expression on the tumor is sustained. This is how it looks in the ideal world, and not always do we get to this memory state. And this is our job now as T-cell engineers to adjust the design of these receptors to wisely select surface antigens that enable such an ideal immune response with synthetic immunity. The CAR T-cell life cycle is illustrated here. So it always starts with a leukapheresis. T-cells are obtained and activated for gene transfer, expanded and formulated for infusion, either as a fresh product or cryopreserved for shipment to the treatment site and then infusion after a lymphodepleting regimen. And we've heard about the possibilities to even use in vivo gene transfer now with, for example, mRNA that is packaged into nanoparticles, and where this gene transfer is happening in vivo. This is with encouraging data in mouse models, but it's not yet there ready for clinical application. CD19 is the exemplary target for this therapeutic modality. We know that CD19 is expressed throughout B-cell development, on mature B cells, to some extent also on plasma cells, and is retained on those hematologic malignancies that arrive at these distinct stages of development. It has a very predictable toxicity profile with elimination of these normal B cells, and this is why it has served as an exemplary target for this treatment. Also due because it's on malignant B cells expressed at a relatively high density with more than 10,000 of molecules per tumor cell, which is right at the sweet spot and threshold where the CAR confers an optimal signal. Here's just a very crude summary of the clinical experience, and there's many published data now. But if you take 10 patients with lymphoma, with chronic leukemia, with acute lymphoblastic leukemia, we see that the manufacturing and provision of the cell product actually works quite robustly. There's a high rate of initial responses, in particular with acute leukemia. There's more primary resistance with chronic lymphocytic leukemia owing to low expression of co-stimulatory and adhesion molecules. And roughly speaking, it's 40 to 50% of patients with lymphoma and with acute leukemia that have a long-term benefit. And there are mechanisms of primary resistance and secondary resistance, and a leading mechanism for relapse and treatment failure is actually antigen loss in acute leukemia. And the mechanism, again, for this is shown here. So acute leukemia cells can learn to do alternative splicing of the CD19 gene such that the epitope recognized by the CD19 CAR, and this is encoded in exon 2, is getting lost, such that a truncated version of CD19 is retained on the leukemic cells, and the CAR is essentially blind for this. So you can approach this by using either an alternative CAR that has a different epitope or an alternative antigen, and this is exemplified by combination treatment with CD19 and CD20 or CD19 plus CD22 in current clinical trials. There's been data with CD19 CAR-T also in multiple myeloma from the UPenn group. Al Ghaffar was the first author on a New England Journal paper that came out a couple years ago, and where they reported a small series of myeloma patients that achieved partial and complete responses with CD19 CAR-T, even though you could hardly detect CD19 by flow cytometry on the myeloma cells. So we've been wondering, can we do better in antigen detection by using high resolution microscopy? So we used a strong microscope that is single cell or single molecule sensitive super resolution microscopy and looked at myeloma cells in more detail. And indeed, you can find CD19 antigen if you look closely. The technique is called DSTORM, direct stochastic optical reconstruction microscopy. So you take an image of a myeloma cell over a certain period of time, and you can get a resolution that you could typically not achieve with photoswitchable antibodies. And this showed us CD19 is present on myeloma cells, even though it is not a uniform target antigen, and it's not there in every patient. So you have to do patient stratification. But if you then incubate these myeloma cells with CD19 CAR-T, you can indeed eliminate this fraction, supporting the notion from the clinical trial that CD19 CAR-T may have some utility and therapeutic effort, however, probably not as a standalone treatment, but as a combination treatment, as was done in the Ghaffar study, using CD19 CAR-T subsequent to high-dose chemotherapy and autologous stem cell transplantation. So we're currently implementing this technique into our patient stratification workflow, not only for multiple myeloma, but also for other indications in order to inform the choice of the CAR target antigen and CAR-T product. So here's an overview of what additional antigens we have at our disposal. And BCMA, B-cell maturation antigen, is the target antigen that is clinically the most advanced. And there are CAR-T products, there are now bispecific antibodies, also antibody drug conjugates. The product that is approved in the United States, it's called Abecma, is the ID-cell. It's a second generation CAR construct, 4-1BB co-stimulation. The BB2121 targeting domain was chosen in a screening process based on its binding affinity and its propensity to actually not cluster too much and induce tonic signaling. And the clinical data are also encouraging. So this these trials had used a flat dosing, so it's not weight adjusted, but it's using fixed doses of 150, 300, and 450 million CAR T cells. In total, this is the dose that was also chosen for the dose expansion cohort, which resulted in very high rates of complete responses. Is this the end of the development of these health products? No, because we can still do better. So we see here that the clinical response is dose dependent. And that amongst those patients that achieve a CR, the median progression-free survival is in the range of 18 months. This is impressive given that these patients are refractory to all conventional treatments with proteasome inhibitors, IMiDs, in conventional chemotherapy, but still it is shy of what we would hope to achieve in terms of long-term disease control and potentially cure in this entity. And the good news is that there's a fully loaded pipeline with improved BCMA CAR-T products that have humanized targeting domains to prevent immune rejection, targeting domains that recognize regions in the BCMA antigen that is not in the soluble BCMA protein that is in patient serum, and so products that are have improved abilities for in vivo engraftment and persistence. So we're curious to see how this field and this work on this target will continue to evolve. One recent vignette that we found, however, in the patients that we've treated with BCMA CAR-T at our center, and this is work by Leo Rasche, one of the myeloma attendings at our clinic, is that there's an interesting mechanism of resistance, and this is homozygous loss of the BCMA gene that can occur. And we've heard reports from other centers as well, and also reports now in patients that have been treated with bispecifics and ADCs. So it's not unique for the CAR-Ts, but we first reported it on this example. So that was a patient that was treated with the BCMA CAR-Ts, the aberrant myeloma protein went down, patient achieved a formal remission, complete remission, but then there was a fulminant relapse and recurrence of myeloma protein, even though the BCMA CAR-T cells persisted in the peripheral blood. And looking at immunohistochemistry, there was already the indication that at the time of relapse, in comparison to the pretreatment analysis, BCMA expression on the myeloma cells had been lost, and this was verified then at the gene level. Actually, in both genes, both alleles had been lost in this myeloma cell clone that, in retrospect, was probably already pre-existent prior to therapy, and then grew out under the therapeutic pressure from this treatment. So this indicates that there is a rationale to look for combination antigen targeting, BCMA plus another target. And the prerequisite for doing this is to validate additional alternative target antigens for these CAR T cells on myeloma cells. Our interest is in SLAMF7, a target antigen that is known in the myeloma community to due to the elotuzumab antibody. And oops, this was too fast. And we're working on this in the context of the Caramba project. This is a project that is supported by the European Union in the Horizon 2020 program. So it's a first-in-man clinical trial using a SLAMF7 specific CAR T-cell product that is manufactured with virus-free gene transfer using mRNA to encode the transposase enzyme. I will show you how this manufacturing process works. But first, let's take a look at what are the current directions in refining CAR T-cell therapy in multiple myeloma. There's a lot of work on optimizing the CAR construct itself, the source of T cells, the clinical setting, and potential combination therapies. But again, a strong effort is directed at identifying suitable antigens that alone or in combination can be targeted. So comparing BCMA and SLAMF7, SLAMF7 is very homogeneous, probably more homogeneous than BCMA on myeloma cells. There is no report on SLAMF7 down modulation or loss in those patients that have received the antibody, elotuzumab. And there is only minimal amounts of soluble BCMA, SLAMF7 protein in patients' urine, whereas BCMA is actually a tumor marker. So this speaks in favor of targeting SLAMF7, and this is why we've embarked on this effort and generated a SLAMF7 CAR T-cell product, looking again at the expression profiles of this at the gene level, very high in multiple myeloma, plasma cell leukemia, probably also some types of B-cell and T-cell lymphoma, most notably NKT cell lymphoma also have SLAMF7. In normal tissues, it's essentially absent. The low signal that you have here is due to infiltrating lymphocytes, for example, in the GI tract and the lymph nodes. And at a protein level, it is highly and uniformly expressed on the cell surface, both in patients with newly diagnosed disease and patients that have received prior treatment. So the SLAMF7 CAR T-cell product that we developed has some innovations that we've been working on over the years. So it has a tailored spacer design in order to accomplish optimal immune synapse formation between CAR T-cells and myeloma cells. There's a defined composition of killer and helper cells in order to obtain a consistent pharmacokinetic such that potential toxicity, but also the time to response is more consistent and can be better predicted. There is a safety marker, EGFRT, that can be targeted with cetuximab Erbitux as a switch-off technology to enhance patient safety. And finally, there's this humanized targeting domain in order to reduce immunogenicity of that cell product. This is the first cell product in Europe that uses virus-free gene transfer. So it was also kind of a icebreaker example to go through the regulatory approval process and making that clinical trial happen in 4 European countries. So as of the date, we have approval in 3 countries, Germany, Spain, and Italy, and are awaiting the approval in France as well. The CAR T product is very effective. So this is an in vitro assay of lysing primary myeloma cells, including those that are refractory to proteasome inhibitors and IMiDs. And this is the data from a mouse model where a myeloma cell line is engrafted in these mice, and then a single dose of the cell product is administered. It's a complete response rate. And if you look in the bone marrow, you find a condition that would be consistent with MRD negativity in humans. And it's, if you compare it side by side, BCMA CAR T and SLAMF7 CAR T in this mouse model, there are typically some residual myeloma cells after BCMA CAR treatment. These are the low expressors. This is not the case with SLAMF7 CAR T, and this makes us hopeful that as we go on with this clinical trial, we'll see not only efficacy, but hopefully also efficacy that is stronger than with BCMA. Here's a snapshot on the clinical trial protocol. So patients must have received at least 2 prior lines of therapy with a proteasome inhibitor, an IMiD, and an anti-CD38 antibody. and patients that have received prior treatment with elotuzumab and patients that have received a prior allogeneic bone marrow transplantation are allowed to participate after a safety interval. Here's an overview on the study flow. Important to note, it's a fresh, non-cryopreserved cell product. The vein-to-vein time is only 16 days from leukapheresis to CAR T-cell infusion. We give the cell product in an inpatient setting and then follow up the patients for safety and efficacy, and also, do an extensive correlative research program, including also an assessment of health or treatment-related quality of life with this novel, innovative, but also quite intense treatment. Intense in terms of, I think, also the emotional aspect and the psychological aspect when you go through this treatment. So we have we're now entering the dose level 2. So we have treated patients at the sentinel dose level that was, because it's first in human, a mandate by our regulator to go in with an ultra low dose of the cell product, 3 × 10⁴ per kilogram. We've completed this dose level 1 with 1 × 10⁵, and the data so far are very good. It's a very favorable safety signal. There's no DLTs. We see CRS up to grade 1. We can also track the CAR T cells in peripheral blood, so they do engraft. And now, I think starting from dose level 2, it's getting even more interesting in terms of anti-myeloma efficacy. One vignette that I can share with you already is this patient here that had more than 12 prior lines of therapy. Within 14 days of administering the CAR T product, the kappa-free light chains as the aberrant myeloma marker were cut in half already. And we do see the CAR T cells in the peripheral blood. Here they are. So they engraft, and coincident with this, we see the development of low-grade CRS with increased levels of IL-6 in serum. We're continuing, the follow-up on this patient, and we'll report more data once they become available. But overall, this is quite encouraging. So the manufacturing, as I said, is done using Sleeping Beauty transposition as a virus-free methodology. Sleeping Beauty is a 2-component system with a cut and paste enzyme called transposase, is shown in orange, and we encode this as mRNA. And then the transposon, this is double-stranded DNA, in our case encoding the SLAMF7 CAR that is mobilized from a donor vector and then stably inserted into the T-cell genome. And instead of using conventional DNA plasmids, where the gene transfer rate is typically quite low, we use mini-circle DNA, those are small DNA circles, and this dramatically increases the stable gene transfer rate. And an interesting vignette of Sleeping Beauty is that it has a random genomic insertion profile. So we have a high frequency of so-called genomic safe harbor insertions where you would not be concerned of malignant transformation. So we've done 4 clinical grade manufacturing campaigns. Of course, we've done many technical practice runs, scale-up runs, and validation runs. But these are now the runs for patients that we've treated, and they've all been in spec and have been successful. Here's a summary of the Caramba consortium. So it's our site in Würzburg, and I'm the coordinator of this project with the sites in Pamplona, Milano, and Lille. GMP manufacturing is done at the German Red Cross Blood Service in Frankfurt. Myeloma Patients Europe is a full consortium member, and we appreciate the input and the assessments that the patients provide to us and help us navigate through this project and clinical trial. Overall, the bench to bedside time for this project has been quite fast. We've reported the clinical data in 2017, have been lucky and successful in getting funding from the European Union to organize and prepare this clinical trial, and have done the first in human treatment in August 2020. So it's 3 years, which, considering the regulatory environment in Europe, is pretty fast for an academic IIT clinical trial development. So in summary, this Caramba trial is a first in human clinical trial with SLAMF7 specific CAR T cells. SLAMF7 is a strong CAR T antigen myeloma with uniform expression. So far, we've seen a favorable safety signal with a clinical vignette that shows that the CAR T cells engraft and confer anti-myeloma efficacy. And importantly, it's the first manufacturing process that has been approved in Europe that uses virus-free gene transfer with an mRNA component to encode the transposase, the cut and paste enzyme that anchors the gene encoding the CAR in the T-cell genome. I'll need 2 more minutes to finish and show you one additional project that we've been working on and that just started in January this year. It's called T2Evolve. This is a project in the IMI, Innovative Medicines Initiative of the European Union. And these are public-private partnerships between academic partners, industry partners that have a common theme and a common vision to move, in this case, cell-based immunotherapy forward. What we realize here is that there's a fully loaded preclinical pipeline of novel CAR and TCR engineered T-cell products in Europe, and there's a bottleneck in clinical translation. And if we widen up this bottleneck and are able to accelerate development, that should help us to get more cell products into the clinic and have more patients benefit. And the keys to accomplishing this, in our view, are standardizing preclinical models. If more investigators use the same standardized models to assess safety and efficacy, it should be easier to get this through regulatory review and approval. Also, we are working on establishing and refining standards in manufacturing, product release, and monitoring, such to compare inter-trial and intra-trial comparability, being able to learn faster if we do the same follow-up, for example, in pharmacokinetic in different CAR-T trials. Optimizing lymph depletion, for example, in order to support the engraftment is a more specific aim that is catered around the clinical use of cell products. So there are partners from academia, biotech, major pharma, there are regulators, patient advocates, healthcare providers and practitioners that are part of this consortium, and I'll show you the partners here. I'm the coordinator of this consortium together with Hélène Negret from CRVA, and these are the partners that are involved. It's a 5-year project, and these IMI projects are very inclusive, so it's about building a strong stakeholder community and engaging as many people in Europe as possible in this thinking process of how we can accelerate the development of cell products. One particular example I want to feature here is in the work package 2. This is about patient and healthcare provider involvement in education, and healthcare providers, this is both family, but also healthcare professionals, study nurses and physicians. And one first exercise is to review and collect the information and education material that is available to patients in Europe from all European countries, identify gaps, and we identify the need to explain better to patients the requirements for long-term follow-up first. But second, also in a patient-friendly manner, information on how effective can the CAR T-cell treatment be for you and how will your life be after the CAR T-cell treatment. These are 2 concrete examples that we're currently working on. I invite also the colleagues here from Lithuania to weigh in and engage with us. And here are the ways of how you can connect with us through the website, through the social media. Again, it's a very inclusive consortium and community, and we appreciate every input that we get from the different EU member states. So this was the rapid overview I wanted to give you. We've reviewed basic principles in CAR design, the current clinical trials data with CD19 CAR-T in leukemia lymphoma. CAR T-cell therapy has arrived in multiple myeloma with BCMA is the exemplary target antigen. There are more target antigens and technologies on the horizon that will make this treatment even more effective. And there is a lot of efforts at the national and importantly at the international and European level to help bring this treatment to more patients. With this, I want to thank first, of course, the patients, the families that take part in our clinical trials, all members of the Caramba Consortium, the T2Evolve Consortium, the funding agencies that are supporting us, and of course, again, the invitation of the organizers to this meeting, and Dietger Niederwiese for his mentorship and continuous support throughout these years. I look forward to your questions. Thank you.
Thank you so much for your exciting presentation and exciting news and perspective for the patients and for the professionals for treatment, new options. We don't have questions from the audience, but I would like to ask you, what do you think about the possibility of local production with the Sleeping Beauty technology for CAR T cells compared with the viral technology? Which technology is more easily available for the centers and smaller centers?
No, it's an excellent question. This has been one of the motivations for us to invest into thinking into this technology. We realized that many universities have GMP facilities, but then when you work with transposons, this is about a safety level 1 procedure because these transposons do not propagate by themselves, whereas using virus, this is a biosafety level 2 procedure, which has higher requirements in terms of infrastructure and also of whether you can run different processes in the same facility or neighboring clean rooms. So this transposon technology is uniquely suited to be rolled out for on-site manufacturing and especially academic GMP facilities.
Okay. Thank you. So we are moving on time. Professor, do you have any questions? So thank you.
My pleasure.
Professor. And I would like to present my co-chair to ask for his presentation. And very shortly, I would like to introduce you. Professor Selim Gorbachoglu is a professor in Children's Hospital in Regensburg, head of the Department of the Hematology, Oncology, and Transphysiology, and transplant, I'm sorry. And he has many publications and interest in the hemoglobinopathies, transplant-related endothelial injuries, and other issues. And his publications are in the most citated journals. So we are very happy to hear you. Last year, it was very nice to hear you, and very happy to have you here once again this year. And I hope it's going to be a tradition for your research spread in Lithuania. Thank you.
Thank you so much for this kind introduction. So I'm happy to present you the first safety and efficacy data of gene editing in hemoglobinopathies. And the background is actually very simple. The hemoglobinopathies are a worldwide burden of humongous size for many, in particular, low and middle income countries and developing countries, but also for Europe and in particular for the United States. TDT is caused by more than 300 loss of function mutations that reduce the level of beta globin production and lower the total hemoglobin to the level of absolute transfusion dependency in these patients with severe transfusion dependent thalassemia. There are at least 60,000 annual births that are a socioeconomical burden above all, in particular for the patients. And the morbidity, of course, is dependent on the severe primary and secondary iron overload that eventually leads to liver failure, endocrine failure, and heart failure. And all conventional care so far is not really capable of coping with this progressive chronic iron overload, so that the overall mortality of these patients is still high and their life expectancy is short, even in industrialized countries. Sickle cell disease, another hemoglobinopathy, but by far worse than transfusion-dependent thalassemia, is the complication of a single point mutation that causes hemoglobin to polymerize, leading to sickling of red blood cells. The rate of annual births is exceeding 300,000 because many of these patients are born in little villages outside large cities, in particular in sub-Saharan Africa. So many of the devastating diseases that occur there are not recorded and statistically not seen. The disease is a two-phase disease where we have the classical textbook presentation at younger age with pain crises, sequestration crises, in particular sepsis, acute chest syndrome, and strokes in infants. In developed countries where we were capable with simple methods like education, vaccination, appropriate pain care and antibiotic care to overcome infant mortality, we see that these patients succumb to sickle-related complications significantly earlier than their peers, by approximately 20 years. And the reason for is not the classical presentation here, but rather a systemic capillary vasculopathy that is leading to heart failure, kidney failure, and cardiopulmonary failure. So it is, for both diseases, a huge unmet need to care for these patients. And we have seen just recently in the New York Times an article about care for patients who are not mainstream, like cystic fibrosis, where there is a plethora of drugs available. And that is not the case for sickle cell disease, where until very recently there was just one drug that was hydroxyurea. Now there are 4 drugs, but nevertheless we still do not know what the efficacy of these drugs with regard to this long-term chronic vascular damage will be. Now, these are data that we presented at the EBMT and earlier on at the Presidential Symposium on ASH, and they are the early safety and efficacy results with a single dose of autologous CRISPR-Cas modified hematopoietic stem and progenitor cells in transfusion-dependent thalassemia and sickle cell disease. Now, the background for this treatment option is that elevated fetal hemoglobin is associated with decreased disease severity. We know that from the combination of patients who suffer from TDT and sickle cell disease, plus a condition that is known hereditary persistence of fetal hemoglobin. And this hereditary persistence of fetal hemoglobin leads to high and very high levels of fetal hemoglobin that are associated with either transfusion independency for thalassemia or a complete abolishment of sickle-related vaso-occlusive crises in case of sickle cell disease. Now, naturally occurring genetic polymorphisms in BCL11A are associated with elevated hemoglobin F and increased severity for TDT and sickle cell disease. So BCL11A is a suppressor for the expression of hemoglobin F post-natally. And editing of BCL11A results in reactivation of gamma globin expression formation of hemoglobin F in mouse models. So CTX001 is produced using ex vivo editing of the erythroid enhancer region of BCL11A in CD34 positive hematopoietic stem cells. It reduces erythroid specific expression of BCL11A. An infusion of CTX001 leads to an increase in hemoglobin F levels in erythroid cells in vivo. That is the background now. Now, there are two trials ongoing and enrolling patients internationally. They are both phase 1/2 trials, multi-center, open-label, single-arm studies that enroll TDT patients aged between 12 and 35 years and respectively sickle cell patients with severe disease at the same age range. The primary endpoint for the THAL trial is proportion of patients achieving sustained transfusion reduction of 50% for at least 6 months, starting 3 months after CTX001 infusion. And for the sickle cell trial, is proportion of patients with hemoglobin F levels above 20% sustained for at least 3 months, starting 6 months after the infusion of CTX001. Now, the trial design is very simple. Patients who are eligible receive an apheresis. Stem cells are collected and are sent to a central manufacturing location where CRISPR-Cas9 editing takes place. After quality control, cells are frozen and returned to the participating centers. There, the patient receives a myeloablative conditioning that currently consists of busulfan, and CTX001 is infused. Patients are followed inpatient until engraftment and hematopoietic recovery and are discharged thereafter for outpatient follow-up for at least 2 years. They are monitored for engraftment, hematopoietic recovery, adverse events, hemoglobin production, hemolysis, hemoglobin F and F cell expression, red blood cell transfusion requirement, and of course, vaso-occlusive crises in the case of sickle cell disease. These are the patient characteristics for the 7 patients with the TDT with a follow-up of a minimum of 3 months. There were 7 patients, 5 females and 2 males treated with an median age of 23 years at consent. And the treatment characteristics are as follows. The patients received 11.6 times 10 to the 6 CD34 positive cells per kg. Neutrophil engraftment and platelet engraftment took place on day 32 and day 37. This is a little prolonged for an autologous transplant. And most importantly, the related adverse events that occurred during transplant were all related to autologous transplant as expected for a myeloablative conditioning with busulfan, and there were no CTX001 related SAEs that were reported in all other patients. Clinical outcome, there was a clinically meaningful hemoglobin F and total hemoglobin rise that was achieved early and maintained. So of these 7 patients, they started out with a median hemoglobin of 10.1 gram per deciliter, and after 18 months, at least one of the patients reached a normal hemoglobin F level of 14.1 that basically consisted unanimously of hemoglobin F, and the remaining patients are currently rising their hemoglobin, patient number 2 at 12.2 gram per deciliter, and so on. Very important, more for sickle cell patients, than for the thal patients is a pancellular expression of hemoglobin F that is maintained. So in the circulating red blood cells, in the thal patient population, the expression of hemoglobin F is 100%. So every single red cell that is circulating mature is expressing hemoglobin F. The duration of transfusion independency after CTX001 infusion is presented here. So all patients almost immediately after engraftment or transfusion independent and are persistently transfusion independent. Now, the 3 sickle cell patients that have been followed for at least 3 months are depicted here. Again, age at consent was 22 years. So all are advanced stage sickle cell patients. Treatment characteristics were as follows. They received, as expected, a lower autologous cell dose of 3.8 times 10⁶ CD34 positive cells per kg. Neutrophil and platelet engraftment occurred at day 22 and 33 respectively. And again here, very importantly, there were no SAEs that were related to CTX001. Clinically meaningful hemoglobin F and total hemoglobin levels were achieved early and are maintained in all 3 patients at 12, 11.5, and 13.2 gram per deciliter. And here, as you see, there's a difference to the thal patients, as you would expect. Thal patients cannot produce beta chains at all, whereas here we have a mixture of hemoglobin F and hemoglobin S, an approximate ratio of 1:1 in almost all patients. And that is an important information because theoretically, these patients do not express a heterozygous ratio, where you would expect a hemoglobin S level of approximately 35% and the rest being hemoglobin A. So theoretically, these patients have a higher risk for vaso-occlusive crises. But much more important is the presence of F cells. And F cells are mature red cells that carry a certain percentage of hemoglobin F. And that is the case for all patients. All 3 patients that were treated so far have a certain level of hemoglobin F present in their red cells, which means that these F cells interfere with hemoglobin polymerization and at least theoretically should protect these patients from sickle-related vaso-occlusive crises. And this is the case, as you see in the 3 patients with a follow-up of 18 months. The duration of vaso-occlusive free time post-treatment is persistent up to now in all 3 patients. So the theoretical ratio of hemoglobin F and hemoglobin A is reflected in the clinical benefit for these patients. On top, all patients have detectable hemoglobin and improved LDH, so indicating that there's no evidence of hemolysis. Important is also the fact that BCL11 editing is observed in bone marrow CD34 positive cells with a follow-up of at least 6 months in all patients, and in particular in the patients with the longest follow-up of 12 months, 76.1 and 80.4% of the cells carry the allelic editing. And this can be predictive of a prolonged and sustained duration of efficacy of this treatment option. So in conclusion, the first 10 patients treated with CTX001 have been followed for 3.8 and up to 21.5 months and have stopped transfusions, and in the case of sickle cell disease are vaso-occlusive free. Overall safety profile is generally consistent with the myeloablative conditioning, in particular with busulfan and autologous bone marrow transplant. Clinically meaningful hemoglobin F and total hemoglobin levels were observed early and maintained across all 10 patients. So we have a clinical proof of concept for CTX001 that has been demonstrated for both diseases. And these data demonstrate that CTX001 is a potential functional cure, obviously a surrogate cure, but a functional cure for the treatment of TDT and sickle cell disease. Now, this was published recently in the New England Journal of Medicine, and we are waiting for completion of the trial to give you an update on the remaining patients. The question now that is emerging is gene editing or gene therapy the new standard of care? And I think this is a question that, of course, needs to be answered in the next couple of years, because besides proof of concept, safety and sustained efficacy are the 2 questions that will remain to be answered. We have one issue here. As we know, we have the so-called gene addition trials or gene therapy trials, as we also call them, where Bluebird unfortunately had to suspend its trials for sickle cell gene therapy following a cancer diagnosis in 2 more patients. So out of approximately 40 patients now, 6 patients developed cancer or myelodysplastic syndrome, and that is unfortunately a little disturbing, so that we have to see what lentiviral-based gene therapy is really going to do in the future, and if this is a potential standard of care. I want to draw your attention in that regard to the presidential session at the last EBMT meeting, where Dr. Jörn Sven-Kuhl presented data on a lentiviral-based construct for treatment of cerebral adrenoleukodystrophy. And they treated 42 patients with clonal insertions of this lentiviral vector between 500 and 15,000. And also here it is a little disturbing that out of these 42 patients, there were 2 patients with clonality and 1 presenting with the borderline neutropenia and the other one presenting with pancytopenia. So you really have to be careful, and we have to weigh well our treatment options. I mean, adrenoleukodystrophy is a devastating disease for which we really have no cure, not even stem cell transplantation. Hemoglobinopathies, thalassemia, and sickle cell disease, when treated early, are both easily and excellently accessible for stem cell transplantation when properly done, and currently in prospective trials. And I think this is an important message, so that we have to weigh risk and benefit for stem cell transplantation and gene editing. And I think they have to exist in parallel, because we have many, many worlds these patients live in. The industrialized countries that can afford gene editing and gene therapy for a price tag of more than 2 million per patient. And there are countries who cannot do that. But these countries cannot even provide hydroxyurea and any other conventional care for these patients for a prolonged period of time, where stem cell transplantation, provided safely, is a very, very valid alternative. So in conclusion, matched sibling donor transplantation is standard of care. The age is of course important, because in particular in sickle cell disease, when these patients get older, even a matched sibling donor is associated with significant chronic GVHD. That is different from thalassemia and the consequence of the systemic vasculopathy that is triggering GVHD in the allogeneic setting. A haploidentical transplantation, I have not shown you the data here, is curative for almost everybody, because we have a statistical donor ratio of 2.7 donors per patient, and outcome is increasingly comparable to matched sibling donor stem cell transplantation, and probably better than a mud donor transplantation, also with regard to availability and costs in low-income countries. And haploidentical transplantation, in particular when you use post-transplant cyclophosphamide, is cost-efficient and affordable, as has been demonstrated in low and middle income countries. We have to challenge the classical donor hierarchy, matched sibling, mud versus haplo, in particular when we think of sickle cell disease, where a haplotransplant, a T-depleted haploidentical transplantation, might be superior to a mud transplant with regard to early and late post-transplant complications such as GVHD. Gene therapy, of course, it is fantastic and it will be the future. We still have to see which one is going to be the leader in the field, and I think we're all expecting, in particular for sickle cell disease, the gold standard, that is homologous recombination, which is called gene correction for the single point mutation that is causing that disease. For thalassemia, the situation is different. We have over 300 mutations, and we only need transfusion independency. So this surrogate treatment of hemoglobin F expression is probably the better choice, and we have a treatment option available for many of those patients that are not accessible for stem cell transplantation, or are advanced risk for complications related to an allogeneic transplant. It is, of course, still experimental. We have to wait and see what the off-target effects will be. The loss of fertility is the same as we have for stem cell transplantation. And I think for both treatment options, we are waiting for solutions for a chemotherapy-free myeloablative conditioning with CARs or antibodies against stem cell factor receptor, and other modalities that are developed by companies like Magenta and Jasper are coming on their way early. And I think this will be a major step forward for the cure of those patients. And of course, we have to keep in mind the costs, in particular for patients from low and middle income countries. So when is the optimal age for a curative approach? I think I would not transplant anybody before 3 years of age for several reasons. Number one, adenoviral infections are a problem in this age range that are coming down when the patients get older. We have a challenging pharmacokinetic in that age. We have high risk of veno-occlusive disease, in particular for patients with thalassemia. And there is no morbidity and mortality for none of the two diseases at that age. So you can wait. If you have a metastatic donor, you should go for a transplant as early as possible, but you have to collaborate with the patients and the parents, because at age 3 to 4 to 5, with a proper preventive care with hydroxyurea and other means, these patients have no sufferance of their disease. So taking them for elective transplant is a very, very difficult decision to take. So nevertheless, it is a safe option, but still it is associated with complications that we have to discuss with the parents. But if, in particular, in the case of sickle cell disease, these patients at early age present with sickle-related complications, you can go for a blood transplant as well as for a haploidentical transplant. I would call the age range between 10 and 18 as a golden age for these patients. They still have a little iron overload. They still have few irreversible sickle-related complications. The risk of VOD is low. The patient can give consent instead of assent from the parents, and fertility preservation, particularly in post-pubertal patients, is very efficient. When we come to the age range above 15 to 18 years, the situation changes. These patients suffer tremendously from their sickle-related irreversible complications, like the osteonecrosis, the chronic pain, the neuropathy, and so on. And of course, on top of that, the transplant-related complications arising, such as neurotoxicity and PRES, VOD, acute and chronic GVHD, alloimmunization, and the delayed immune reconstitution, as well as rejection, particularly for the FAL patients. Now, this is the patient population where I, in particular, see a substantial benefit for gene editing and gene therapy, where an autologous transplant can avoid many of those complications presented here. Thank you very much for your attention.
Thank you, Professor, for the exciting presentation and very encouraging future for the patients with such a difficult diseases that are making a lot of problems for these patients. Then you take into account all the technologies for the gene editing. At this moment, as I understood, you are using viral technology, yes?
No. There is the viral technology is used by what we call gene therapy or gene addition, where we introduce an entire beta globin chain, right? That is modified, so it's not polymerizing using a lentiviral backbone. The CRISPR-Cas technology is using electroporation, right? That's probably the reason why the engraftment is so delayed. So there's no viral vector involved in at least in the Vertex and CRISPR approach.
Okay. So at this moment, we don't have any more questions from the audience. Thank you for being on time. And we would be happy.
Can I ask one question? So,
of course. Sorry.
First of all, congratulations. I mean, it's a very nice example, and essentially we're neighbors in Würzburg and Regensburg. But with the CRISPR discussion, any assessment of the off-target reactivities that these CRISPR guides have? I mean, no matter how well they are designed, they always have some 0.1% off-target reactivity that nobody's really certain of how to assess. Can that translate into an adverse event or not? What's your view, and what kind of risk assessment do you do, and how do you also counsel patients when they ask about that?
No, I think the problem is that everybody thinks gene therapy is a piece of cake, easy to use, and transplantation is the bad evil. I think that's not the case. I mean, when I look at my patient population, we have now done over 50 patients with thalassemia and advanced stage sickle cell disease here in Regensburg, and we're transplanting adults up to the age of 45. Our overall survival is beyond 95%, and none of our patients suffers from severe chronic GVHD. I think that is something that you have to beat, because you have a really an excellent track record of over 50 years of stem cell transplantation. So if these patients are off immunosuppression, no GVHD, full donor chimerism, they're cured. For gene editing or gene therapy, or whatever you want to call it, none of this is known so far. I think it's an excellent technology, very interesting, but we are at the step of proof of concept and not more. And for either one of the treatment options, we really have to follow those patients for longer. And as you have seen for Bluebird, we have not seen malignancy in the thalpi patient population, but in the sickle population. Why this is the case, we don't know. But seeing cancer that early on is very disturbing. And I think it was the best solution to lock down the program and watch what's going on. Nevertheless, I think that the specificity of the CRISPR-Cas approach, probably even more so with a TALEN-based approach, is higher than a lentiviral approach. And of course, you want polyclonality, but in the end, again, statistically, even polyclonality at some point will be related to a hit somewhere in the genome that is cancer sensitive, right? So we really have to see what price we want to take, because we have to talk to the patients. When you transplant them, you cannot tell them he's not going to die, because you have all these complications related to the allotransplant, and you have to tell the same story to patients who go for a gene editing approach, right? So we have the options, and I think time will tell us which patient in which situation is the best choice for which treatment option. But I think have options, that is important. We didn't have them 10 years ago. Nobody transplanted a sickle cell patient 10 years ago. Now we have the options, and we can offer a cure to these patients, and I think that's amazing.
Super, thank you.
Thank you. We have one question from Professor Niederwieser. He's wondering about if mRNA is inserted into genome. Is it possible to that insertion of mRNA into genome?
Well, I think with the CRISPR-Cas method, you introduce a nonsense mutation in the promoter region of BCL11A, so that you interrupt basically the transcription of BCL11A. That's what is done with the Cas9 enzyme. So you're introducing a new genetic fragment there that is basically stopping the production of that protein and then releases hemoglobin F. Yes.
Okay. So thank you so much. Thank you. And now we will have a 50 minutes break and waiting for the third session. Thank you so much.
So we have the audience already. So good afternoon. On behalf of my co-chair, Professor Sandra Lienice, and myself, I would like to welcome you to this session on lymphoproliferative diseases. It's my special pleasure to welcome you. It is, as you know, the 6th Kaunas Lithuania International Seminar on Hematology Oncology. And I've seen the program is fantastic. We had already had the opportunity to listen to excellent presentations, and I'm sure we have a very excellent presentation in front of us. And it is Professor Paolo Chia, full professor of medical oncology from the Università Vita Salute San Raffaele in Milano. and he just co-authored with many other colleagues the ESMO guidelines on diagnosis and treatment of patients with CLL. And his topic is CLL chemotherapy-free and what then? So, Professor Chia, we are very pleased that you agreed to present it within this symposium, and we are looking forward to your presentation. Thank you very much.
Thank you for the nice introduction and also for the invitation here in Lithuania, although of course all remotely. One day we hope we can start again traveling. So here my disclosure, and I like to show also just to witness how much research has been done and how much achievement has been achieved indeed in CLL treatment, with a lot of companies, a lot of small biotechs also that really work with innovative molecules that really allowed us to transition from an immunochemotherapy based treatment in CLL to novel treatments. And it is, as mentioned by Professor Ludwig, that is absolutely visible in the new and the updated ESMO guidelines that we published at the beginning of the year together with many other distinguished colleagues. And indeed, the two major key points to take home is one, that we need to stratify our patients based on genetic features, immunoglobulin genes, MP53, and we will see in a moment. But the other major point is that in the blue boxes, you do see all the different treatments that are now available in CLL, and the chemoimmunotherapy is really disappearing from definitely being a priority, but also in some boxes you don't see it anymore. And if we stick to first of all the stratification based on genetic features, the P53 patient with P53 aberration is definitely the subgroups of patients where chemotherapy is gone since many years, for the simple reason that we understood that patient may carry aberrations in the P53 gene, either deletion that can be detected by FISH, or mutations in the gene that can be detected only by Sanger sequencing or just next generation sequencing. And these are two distinct tests that should be performed in all our patients before starting any line of treatment in order to identify who has a malfunction or the absence, the lack of function of the P53 gene. And these patients are those who do not respond to immunochemotherapy for the simple reason that the P53 is not there or is mutated, so it cannot be activated. So the apoptotic pathway activated by the exposure to chemotherapy is not present. And these patients, at the time of in the era of immunochemotherapy, were patients who had a very short or overall survival with a couple of years, 2 or 3 years, for the simple reason that we were not able to treat their disease with immunochemotherapy. That fortunately completely changed it with the introduction of novel drugs, and in particular the continuous treatment with BTK inhibitors. Here I show you the data with ibrutinib that has been the first one, of course, to be used, utilized, and approved. And here I present the data, the 4-year follow-up of a pooled analysis of 4 different studies that have been presented at ASH 2020, where only the patient with deletion 17p and or P53 mutation have been analyzed. And as you can see here, when they are treated in first line with ibrutinib, they have a progression-free survival at 4 years that is 79%. So 4 out of 5 patients are still responding after 4 years. With the immunochemotherapy, I just remind you, they were dead after 2 or 3 years. So the perspective of these subgroups of patients completely changed, and the novel therapies is really chemo-free therapy really revolutionized their outcome. The same thing we can see it in a 6-year follow-up of a phase 2 study run at NIH by Adrian Wisner, recently published on New England Journal of Medicine. The update is 6 years, where you do see that at 4 years, still 79% of patients are progression-free, and this is so the results are very reproducible across different studies. And at 6 years, we have 61% of patients still responding, so almost 2 out of 3 patients that are still responding to ibrutinib continuous treatment. The same thing happens with other BTK inhibitors. In particular, what we believe is the continuous treatment with BTK inhibitors that is probably very beneficial in this subgroup of patients. Here, I show you the data from the elevated treatment naive study where acalabrutinib, the second-generation BTK inhibitor, with or without obinutuzumab anti-CD20 antibody, was compared to chlorambucil plus obinutuzumab in the elderly comorbid patient. And here I show you data in patients with deletion 17p, patients with or without deletion 17p. If treated with chlorambucil plus obinutuzumab, they definitely have a shorter progression-free survival compared to any other patient who has been treated with acala plus or minus obinutuzumab, and there is no difference between patients with or without p53 aberrations. Here we have only the follow-up at 2 years, but we will be presenting at ASCO the follow-up at 4 years. Another molecule that we have, a chemo-free molecule, is the BCL2 inhibitor venetoclax, and this has been tested together with obinutuzumab in the CLL14 study in a fixed duration regimen. So for 12 months, elderly patients were either treated with venetoclax plus obinutuzumab or chlorambucil plus obinutuzumab. And as expected, the combination, the chemo-free combination, is much better than chlorambucil plus obinutuzumab in the overall population. If we look at p53 aberrant patients here, we do see that patients with p53 aberrations have a better progression-free survival when compared to those treated with chlorambucil plus obinutuzumab, if they are treated with venetoclax plus obinutuzumab. Now, if we compare these patients with p53 aberration treated with venetoclax plus obinutuzumab with those who do not carry p53 aberration and are treated with venetoclax plus obinutuzumab, there is a significant difference. So suggesting not the BCL2 inhibitor is not efficient enough, but it's the fixed duration that very likely is not the appropriate treatment for this subgroup of patients who really benefit, as we saw before, from the continuous treatment with BTK inhibitors. When we think about p53, we are very keen as ERIC, European Research Initiative on CLL, and indeed we created a dedicated network where patients, to promote the idea that all patients should be tested for the p53 aberration, FISH and sequencing, 2 different tests, before starting any line of treatment. And we also created a certification process to help laboratories all around the world, not only in Europe, as you can see here, but all around the world, to start the analysis, to set up the analysis, but also to certify the quality of the ongoing work. So if your laboratory in your hospital is not performing the analysis, please tell them to contact us, and we will help them to set up the analysis for free. It's an academic effort, and if they are already performing it, I would suggest them to undergo the certification process again for free in order to be reassured on the quality of the testing. So the other point, luckily, I would say the p53 aberration is present in only 10 to 15% of patients at the time of first-line treatment, but we can check in all other patients the immunoglobulin gene status, and this is really relevant to deal with the patient not at diagnosis anymore. So though it has a prognostic value, so patients who have mutated immunoglobulin genes tend to have a much longer survival, a much longer time to first treatment. So they typically experience a more indolent disease. Still, this is not cannot be applied at the level of single patient, single individual, because indeed, even among the mutated patients, some of them, up to 1 out of 4, will indeed need the treatment during their lifetime. And among those with unmutated immunoglobulin genes, again, another 1/4 of patients will not need any treatment during their lifetime. So when we try to predict the outcome of a single patient in our office, we will make a mistake in 1 case out of 4 if we use the mutational status at the time of diagnosis. So now we are really, even also in the guidelines, we are really suggesting not to perform this test at the time of diagnosis. But indeed, it needs to be performed before starting treatment, because now we learn that the mutational status can somehow predict the response again to immunochemotherapy. And this is the study from Michael Keating some time ago, where he showed, together with the colleagues at MD Anderson, that patients with mutated immunoglobulin genes can reach a plateau in terms of progression-free survival when treated with FCR. And this happens in around 60% of the individuals. While instead the patient with unmutated immunoglobulin genes, they tend to continuously progress without really reaching a plateau. If we consider a patient with the mutation in the immunoglobulin genes, but also lacking P17P deletion, then as shown by Davide Rossi and Gianluca Gaidano, 75% of the patient will indeed achieve durable responses with FCR. So we are talking about young patients with mutated immunoglobulin genes and no deletion 17P. The issue is that 25% of the patient will indeed relapse, and quite soon. So we cannot promise to a patient with mutated immunoglobulin genes that immunochemotherapy will be the best treatment in every case. There is a high probability that the patient will respond with a durable response for up to 10 years, but it is not assured. And in particular, this issue is so relevant to identify the patient with mutated immunoglobulin genes, because all the others, the unmutated immunoglobulin, should not be treated with immunochemotherapy. For those with mutated immunoglobulin genes, we might discuss if indeed they are the only subgroups where maybe they can have a benefit from fixed duration immunochemotherapy. So the ERIC again created an immunoglobulin network with the same objectives, so promote the idea of testing immunoglobulin genes before starting first-line treatment. Immunoglobulin genes remain stable, so we don't need to repeat it all the time. And also we created a certification process also for the immunoglobulin genes, also all around the globe. So again, if your laboratory is not performing it or is already performing, tell them to become an ERIC member and ask to be certified. I just want to remind you that though the mutated patients are the only one that nowadays in 2021 one should discuss still the option of immunochemotherapy, I would just want to remind you that this is a very minor portion of patients who need treatment. So mutated patients are the vast majority when you consider patient and diagnosis. But when you look at patients at first-line treatment, then only 1/3 have mutated immunoglobulin genes. And only a third of this third will be young enough to be tolerant to tolerate FCR. And so these are only 10 to 12% of patients are those to whom we can discuss the possibility of using FCR and immunochemotherapy. And indeed, here I show you instead for the unmutated patient, where indeed in this patient the advantage of using chemo-free treatment, both fit and unfit patient, is absolutely overwhelming. So this is the ECOGNITE Team 12 study, young patient treated with ibrutinib plus rituximab or fludarabine FCR. And as you can see here, for the mutated patient, there is no significantly different the benefit that they receive with the ibrutinib-based treatment. Same thing happens when in the elderly fit patient treated with bendamustine plus rituximab or ibrutinib plus minus rituximab in the Alliance study. Again, a significant difference. And of course, even more significant difference that we can see when patients are treated with ibrutinib or chlorambucil in the elderly population. And you see here that there is no difference between mutated and unmutated patients when treated with ibrutinib. And we are going to present the new follow-up at up to 7 years at EHA of this study. In the elderly, of course, and also in the young, the issue of mutated immunoglobulin is that what we are discussing here. So is this the population where we still can use immunochemotherapy? As I said, if we look at the young fit patient who could be treated with fludarabine, cyclophosphamide, and rituximab, the two options, ibrutinib plus rituximab in red or FCR in the black dotted line, are identical. So it's not FCR is not the best option for this mutated patient. It's a simple fact that this mutated patient have the possibility to decide between two very effective treatments: immunochemotherapy on one side or novel therapies on the other side, with all the pros and cons. So we know with FCR we can have MDS, acute leukemia in the long run. We have risk of infections, sepsis, and that risk lasts for up to 2 years after the end of the therapy. So these are all things that should be really openly evaluated together with the patient. When we look at the elderly patient, both fit and unfit patients, so those treated with bendamustine plus rituximab or chlorambucil-based treatment, this difference is becoming significant. So the patients who are treated with bendamustine plus rituximab will never reach a plateau and durable responses. So here there is no question. The best treatment is always a treatment with a chemo-free treatment. And this is even more evident when we look at chlorambucil versus ibrutinib in the elderly patient. Of course, you say, but nowadays we would use chlorambucil plus obinutuzumab, which is much more effective than chlorambucil alone, and this is absolutely true. So now we have a number of studies comparing chlorambucil plus obinutuzumab with ibrutinib plus obinutuzumab, with acalabrutinib plus or minus obinutuzumab, with venetoclax plus obinutuzumab. And all these molecules give a much longer progression-free survival to the elderly patient compared to chlorambucil plus obinutuzumab in both the unmutated patient, but also the mutated patient, where the difference is maybe smaller, but it's still significant. The interesting point I want to make here is that if we look at the treatment with venetoclax plus obinutuzumab, I remind you, 12-month fixed duration, the mutated patients seem to reach a plateau. So here we need a longer follow-up, and maybe here we could really see that with the 12 months, we can reach durable responses in mutated patients. When we look at unmutated patients, they tend to progress earlier. So again, we are talking about a cell population that is much more active, that is much more proliferating, and this is probably, again, the reason why a fixed duration is probably not the best that we can give to this patient. Of course, we need a longer follow-up to see if this patient can be retreated with the same treatment, so somehow prolonging the overall PFS, and this has yet to be seen. In the relapsed refractory setting, I don't even mention the space for immunochemotherapy is virtually disappearing. Patients, if they have p53 aberration, will not be treated, of course, with chemotherapy in the second or third or more lines of therapy. If they had a short duration of with immunochemotherapy in the first line, less than 3 years, these patients should not be treated anymore with immunochemotherapy because they should be considered refractory to immunochemotherapy, and they should be treated only with novel therapies, chemo-free therapies. Those who had a long remission, if they have long remission, there is really a possibility that they will never need the second treatment. And in particular, those who had long remission, when they relapse, they will be, by definition, older than when they started. So these patients are those where you don't want to risk another round of immunochemotherapy. And so again, it's very difficult to find a spot in the group of patients where you would feel confident to use, for example, bendamustine plus rituximab, which gives 18 months of progression-free survival in the relapsed refractory setting, which is definitely nothing compared to what we can obtain with all the new chemo-free treatment. So the space for immunochemotherapy in the relapsed refractory setting is really disappearing. I just want to remind you that here in the guidelines, we also wrote that a repetition of FCR is not recommended. So 6 cycles, if the patient tolerated once, that's enough for the rest of the life. So I just want to go and conclude, because of course chemotherapy, chemo-free treatment is now the pillar of the treatment in CLL. But of course, we are far from being at the end of the research, far from being perfect. We have a number of issues. Of course, the first one is the presence of adverse events, which are nothing comparable to immunochemotherapy. They are much more easily manageable. But it's true that if you if you have a patient in continuous treatment, the risk of getting any adverse events in the longer run is still there. And in particular, we are also afraid in the case of, for example, ibrutinib, BTK inhibitors, of a number of adverse events which are rare, like major hemorrhage, also atrial fibrillation, maybe between 5 and 10% of patients, or the increase of blood pressure, that are all manageable, but still, of course, they could create some anxiety in the patients and in the doctors. So that's why a lot of patients, at least in the US, appears to discontinue the drug. And it is interesting to note that in a real-world study presented by Anthony Mato, up to 42% of patients discontinue ibrutinib because of adverse events, and the median time to discontinuation was 7 months, which is definitely very short. So that's why a number of second-generation inhibitors have been developed with a more selective profile of inhibition of the kinases, and in particular acalabrutinib, that is probably the most specific, and then zanubrutinib, who is also much better than, apparently, from a kinome selectivity profile, better than ibrutinib. And we have now studies comparing the molecules head-to-head, ibrutinib versus acalabrutinib. The data will be presented at ASCO. We saw a press release in January saying that the efficacy was comparable, but there was a lower incidence of atrial fibrillation. So going towards the direction of less adverse events. Similar story for zanubrutinib. We recently saw the press release really a couple of weeks ago. Alpine study, ibrutinib versus zanubrutinib. There is a superior objective response rate that in CLL, we don't know really what it means. We don't have yet mature data in terms of PFS in that study, but again, a reduced rate of atrial fibrillation. So again, suggesting that we are moving towards a better tolerated drugs. Second issue with these drugs are the possibility of acquiring mutation. Here I mention again the possibility of BTK mutation in case of continuous treatment with ibrutinib. We can also acquire BCL2 mutation for what it counts. And so for this, a number of new inhibitors, so-called third-generation BTK inhibitors, have been developed, and these have in common the feature of binding in a reversible fashion to BTK, in contrast to stable inhibition binding, stable binding by the first and second generation, irreversible binding of the first, second generation of BTK inhibitor. They are binding, interestingly, to BTK, but also to the mutated form of BTK. So this would give the advantage of treating the patient after they develop a resistance to ibrutinib. And this is what we see from the preliminary data, I would say, in phase 1 of one of the molecules, the RQ531, where here out of 9 patients, 8 responded very nicely in case they had even mutation in BTK and they relapsed under ibrutinib. Here I show you the data presented again by Anthony Mato last year at ASH that show that with a LOXO patient with CLL relapsing in the vast majority of cases after ibrutinib, in 2/3 because of resistance, and in 1/4 with the presence of mutation in the BTK, treated with LOXO 305, they have this kind of responses, which is something very interesting in the relapsed refractory setting after ibrutinib. Here in blue, you can see the patient with mutation relapsing on ibrutinib, and they could achieve almost even complete responses. So the future is very promising. One of the 3 molecules, like becabrutinib, indeed was not further developed because of lack of efficacy. So with this, I think that the last issue is the continuous treatment. We would like to get rid of continuous treatment to have at least, not fixed duration, but at least a time-limited therapy, because that would mean a personalized quantity of drug for patients. So the time can be variable, and we should stop the treatment based on the response, the actual response of the patient. That is what we explored in the Captivate study, where patients have been treated in first line with ibrutinib for 3 months to debulk, and then for 12 months with ibrutinib plus venetoclax. At the end of the 12 months, patients were analyzed for their MRD status, and those with confirmed MRD were randomized to either nothing, so discontinued therapy, placebo, or agglutinin continuous treatment, which is the standard of care. Those who did not achieve undetected MRD were not left alone, were not obliged to stop, but they were randomized to either continuous agglutinin or a consolidation with agglutinin plus venetoclax. And the results presented last year at ASH, 1 year disease-free survival, showed that there is no difference between the placebo and agglutinin in those who achieve undetectable MRD, really suggesting that we can really personalize the treatment based on the quality of the response. Those who did not achieve undetectable MRD, they've been treated, and for all these patients, we have a 30-month PFS of more than 95%. So really, we apparently chose the best treatment for every patient, depending on the quality of their response. And with that, I want to conclude in the era of chemo-free treatment, because this is already a reality in CLL. I think that we have to learn also to personalize the treatment and to find markers, predictors of patients who will benefit from fixed duration treatment, or a time-limited treatment, or for continuous treatment. Thank you very much for your attention. I'm happy to answer your questions.
Thank you very much, Professor Chia, for this excellent presentation. It's wonderful to see the progress which has been obtained in CLL. And I think there will be several questions. There is one question from the floor. The question is whether you still need to check for mutation status in elderly patients.
Yeah, indeed, that's a very good question. And indeed, of course, if you are already planning not to use immunochemotherapy, you might think that it's not worth it to do also to analyze the hemoglobin gene status, for example, of P53. But as I showed you, since now we are moving from continuous treatment to fixed duration or time-limited treatment, this information is still relevant in order to really decide what is the best treatment for our patient.
How did you? Another question from the audience. How do you decide between two treatment options, namely BCL2 inhibitor venetoclax based treatment versus ibrutinib and BTK based treatment? What is your choice and why?
That's a very good question. I have to say that I fully rely on the genetic stratification again, because I think that all the data that we have on BTK inhibitors and the continuous treatment with BTK inhibitors makes them probably the safest option for all patients. We know that we can control for many years the vast majority of our patients, including those with high-risk features. But of course, we are attracted from the fixed duration treatment, and therefore we really like to give, for example, to the mutated patient and the mutated patient just a short treatment that is, I would say, with 12 cycles. I'm dreaming and looking forward to the time when we can really stop the treatment based on the quality of the response, so that we do not need to decide upfront what I'm going to give to my patient. But I just start, and those who respond well, we can stop. Those who do not, for example, I could continue venetoclax monotherapy, but this is not possible at the moment, at least in our country.
Yeah. So we have only a little time left, but two final questions. Is CLL curable? Can we cure individual patients?
Maybe we are already doing some of those who have been treated with FDR, some of the mutated patients have been cured. So I have some patients who never relapsed, and sooner or later they will die of something else. At the moment, most of our patients treated with chemo-free treatment have been treated with agglutinin, and we know there that we don't achieve deep responses, so the disease is still there, even if they are functionally cured. So the disease is there, but it's not doing nothing for 7-8 years now. So is that cure? That's a cure also, but it's not really the elimination of the disease. Okay. So maybe the combination between ibrutinib and venetoclax will really help us to achieve durable responses and really cure, at least in a portion of it, not.
So last question. what are the parameters for you to motivate you to recommend start of therapy in individual patients? Is it all the same as it was? Yeah.
It's always only 3 things. I treated my patients in the last 20 years only for 3 things: being anemic below 10 grams, thrombocytopenic below 50,000, and bulky lymphadenopathies more of 10 centimeters. So don't treat anyone with 5 centimeters lymph node, please. Wait until 10, nothing is happening, and some patients even go more than that without any harm. So please be very strict on objective measurement.
Thank you very much for this excellent discussion. So I hand over to Professor Lenice. Yeah.
Yes, dear colleagues, the next speaker will be Professor Ludwig Hens. Professor is very well-known expert in the field of multiple myeloma and anemia, and Professor is also Chief of Cancer Research Institute in Department of Medicine, and he's a board member of International Myeloma Foundation and President of Austrian Forum Against Cancer. The screen is yours, Professor, please.
Thanks so much, Professor Lenice. So I'm talking about COVID vaccination in patients with myeloma and other monoclonal gammopathies. So I move on. The next slide shows you my disclosures, and then I'm already touching a slide which is common to you because we all know that patients with myeloma have an increased risk for infections. Even before you start therapy, 50% of patients experience infections before start of therapy. So this is mainly due to the myeloma-induced immunosuppression. Immunosuppression by the myeloma clone is probably the most important factor in immune deficiency of our patients, but there are other factors as well. Myeloma and treatment-associated organ dysfunction, and particularly certain myeloma therapies such as proteasome inhibitors, which inhibit T-cell proliferation, monoclonal antibodies, daratumumab, and so on. And we should not forget that many of our patients are of higher age, so they may suffer from immunosenescence, and if they are heavily treated with myeloma therapies, there may be T-cell depletion, and interestingly, males have a higher risk for infections. And infections are actually, I have some problems with my mouse, sorry. The risk for infection is quite high in myeloma patients. This is from a Scandinavian study showing that the risk for bacterial infections is 7-fold higher than in the general population. For viral infection, about 10-fold higher. And you see already an increased risk for infection in patients with MGUS. Most of the infections present in the upper or lower respiratory tract. Actually, most of the infections are viral infections, which are frequently door openers for a bacterial infection. Now, moving on. And when you vaccinate your patients, I have a problem with my mouse. Then what you see is impaired immune response or response to vaccination in myeloma patients as compared to controls. And that is true for practically all vaccines. If you use a staphylococci vaccine, pneumococci, herpes zoster, or diphtheria, myeloma patients usually have the poorest response. And here you have patients with Waldenström disease. Here you have the MGUS patients and the controls. So they have a weak immune response to several vaccines. Now, this is, I wonder whether you can move forward my slides because it is difficult from here. So this is the SARS-CoV virus 2, the culprit of COVID disease. And here you see the name comes from this corona of spike proteins. And the spike proteins are used by the virus to attach to a receptor on epithelial cells on the angiotensin E2 receptor. And when the virus binds to the receptor, then serine protease becomes activated and cleaves some part away from the spike protein, and that enhances and enables endosome independent entry into the epithelial cell. Yeah, okay. So this slide shows the risk factors and for mortality in the largest patient cohort, largest cohort of myeloma patients. And this study has been published by the International Myeloma Society. And you see here the mortality differs in different countries, but there is something which is constant. So the mortality increases with increasing age. And you see here risk factors for mortality: high stage, high risk myeloma, renal disease, active or progressive disease, and one or more comorbidities. Next slide, please. And this is a study from Spain, looking at the mortality in Spanish patients, and you see practically the same. Risk factors are here: age, as you see, male gender, renal disease, and again, active disease or progression, again, as a relapsing disease. Now, when we look at the next slide, you see here a summary on the next slide of risk factors observed in different studies. You see here the mortality rate observed in different studies ranging between 24, 22, and 33%. And here you have risk factors identified: its age, again, high risk cytogenetics, renal disease, active disease, and comorbidities. So let's move to the next one. So we need to protect our patients by vaccines. And nowadays there are different techniques available for production of vaccines. You have here on the left side DNA or RNA-based vaccines, where you inject the respective genetic information, and the patient produces the protein, the spike protein usually. You can use vector vaccines, where you use, for instance, adenoviruses or vesicular stomatitis virus, and you incorporate in the virus the DNA of the protein you want to be expressed. You can use protein subunit approaches, where you just use specific proteins of the virus for vaccination. And you can use virus-like particles, as shown here, or as done in China, you can use a whole virus, inactivated virus, and use this virus for vaccination in your patients. Next slide. And these are the vaccines which are available in the Western world. Here you have the vaccines which are now approved in Europe. You have the mRNA vaccines, viral vector vaccines, and new vaccines will be approved soon. A protein subunit vaccine from Novavax and CureVac will come in with an mRNA-based vaccine. Usually you have to administer 2 doses, only the Johnson & Johnson vaccine needs 1 dose, and all these vaccines give you a high efficacy against the original Wuhan COVID strain. Now, next slide, please. When you vaccinate your patients, some of the patients have already an innate immune response, but what you want to induce is very rapidly to activate dendritic cells, which present the antigens to different T cells, T helper cells, T regulatory cells, cytolytic T cells, and T follicular helper cells, which finally support the differentiation of B cells into plasma cells. And what you want to achieve is long-living memory T cells and memory B cells, as shown here in blue and in red. Next slide. When you immunize patients who have had COVID before, these are the patients shown by the brown dots here, and patients who are COVID naive. You see at the start of vaccination, you see already antibodies against the spike protein in the patients who had been infected. And there's no antibody production in the first few days, but after 5 to 9 days, you find also in the vaccinated COVID-naive patients antibodies, but the antibody levels are much higher in those patients who had had COVID before, and during the further follow-up, this discrepancy remains, but it levels off a little bit here after longer follow-up. What is important is that the first dose is usually better tolerated than the second dose. And what is important also, and that is shown in the next graph, next slide, when you look at a cellular immune response in vaccinated patients, these are those shown in black, versus cellular immune response in patients who had COVID infection before, you see a much greater diversity of T-cell responses to different antigens in the previously infected patients. And in the vaccinated patient, of course, you see only a T-cell response against the proteins which have been used for vaccination here, the S1 and S2 protein. Next one. And that is very important, this slide, because this is a study in 70 healthcare workers. And the researchers looked at cellular immunity, shown here, and antibody production. And what they disclosed is very important, because they found several patients with a significant T-cell response, as shown here by these arrows, without antibody production. So there are some patients who develop T-cell responses but don't develop antibodies. And here you find the vice versa situation, no T-cell response and antibody response in this patient, for instance. So we should keep that in mind, that the world not only consists of antibodies, antibody formation, but cellular immunity may be very important, particularly when it comes to combat infection of the organs. Next slide, please. And now we come to the results which have been obtained in patients with multiple myeloma. We have now 3 studies which report antibody response after 1 dose of vaccine. This one comes from Evangelos Terpos. He used the BioNTech vaccine. This is the baseline situation in myeloma patient in controls. And after 1 dose, you see here a nice increase in the antibody levels in the controls, but a much lower increase in the controls. 8.3% of the myeloma and 20.2% of the controls had neutralizing antibodies greater than 50% at day 22. And responding patients were in remission without myeloma therapy and had no immunoparesis. Low antibody responses were also noted in 9 of 11 patients with smoldering myeloma. The next slide shows the results of an English group investigating 93 patients with myeloma, younger patients, and they found an overall response rate of almost 56% compared to 99% in hospital staff. But what they found, those patients had already treatment, and you see here the response status, and you see here patients who had an excellent response had a higher chance to develop antibodies, and this also applies to patients who had no immunoparesis. So when they looked at parameters which predict for response, this was the response status, namely very good response to myeloma therapy, no immunoparesis, and only 1 line of therapy. The more prior lines of therapy, the lower the likelihood for a good antibody response. And the last study in myeloma, it has just been published last week, next slide please, shows you the antibody response in patients with myeloma and myeloproliferative malignancies and controls. You see here the geometric mean antibody concentration, which is much lower in myeloma patients, lower than in patients with myeloproliferative syndromes, and of course much lower than in controls. And when you set the cutoff value of 14 absorbance units as a cutoff level for a positive response, you see here after the second dose, 22 days after the first dose, you see a minor response, and this improves 5 weeks after the first dose. So there is some improvement after longer follow-up, but it's much lower than in controls. So in some myeloma patients are not able to produce a very good antibody response. Actually, yeah, let's go to the next one. Next one. You have here again the predictors for poor response. Actually, those Italian researchers found very poor antibody response in patients on daratumumab, and the antibody response was much higher in patients on proteasome inhibitors, IMiDs, or a combination of IMiDs and proteasome inhibitors. Next slide, please. Yes, what are the side effects? When you look at the package inserts and from your personal experience, very common side effects, of course, are pain at the injection site, erythema, tiredness, swellingness, headache, muscle pain, joint pain, chills, and whatever. And severe side effects are shown here, and I have an individual slide for the severe side effects. Let's look at the next slide, please. That is next one. Yeah, there are some severe allergic reactions after the mRNA vaccines, which have been observed, but also after the vector-based vaccines. For the BioNTech vaccine, the frequency was 1 in 100,000 doses. It's higher than the allergic reaction towards other non-COVID vaccines, and it's most likely due to polyethylene glycol excipient or polysorbate excipient in the vaccine. You had already probably a very elegant discussion on the vaccine-induced thrombotic thrombocytopenia. What is important, these patients present with sinus vein thrombosis, Planck-Schnick, portal, or hepatic vein thrombosis, have high levels of D-dimers, low fibrinogen, antibodies against platelet factor 4, and a mortality around 20%. And this syndrome occurs predominantly in women younger than 60 years of age. And if you diagnose such a syndrome, you use immediately anticoagulation, but not the heparin, high-dose glucocorticosteroids, and intravenous immunoglobulin. Next slide. And then there is something which is called long COVID syndrome. The pathogenesis is poorly understood, and it is associated with a series of symptoms which may be very debilitating for individual patients. There's no good remedy for this symptom and syndrome as yet. Next slide, please. Now, when we look at the mutation rate of SARS-CoV virus 2, the mutation rate is basically lower than the mutation rate of influenza, 50% lower, even 1/4 of the mutation rate of HIV. But you see here the high prevalence of SARS-CoV virus with the global spread actually indicate there's a lot of mutations which are ongoing. And here you see most prominent mutation. You see mutations in the spike protein, in the nucleoprotein, and here you see it again. So genes encoding the spike protein, nucleoprotein, these are shown here, the mutations are shown here. And when you look at specific type of mutations, next slide, then you see a mutation in the UK variant, in the South African variant, and Brazilian variant, which occurs in all three variants. That is the N501Y mutation, and I will show you the importance of this mutation. You find here other mutation, and here is the Indian variant. And when you look at the importance of this mutation, next slide, you see that, next slide, please. Next, yeah, you see that this mutation increases the affinity of the spike protein to the ACE receptor. It's based on a change from arginine to tyrosine, and this enables the virus to attach the receptor more easily with a higher affinity, increases the infection rate. Next, please. You see viruses with these characteristics penetrate the society. This is a sample example from Canada. This is the old Wuhan strain, and this is the UK strain, which penetrates the viral scenery in Canada. Next slide. And you see here that the neutralizing activity of the AstraZeneca vaccine is much lower against the UK variant, but it's still protective. That is important. That is shown in the next slide. Next slide here. There is a reduced neutralizing activity of the antibodies induced by these vaccines, but usually the vaccines are still effective and when it comes to clinical severe disease. Next slide, please. Here you have the different important mutations, the mutations of concern. That is the Indian mutation again. Here you see all of those mutations have an increased transmissibility. For most of them, increased virulence has been already documented, and reduced antigenicity against the antibodies which are induced by the available vaccines has also been shown for these mutations. And the vaccines, next slide. Next slide, please. Yeah. What can we do in patients with insufficient immune response? They have to obey to the general principles of infection risk reduction, social distancing, mask wearing, hand washing, and so on and so on. They depend, and this is a significant number of our myeloma patients, they depend on herd immunity and ring vaccination. That is meant the vaccination around his social contacts. What is on the horizon is you may use cocktails of monoclonal antibodies against SARS-CoV-2 virus. They are already approved for treatment, and they may be helpful, but they are not approved for protecting those patients. And there are new antibodies in development with a very long half-life of up to 6 months. So in theory, patients without a significant immune response can in future be protected by these antibody cocktails. Next one. Several antivirals, of course, in preclinical and clinical development. And hopefully will be active. Some of them will be clinically active. Next slide, please. So in some, vaccinations have saved more lives than any other medical intervention. That is clear. All patients with MGUS, smoldering myeloma, monoclonal gammopathies of clinical significance should be vaccinated with a COVID vaccine. Next slide. Patients should be vaccinated preferable before the onset of active disease, during well-controlled disease, before start of therapy, before stem cell collection. And if patients are transplanted, probably one should wait for 3 months before you start with the first dose. And of course, during periods without chemotherapy, with the exception of lenalidomide maintenance therapy. Caregivers of patients and patients' close contacts should be vaccinated. New data show significant impaired immune response in myeloma. We have seen that. And next, please. And COVID vaccination will leave many patients unprotected or poorly protected. Next, please. Risk factors for poor response to vaccination are uncontrolled disease, immunoparesis, number of prior lines of therapy, age, and several treatments, particularly CD38 antibodies, BiTEs probably, and other immune therapies. And the recommendations for patients with myeloma after vaccination are as follows: check humoral in cellular immune response to find out whether the patient is on safe ground. If the immune response is insufficient, create herd immunity, use a strategy of ring vaccination, and patients with insufficient immune response need to strictly obey the general principles for infection risk reduction until complete herd immunity. And of course, the future hopefully is bright. New vaccines covering mutated variants, adjuvanted, stronger vaccines, B and trivalent vaccines will be introduced. New therapies will be available in the future, and hopefully the pandemic will be overcome soon. This would also help patients without significant immune response to the vaccines. With that saying, I would like to close and invite you to the International Myeloma Workshop in September this year in Vienna. Thank you very much for your attention.
Thank you, Professor, for presentation. And we at the moment have no questions in the chat, but I want to ask you, what in the case of treatment of those patients and COVID infections, do you have something special for advice, or it's like in general proposals?
If patients are treated, receive myeloma treatment?
And
yes.
COVID infection active.
And concomitant COVID infection, yes. That is a difficult question because, of course, you probably wouldn't change your general policy, which is used for patients with COVID infection. You will use probably high-dose corticosteroids. And if you have the monoclonal antibody cocktails at hand, you will consider to use them. So the antibody cocktails against COVID. Otherwise, of course, you will stop myeloma therapy, no question. But myeloma patients who are COVID infected usually have problems to eliminate the virus and have prolonged periods of infection. And this is an excellent ground for the virus to produce mutations. So it's a difficult situation. So, and you, of course, you can use reconvalescent serum, but this has not been shown to be very effective. I think the monoclonal antibodies are much more effective.
Okay, thank you.
So,
I think it's no more questions. Thank you, Professor. And the next speaker will be Laura Zvēniece from Riga Stradiņš University, from Institute of Microbiology and Virology. And she is research assistant. At the moment, her main interest is medical genetics, immunology, molecular biology. And at the moment, she is also a PhD student in Riga Stradiņš University. Please, Laura.
Hello, everyone. Thank you for the very kind introduction and for this opportunity to participate in this very well organized conference. As I was already introduced, I'm a PhD student in Riga Stradiņš University, and this research that I'm going to show today is part of an ongoing project, which is based on our previous results and aimed on validation of new prognostic markers for the CLL patients. And these are cell surface chemokine receptors, CCR1 and CCR2. The aim of the project that we are working on is to validate these two receptors, CCR1 and CCR2, their cell surface expression as a reliable predictor of this high-risk progression in CLL patients at presentation, and to evaluate its association with the other already known prognostic factors, including the immunoglobulin heavy chain variable region mutational status and also Epstein-Barr virus DNA load. Just a little bit about the receptor so that everyone understands. So the CCR1 is the chemokine receptor type 1, and these chemokine receptors are cytokine receptors, so their ligand is cytokine named chemokine, and they are expressed on the surface of certain immune cells. About the structure, as you see on the image on the right, there is it has the 7 transmembrane domains that correspond to this G protein coupled receptor family member, and this receptor responds to a number of inflammatory chemokines that are induced upon inflammation and under pathophysiological conditions. And the CCR1 transduce a signal by increasing intracellular calcium levels. And they are very important receptors and it's an important network on this immune system. The localization is on the 3rd chromosome. Earlier, applying multi-parameter flow cytometry analysis on the peripheral blood mononuclear cells of CLL cells, we determined a correlation between the self-surface expression of chemokine receptor CCR1 and the negative prognostic marker CD38 on these CLL cells. If we talk in numbers, then the number of patients with the CCR1 positive and CCR2 positive CLL cell lymphocytes was essentially higher in the CD38 positive groups compared to the CD38 negative. We divided based on the CD38 surface expression. We divided these patients into 3 groups. CD38 positive, so CD38 moderate, and CD38 negative group. And the CCR1 and CCR2 expression was on the CLL cells, but the highest in this group with CD38 moderate and CD38 positive expression of the cells. And CD38 is a marker. Its expression on the CLL cells has been already associated with the unmutated immunoglobulin. Also, the shorter overall survival in patients with the CLL, and there are already numerous reports that confirms this association between CD38 on CLL cells and more aggressive CLL disease. Also, these patients had the reduced time to first treatment, progression-free survival, and overall survival. These results that I just showed you in the previous slide are already published in the previous year in the Journal of Clinical Medicine. The aim of this study was to identify mutations within this CCR1 gene in CLL patients and compare them between these 2 groups with low, moderate, and high CD38 expression on leukemic cells. The methods that we used, so we amplified the CCR1 gene exon 2, covering the CDS region using PCR. Then we cloned this amplified fragment into vector, and then we extracted 10 clones and analyzed their sequences. The sequences were compared to the here you can see the exact reference sequence that was found in the SNP database. The results that we got, so with CCR1, we analyzed 32 patient samples, 10 clones per each sample. And in 12 patients, we found single nucleotide variants, 9 different single nucleotide variants within the CCR1 gene CDS region. if we see between different groups, so the low expression CD38 group was with less than 6% of CD38 on on CLL cells. Moderate CD38 expression was if the expression level was between 6 and 30%, and high CD38 was above 30% of expression of CLL cells. And we see that the most these single nucleotide variants we found in moderate and high expression CD38, in each 5 different ones, and only 2 in this low expression group. Notably, that identical frame shift variant was found in 2 patients from CD38 moderate group and 1 patient from CD38 positive group. All of the rest were unique single nucleotide variants that were not consistent between different samples. Also, despite these variants that were already reported in this database of single nucleotide polymorphisms, we found several mutations, the variants that were not reported in this database. They were found in 25 patient samples out of 32. Most of them were unique for the patient or the clone, but 4 variants were identified in more than 1 patient. It was in 2 to 4 patients, the same variant. And if we look on the distribution for these mutations among different CD38 expression groups, here on the right, on the left upper part, we see the CD38 negative, and here the moderate on the left side and positive on the right side. All of the orange ones are the single nucleotide variants that we saw, and only in 1 patient it was in more than 1 clone. It was in 7, and the mutations were missense in most of the cases, and there was 1 case with a nonsense mutation, so in the with a premature stop codon within the CCR1, and this case we found in this CD38 positive group. So the conclusions that we detected some single nucleotide variants in 10 patients with the prognostic marker CD38 expressing leukemic cells, which could suggest that the identified single nucleotide variants within the CCR1 gene exon 2 might correlate with a more aggressive type of disease. However, we need further analysis of this CCR1 exon 1 and also this 5' untranslated region, as well as extended cohort of patients for these unfailing conclusions, because we cannot rely on only 1 clone to speak for sure. But as I already showed you in the beginning, we also work and are interested in CCR2 receptor, because the CCR1 and CCR2 share a homology, and if they can replace one another and interact with the same ligands. So the CCR2, we already started the analysis of the sequences, and these results are not yet finished, but we already see that there are several, 13 single nucleotide variants so far, and we see this detection of the variants in more than 1 clone and in more than 1 patient. So there we can have some conclusions and correlation between them. There were 2 patients where no allele identical to reference sequence, so those alleles were with single nucleotide variants were found in the database. This study was conducted in the frame of Latvian Council of Science Research Project with the project manager Irina Holodnyuk, and hopefully we will finish our results and we will have them published, and then we can have more information regarding this topic, especially about the CCR2 and the results, and could there be this association between these variants and the more aggressive type of the CLL disease. And also, this is part of my PhD thesis, which topic will be investigation of chronic lymphocytic leukemia prognostic factor association. Thank you very much for your attention. I would be happy to hear any questions you have.
Yeah, thank you very much, Laura, for this excellent presentation. It was a pleasure to follow you. So I look whether we have something in the checkpoint. No, not at this point of time, but I would like to ask you, are there inhibitors for CCR1 known, or did you try silencing the gene or knocking out the gene for CCR1, and is this clinical relevant in these aggressive types of leukemias?
Thank you for the question. We have not found any inhibitors, and we have not yet performed these experiments with the knocking out of the gene. However, with these mutation analysis, we wanted to see if there is why this association between the CCR1 expression and the CD38, which is negative prognostic factor, why it is not 100%. So we wanted to see first if we have some kind of reason in the gene level, in genetic level, and if, for example, in the CCR1 we can't for sure say that there is these different mutations. So the next level would be maybe to look on this epigenetic level that maybe turns off the expression of this gene. But definitely we will go further and maybe perform another project with more and different analysis on these receptors.
Oh, very good. So thank you very much. There are no questions from the audience. So I think we are just in time, and we will move on. Thanks again for this wonderful presentation. And it's my pleasure now to call Milda Rudzianskine. She is a hematologist oncologist working in the hospital Lithuanian University of Health Science, Oncology and Hematology Department, and she will share with us her experience with auto transplantation in patients with relapsed refractory multiple myeloma. She will not be presented live, but there will be a video, and we will have a discussion afterwards when we have seen the video. Thank you, and let's see the video.
Good afternoon for everybody. High-dose therapy and autologous stem cell transplantation remain integral in the initial treatment of multiple myeloma, and now are increasingly being applied also for management of relapsed disease. I would like shortly to present data of our center of our patients who underwent salvage autologous stem cell transplantation for relapsed multiple myeloma after receiving an initial transplant from 2020. Our autologous stem cell transplantation program was implemented in our center and started from 2020, and as you can see, every year the numbers of patients are increased, and not only for multiple myeloma patients as it's shown in this chart, but also for other indications as lymphoma and autoimmune disease. Till the beginning of the May in 2021, we did already 146 transplants in total for multiple myeloma patients. Some of them had tandem transplantation, 70 patients had the second transplant in the disease relapse as a salvage transplant. has been a growing interest in the role for autologous stem cell transplantation in the salvage setting, and several studies have shown it to be safe and efficient in selected patients. 102 patients received one tendon transplant in our center, and half of them relapsed. And we were able to do a salvage autologous stem cell transplantation for 70 patients. The reasons why we couldn't perform transplant for all patients were old age and comorbidities, short duration of the remission after the initial transplant, no deep remission after the salvage therapy, second-line therapy, and patient decision. Demographics and clinical characteristics at the time of initial autologous stem cell transplantation and salvage autologous stem cell transplantation are shown in this table. The median age at diagnosis and during the salvage autologous was quite the same. Almost all patients were ISS 2 stage of disease. The most patients received melphalan 200, also in the salvage autologous stem cell transplantation. These patients who was treated with reduced dose of melphalan during the initial autologous stem cell transplantation, also they received reduced dose of melphalan salvage autologous stem cell transplantation. And median time between the initial and salvage autologous stem cell transplantation was 30 months. If to look in this picture, you can see that the patients who receive only one transplant are more likely to relapse than the patients after the tandem transplantation. We also have to take into account that patients who had tandem transplant were high-risk patients or patients who didn't achieve the complete remission after initial transplant. Also, recent results of clinical trials with the new induction regimens indicate that there is a role for tandem stem cell transplantation in the presence of adverse cytogenetic abnormalities and high-risk myeloma patients. So the tandem transplantation approach, I think, should be considered for all patients who experience the incomplete response to a single transplant. It's very important to identify the high-risk multiple myeloma patients at the time of diagnosis. Accurate identification of these high-risk patients in the first step to improve the outcomes, not only for these unfortunately individuals, but for all patients. In our center analysis, we found that around 20% of all patients were high-risk patients, and 4 of them relapsed. If to talk about induction therapy, based on response rates and progression-free survival, 3 drug combinations, including at least bortezomib and dexamethasone, are currently the standard of care before autologous stem cell transplantation in Lithuania. Almost all our patients, especially high-risk patients for induction chemotherapy, were treated with proteasome inhibitors as bortezomib and dexamethasone backbone. Chemotherapy adding the third agent, in the most cases thalidomide, sometimes cyclophosphamide. It is well known to induce high response rates. Usually 4 courses were given for the induction chemotherapy in our center. In the relapse setting, as you can see in the chart below, for the second-line therapy, several regimens with various combinations of drugs were used, but much more often the bortezomib-based chemotherapy again, because only from the 2020 July in Lithuania we received the reimbursement of the carfilzomib and lenalidomide combination. Before we can use lenalidomide only in Lendex combination, and it is not sufficient for the relapsed patient who underwent the salvage autologous stem cell transplantation. The assessment of response is based on International Myeloma Working Group criteria, and as showed in this chart, the complete response after salvage therapy before autologous stem cell transplantation was 18%, and very good partial response 82%. And after salvage autologous stem cell transplantation, we were able to achieve quite double of complete response, 35%. The introduction of novel agents early in the management of patients with myeloma has improved the progression-free survival to frontline therapy and after. The median follow-up was 28 months, and the median progression-free survival after the first autologous stem cell transplantation was 25 months. 2 years PFS was 68%. It could be longer if we will be able to give patients maintenance with lenalidomide or proteasomal inhibitors for high-risk patients. Unfortunately, we don't have reimbursement for maintenance in Lithuania. If to look at the PFS curve after the tandem transplantation, where in tandem autologous group, the major part of the patients were high-risk patients or with incomplete remission patients, we found that the median PFS 19 months and 2 years PFS of 72% of all patients. The median PFS after salvage autologous stem cell transplantation was 18 months without maintenance therapy. So in our center, experienced salvage autologous stem cell transplantation appears to be safe and quite effective treatment strategy for relapse multiple myeloma. Advances in the treatment of multiple myeloma have greatly improved overall survival over the past decade. 5 years overall survival in our patient was 73%. That showed that overall survival in myeloma patients seen in a clinical practice setting match the results of the clinical trials. In conclusion, salvage autologous stem cell transplantation could be considered as an option in relapsed refractory patients who had at least 18 months time of progression after the initial stem cell transplantation. And I would like to thank my colleague Vilma Svetitskienė for her help to make this presentation. And of course, I would like to thank all my colleagues from Hematology department. We are working all every day together, and they are a very big help every day for me. Thank you very much for your attention.
So, do we have an option to discuss this?
We are ready for discussion, Professor. Yes.
So, this was very interesting. And the overall survival data look exceedingly good, I must say.
Thank you.
But I've seen several induction regimens. Don't you have a policy where you use just one regimen for induction in all your patients, such as VTT, which has to be shown to be very effective and probably more effective than VCT or tablets?
Yeah, we are trying to use for induction VTD, as I will show, but if there is toxicity or intolerance, we are moving to VCD, and so mostly proteasome-based Velcade, but for Revlimid we don't have for first line at the moment. Before autologous hematopoietic stem cell transplantation.
Yeah. And how many cycles do you usually, but we will see from your presentation, how many cycles?
Usually 4 to 6 cycles. It's like Spanish data, we move to 6, but we are more to 4.
Yeah. And there's a discussion of what should be done in patients who are not responding very well to your first-line induction treatment. Let's say patients are on VDD and don't achieve partial remission or better. Do you then move on to transplant immediately, or do you try to switch to another regimen?
It's if we achieve at least partial response, we are moving to transplant. Yeah. If not, maybe trying bendamustine to switch to alternative to get better at least response and to go to transplant. Yeah. So, but we don't have many options at the first line to change.
Yeah. Are there any questions from the audience? No. So I think Professor Lenice will introduce now the next, you, Professor Gerbuntavikus. Yeah, so I stay background and the floor is of Professor Lenice. Yeah.
Yes, dear colleagues, it's my pleasure to introduce next speaker, Professor Ronaldas Gerbitavičius. He is the head of hematological department in Lithuania University of Health Science Hospital Colloquium, and his main interest is thrombosis and also multiple myeloma. And today he will speak about multiple myeloma. And the screen is yours, Professor.
Thank you, Sandra. Thank you, Ludwig, for a nice introduction. And I would like to present our results from our small cohort of patients, which were double transplanted for multiple myeloma. And as we all know, the superiority of autologous hematopoietic stem cell transplantation over conventional therapy for transplant-eligible multiple myeloma patient is confirmed even in the era of these highly active novel agents. But also, we can hear from different conferences quite conflicting results regarding single versus double hematopoietic stem transplantation while we performing with autologous multiple myeloma patients. And results from new studies are emerging and discussed. And I think one of the most important studies also is presented by Professor Michel Cavo. This is European Multiple Myeloma Network 02 study, which also at one randomization arm also compared tandem transplantation versus single transplantation followed by lenalidomide maintenance. And authors of this result of this study reported superior 5-year progression-free survival, 53% versus 44%, and superior overall survival, 80% versus 72%. When we performed tandem transplantation versus single autologous hematopoietic stem transplantation. And after that, subgroup analysis was done, and authors now also reporting what the best response was in high-risk cytogenetic multiple myeloma group when comparing double versus single autologous transplantation, defined as 70p deletion for 14 translocation and 14-16 translocation, and 5-year overall survival in tandem arm was 61% versus single 54%. Also, we heard controversial results from our colleagues from US, BMT CTN 0702 stamina study, And in intent to treat population, it was not different between tandem and single transplantation. Of course, study design was completely different from EMN02 study, but now in ASCO 2020, we reported what as treated analysis, also superior 6-year progression-free survival was observed in tandem transplantation group versus single, 49% versus 38%. And also we noticed the same trend, but the most benefit was in high-risk patients, PFS 6-year 43 versus 26%. So from 2016, we have in our department 27 tandem transplantation for multiple myeloma, 24 patients, 3 patients were multiple plasmacytoma patients, and 26% high-risk cytogenetic features is roughly the same as EMN study. And as mentioned, MILDA, no consolidation therapy was possible in our hospital, and no maintenance therapy was given. So median time before first and second autologous hematopoietic stem transplantation is 162 days. So we know definition of tandem transplantation 6 months. So it's we are fitting in this definition. And regarding gender, it was equal distribution of male and females, and mostly we transplanted patients from 46 to 65 years of age. It's 82% of patients, but some patients were older when 66 years old. It's about 7% of our patients. And at the diagnosis, most patients which were given tandem transplantation were in Duria-Salmon third stage, 48% third stage A, and 22% on 3B stage. And the same it was noticed on the ISS risk stratification. Most patients were in multiple myeloma high risk group, ISS 3 stage 48%, and ISS stage 2 41% of patients. At diagnosis, as in maybe other clinical studies, most patients were diagnosed with IgG type multiple myeloma, 48%, 19% were IgG-A multiple myeloma, and 22% presented with only light chain disease. As for multiple myeloma induction regimen, we can repeat what 82% of patients got Velcade, thalidomide, and dexamethasone, and usual median course 5 courses of induction range from 4 to 6, and some patients due to intolerance got instead thalidomide, cyclophosphamide, and at the end of the induction, 33% of patients were in complete response, and 52% reached very good partial response, and 15% were in partial response. So just with graph, I would like to show what in both transplantations, conditioning dose was the same. It's most patients received classical melphalan 200 milligram per square meter during the first and during the second autologous hematopoietic stem transplantation. And just for the sake of interest, mostly using cyclophosphamide 3 grams per square meters and GCSF mobilization, we collected before first hematopoietic stem transplantation about 14 million of CD34 positive cells per kilogram of body weight of patient, and we used for the first transplantation 5.7 on median, and for the second 5.3, so it's roughly the same. And for the potential third transplantation, as it's also shown what it can be used in some cases, it is left 4 million CD34 stem cells. So mobilization efficiency was good for our patients. And I wanted to compare engraftment and regeneration during first and second transplant. Before just we started this program, I was a little bit afraid of this tandem. Maybe thought what second transplantation it's more toxic, but from our small cohort of patients, we see now what engraftment and regeneration of platelets and leukocytes are the same during the first and the second transplantation. So platelets engrafted and regenerated median on 14 days, and leukocytes on 11 days, and it's the same during first and second transplantation. And also we may be asked, maybe different it will be in blood cell support or erythrocyte transfusion or platelet transfusion, but after the first hematopoietic stem cell transplantation, erythrocyte transfusion were from 0 to 3, and after second from 0 to 4, and platelet transfusion median it was 2 during first and during second autologous hematopoietic stem cell transplantation in tandem setting. The same also reflects in infection complications. We diagnosed 14 infectious complications during first transplantation and 15 during second, and mostly it was febrile neutropenia managed successfully with antibiotics. So there is no increased toxicity during second transplantation, and it reflects in a hospitalization duration. It's the same, a median 25 days during first transplantation, and a median 26 during second transplantation. So we were also observed that responses increased after induction, first transplantation, and second tandem transplantation, and complete response we can see after first transplantation we are 59%, and after tandem second transplantation 74%. Of course, we are not doing MRD measurement, so we cannot report with results, but just we can hope what also increased MRD level as well. And regarding progression-free survival and overall survival, our results matched well with, I think, Yemen 2 study, 3 years progression-free survival 65%, and 3 years overall survival 83%, and standard risk patients regarding progression-free survival were a little bit better than high-risk patients, 68% versus 55%. So just for a small cohort of patients, I would like to conclude that adequate number of hematopoietic stem cells for 2 or potential 3 autologous hematopoietic stem transplantation procedures are mobilized and collected for most multiple myeloma patients. And upfront tandem autologous hematopoietic stem transplantation is a safe and effective treatment modality for multiple myeloma patients fit for intensive chemotherapy. And in the absence of maintenance therapy, it can say what we first attractive strategy to deepen and maintain response achieved with multiple myeloma induction therapy, and especially for patients with high risk cytogenetic features, but in some cases also standard risk patients. So thank you very much for attention, and we'd like to accept questions.
Yes, thank you very much for your presentation. And it's no questions in chat.
Yeah, so thank you.
Thank you.
So do we have any other questions from the floor at this point of time?
No.
No? So then I assume we shall move on after this interesting presentation. And we have already Professor Paul Richardson in our video cast. Professor Richardson is one of the world's most eminent researchers, clinical researchers in multiple myeloma. He has pioneered the introduction of several novel drugs, starting from the proteasome inhibitors over IMiDs and now selinexor and other new drugs. And he's, I think, one of the principal investigators of the joint study between the Dana-Farber Cancer Center and the French group, the IFM group, analyzing the efficacy of LBD in transplant-eligible patients and looking at the molecular background of these patients and connecting them with outcome. Professor Richardson has received several awards, among them the IMF Robert Keil Achievement Award and many others. But I think what is most important, I think he is a very kind physician, has an excellent relationship to his patients. He really cares and provides probably optimal myeloma care. So it's a privilege for us to have him here. Paul, we are very pleased that you are here. We know that you are very busy. We thank you that you accepted the invitation. And you have a very interesting topic, namely multiple myeloma therapy in 2021. Do we have too many options? So Paul, the floor is yours. Thank you very much.
Thank you very much indeed, Heinz, and it's my privilege to be with you. Can you hear me?
Yes, we can hear you. We can see you very good. So you are good, already on screen.
Well, I'm extremely grateful to the whole team who made this, put this together today, and particularly to Rumika, who was Rumiko, I believe, the very nice lady I worked with yesterday who set this all up. And it's a real privilege, Heinz, to join you. And I'm especially grateful to the organizers, and in particular to Ditka Niederwiese for the very kind invitation. And please, it's a privilege to be with you, Heinz, please. It's a pleasure actually on a Friday morning here in Boston to be able to talk with our audience. And it's so nice to see we have over 230 attendees, and I know it's late on a Friday in Lithuania. So I appreciate everyone's time. Thank you, Heinz. My mission to follow the previous speaker was really to talk to you about sort of new directions and future directions in myeloma and give you a real flavor of how complex our therapeutic armamentarium has become. But in that message, I would argue there's tremendous hope and a real possibility of what I would consider the potential for really incredible functional control of disease for many, many years in increasing numbers of our patients. I use the term functional, well, some colleagues use the term functional cure. I think that may be a little premature, but I very much hope that we're getting there, and I hope to be able to show you this. These are my relevant disclosures. And then my next slide is really a description about multiple myeloma in terms of its pathobiology. And really to spend a little time on this slide because it's the old saying, a picture says 1,000 words. Myeloma, of course, is not one disease. It is truly multiple myeloma. And it's highly complex at diagnosis. And of course, its genomic profile at relapse is extremely complex and much more so than it is at diagnosis. And this reflects an entity called clonal evolution, which we've come to understand and better appreciate, and appreciate the implications this has for our patients. So as we think about disease, and I particularly want to bring your attention to the whole genome sequencing here illustrated on the right, it's important to recognize that in this particular patient, and this patient's part of a clinical trial, and we'll talk a little bit more about that in a moment, but at diagnosis, this patient had actually over 5,000 mutations on whole genome sequencing. After initial treatment, intensification with high-dose melphalan, and maintenance, when this patient relapsed, the number of whole genome sequence mutations that were detected were over 12,000. So this points to the challenge, and it points also to what I would argue is the opportunity, because on the one hand, we have a disease with such a mutational burden that it's perhaps no surprise that purely targeted approaches have really not necessarily, with the perhaps exception of venetoclax, been tremendously successful in dealing with this disease. Having said that, combination therapies built around platforms of rational combinations that throw a net around the pathobiology of the illness clearly have resulted in tremendous improvements. And in that same context, I think it's important to look strategically at this disease and understand the impact of therapy on long-term outcome. You know, how does this impact on mutational burden? How do we think about immune exhaustion? How do we deal with infectious complications, recognizing that the immune milieu within which this immunological neoplasm lives is incredibly important to understanding how we can control it best in the future, in the longer term. And of course, as we think about this, the complexity of a reticuloendothelial disease like myeloma, in which we have extramedullary disease as an important aspect of its pathobiology in the longer term, something we've lived with myeloma since its very beginning, of course, but it's something that's becoming an increasing challenge as our therapies emerge. And so as we think about this, our ability to risk stratify, recognize clonal heterogeneity, and individualized treatment with the advent of novel therapies becomes very important. Now, in terms of the therapeutic options that are available to meet this challenge, I echo the point that Heinz so nicely made. You know, we have multiple new drugs, thank goodness. In fact, there are 15 approved novel agents at the present time and more coming. And this graphic I built and adapted it from my partner's very nice review a few years ago in leukemia, Jacob Laubach, and then a very nice review from Philippe, just published in Lancet Oncology on behalf of us. It was an IMWG working group paper in which we try to address this issue of how on earth do we sequence and strategize therapies to ensure best outcomes for our patients. The important thing to recognize, though, is that with these multiple drugs, it's also critical to appreciate that you can revisit different classes of drugs later in the disease. Simply because someone becomes resistant to a proteasome inhibitor in its inception at initial therapy certainly doesn't mean you can't visit it later in a rational combination. So for our patients, this generates the opportunity for a really strategic view of the illness, a long-term view in terms of outcome. And this next slide sort of captures that. Please let's think about strategic considerations in myeloma now versus just the simple tactical ones, and recognize that tolerability and efficacy are key with combination strategies. Now, in the interest of time, I'm not going to spend time on precursor states such as MGUS and smoldering disease. Suffice to say, great research is being done in this area. I would especially acknowledge colleagues such as my partner Irene Gobil from our group, who's doing great work there, as well as others, in which we're really trying to understand that entity better, target it with immunotherapeutic strategies predominantly, and improve outcome by virtue of so doing. I'm going to focus here in the relapse refractory space. I want to spend a little bit of time in the upfront space initially to build so nicely on the excellent talk from the previous speaker. Now, in that context, a couple of things to share as key targets in myeloma as we think about myeloma management in 2021. I would argue, I've just shared with you that there is tremendous interest in genomic abnormalities. How do we target and overcome mutations? And I've already touched on the critical role of combination and continuous therapy. I do want to spend a little bit of time on the evolving position and timing of transplant, recognizing that high-dose melphalan has been a mainstay of therapy in the context of younger transplant-eligible patients for 30 years. I had the privilege actually of working for Tim McElwain when he was alive. And as Tim said to me when I was just his junior lecturer, and he was obviously our professor in chief, he said, if we can do better for our patients than high-dose melphalan, and remember that was 1990, we will be doing our patients a favor. And I was very struck by that statement. But what he really meant was that obviously cytoreduction with high-dose melphalan was a key. The toxicities, of course, especially then, were very real. Obviously, we've improved dramatically. But I want to share with you data that I think makes us need to think again about how we position genotoxic alkylating therapy and how we use it, recognizing that alkylators are an absolute mainstay of therapy. That is absolutely established. But nonetheless, how do we position them? How do we think of using them? And what now are our alternatives? Now, in that spirit, I then want to spend some time on targeting excess protein degradation and production and talk to you a little bit about what that means in the pathobiology of myeloma and the translation to therapeutics. And most importantly, spend time on immune suppression, because I see this as the sort of the new frontier. This is the most exciting area, in my view, in myeloma research at the present time, where we're looking at restoring anti-myeloma immunity and all that that means. And in my humble view, that I think is going to be one of the most important advances in the last decade that will really transform therapeutic outcome for myeloma. So when you think about frontline therapy, this is clearly evolving. And if you look to the left of the slide, the past is on the left, recognizing that in different healthcare systems, access to new drugs has real challenges. That being said, we have wonderful combinations like bortezomib, thalidomide, and dexamethasone, where in the absence of access to lenalidomide, it has provided a great therapeutic opportunity for our patients, of course, and especially when you combine it with an antibody such as daratumumab, that platform has been particularly enhanced. Obviously, going forward, however, the lenalidomide backbone as the immunomodulator of choice in the upfront setting, I think is fairly now well established. And importantly, as we add that with the real benefit of the antibodies, we're seeing a transformation in outcome. So our lymphoma colleagues have been very fortunate to have CHOP Rituxan for many years. I would propose to you that for the first time now in myeloma, we really have the equivalent of CHOP Rituxan. We have the immunomodulator, proteasome inhibitor, steroid triplet, plus the monoclonal antibody, such as daratumumab. That, in my view, has become our CHOP Rituxan. And the question then becomes is how does this then impact not only on therapeutic sequencing, but also how does it impact on the position and timing of transplant? And in that same context, we need to think about the fact that myeloma is above all, in my view, the most adept of neoplasias in terms of resistance mechanisms. And so therefore, if we're using drugs like daratumumab early, does that mean rather like CHOP Rituxan, where you use Rituxan throughout diffuse large B-cell lymphoma, be it CHOP-R, R-RICE, R-EPOC, is the same thing the case in myeloma? Or do we need to be thinking quite differently about how we deploy our various antibodies through treatment courses in myeloma? So we'll touch on all of that as we discuss the therapeutic landscape this morning, or this evening, I should say, or this afternoon to you. So with that in mind, let's think first about triplet-based therapy. Now, this really started to gain traction over 15 years ago. And in fact, in the upfront space, this is just a representative example. Our original work with RVD was published in 2010, in fact, so over a decade ago. And at that time, we were struck by, in the setting of a multi-center trial of 66 patients, for the first time without transplantation, we saw a response rate of 100%. And in that body of data, we were able to demonstrate high quality response in the phase 2 population of 74% VGPR or better. And in fact, a 57% near CR or CR rate back then. So this was quite striking. And importantly, in this group of patients, they weren't just transplant eligible, they were also older patients too. In fact, our oldest patient in the study was in his 80s. But the fact of the matter was, this was the first time we'd seen a triplet with such high quality response generate such impressive outcomes. When we added to that with chemotherapy in the form of liposomal doxorubicin and cyclophosphamide, the results, interestingly, weren't necessarily any better. In fact, arguably, the combination with cyclophosphamide, the response rates dropped somewhat to around 88%, recognizing all the caveats of cross-trial comparisons. In any event, the observation that the triplet clearly was providing a platform and the cytotoxic chemotherapy didn't necessarily add a great deal, I think was particularly informative. Now, Anduri led a pivotal trial, the SWOG SO777 study, in which RVD was compared to RD, and this was a large multi-center US trial, first presented by Brian at ASH in 2018, and I apologize, actually a little bit earlier than that, in 2015. But nonetheless, that being said, this is an update from ASH 2018, where he was able to demonstrate a significant improvement in response rate in favor of RVD over RD. And in that same context, he was able to then demonstrate, oops, I'm sorry, I'm going to go back. He was then able to demonstrate, let me just go back a second, sorry. Well, let me do it, no. Let me see if I can go back. Here we are, sorry, that's much better, I can see it better. Oops. Let me go back, there we are, go forward one. Perfect. So basically, he was then able to demonstrate in the paper that was published in The Lancet in 2017 that there was progression-free survival and overall survival advantage in favor of the RVD combination over RD. And then, very importantly, when this was updated more recently in a paper published by Brian last year, you can see that best response and overall survival by best response at 12 months correlated with clinical outcomes. So this platform of RVD compared to RD had very comparable outcomes and very, very importantly showed clinical benefit in favor of the triplet over the doublet. Now, the question then arose, well, can we improve upon RVD? And can we enhance this with the platform of carfilzomib, lenalidomide, and dexamethasone and take this forward? Now, myself included, I actually was hoping or expecting carfilzomib to outperform lenalidomide, bortezomib, and dexamethasone in this setting. But interestingly enough, that's not what we saw. In this study, we were able to demonstrate that, in fact, the two triplets were very equivalent in their outcome, and that the toxicology of the combinations really mattered. Carfilzomib is an extremely potent proteasome inhibitor and has obviously advantages as being an irreversible inhibitor of the proteasome by virtue of its epoxy ketone class and its irreversible interaction with the beta-5 subunit. But one of the challenges with carfilzomib is vascular toxicity, and this came to the fore in this study with a 16% grade 3, 4, 5 rate of cardiovascular, pulmonary, and hypertensive type complications. Again, limiting perhaps in an important subset of patients the clinical benefit that can be derived from this. Having said that, it remains in the high-risk population in this particular trial, a triplet perhaps that may have real merit in the early setting. RVD, however, performed very well, and with equivalent outcome, the conclusion from the endurance study presented by Shaji Kumar as a plenary session at ASCO last year was that RVD should remain the triplet of choice in the upfront setting for transplant eligible and ineligible patients. And this, of course, is a very important conclusion. However, I would stress that I think KRD has a definite role, particularly in younger patients who are not at risk of vascular complications and at the same time perhaps have higher risk features. Now then the question arises, well, where does transplant belong in this paradigm? And we just heard so nicely just before about the role of intensification in the setting of myeloma and how tandem transplantation may serve a high-risk population. However, for the general myeloma population, where does early versus late autologous stem cell transplant belong? And our IFM colleagues have really led the initial experience in this with a prospective randomized phase 3 trial of 700 patients. And this data was presented in updated form at ASH as an oral session in December. And what Dr. Aurore Perot was able to present on behalf of the investigators was that with an 8-year median follow-up, there was no difference in 8-year overall survival between RVD kept initially with stem cell harvest and transplant kept in reserve versus RVD followed with early transplant. And what was very interesting was whilst there was significant PFS gain with early transplant initially, that was offset in the delayed transplant group by an equivalent PFS2. So this raises the possibility that you can keep transplant in reserve for selected patients rather than using it in everyone. What was also important in the study was that MRD was a negativity was a strong predictor of outcome regardless of what treatment you received. Now, what was very interesting, though, this particular correlative science paper presented as an oral session at ASH in December that mirrored this particular trial, the IFM study. This was work from my colleague Mehmet Samur, and I especially want to acknowledge Nikhil Munshi and Hervé Ave-Loiseau, who lead our correlative science group in this study. And what we were able to show here was that if you received RVD and you relapsed, your mutational burden from a median of 7,000 mutations at diagnosis magnified by approximately 1,700 on average at relapse. Sobering. However, if you got RVD and transplantation and you relapsed, that magnification in mutational burden was dramatically larger, and it exceeded 5,600. So this was highly significant, and this suggested that high-dose melphalan causes a 4-fold higher mutation accumulation rate per month than RVD alone. So a genotoxic alkylator-based chemotherapy in a surviving fraction of myeloma cells generates a substantially higher mutational burden at relapse than that seen without it. This is a very seminal observation in my opinion, and I think what the clinical implications of this mean remains to be seen. But nonetheless, this may explain, in part at least, why we see PFS benefit to early transplant, but we don't see overall survival benefit. And arguably there are subsets of patients in whom we may be actually doing more harm with early high-dose melphalan than we may be doing serving and benefiting others. But this obviously is a very dynamic and evolving area where ongoing studies are critical. In that spirit, our own study, our own arm of this French-American partnership is still ongoing, and we cannot report outcome from this trial yet. This was started at the same time as the French study, but in contrast to the French study, lenalidomide maintenance was given until progression and or intolerance versus just 1 year. Our French partners have reported data with maturity now based on the 1 year of maintenance. We in the US cannot yet report this data, and we hope to have information, if not by the end of this year, by next year to report. The very fact that we're at a much longer follow-up period than our French partners tells us that maintenance is equalizing the effect in both arms at this point at least. And we will see what this data tells us, but it certainly does support the notion that in selected patients, transplant can certainly be kept potentially in reserve. Now, with that in mind, that leaves us where we are with 4 drug combinations. And as you can see in newly diagnosed myeloma, there are a vast array of them to choose from. And the reason this becomes so important is because this then has a direct implication on what I'm going to spend the rest of my talk on, which is focusing on the construct of where these new 4 drug platforms are going and then what implications these have for relapse. Now, daratumumab combined with RVD and used in transplantation has been shown to be dramatically beneficial. And I especially want to acknowledge the Griffin data, which show this. In particular, data that was presented at ASH, which showed that the combination of RVD and daratumumab after transplantation continued to improve MRD negativity. And this raises a key question that the use of lenalidomide-based therapy with an antibody as part of maintenance can further enhance outcome in the initial treatment setting. The outcomes from this, therefore, then are quite impressive. Now, with that being said, this then leads us to the critical point that we have very high quality response combinations in the upfront setting that can generate with or without transplant rates of MRD negativity that are unprecedented. And with that in mind, and with those maintenance strategies ongoing, what implications does this have when disease recurs? Because obviously, if you will, our upfront platform now reflects multiple new drugs, quadruplets plus maintenance, and therefore the relapse characteristics that we then see will change quite dramatically. But I think the important conclusion from this particular slide is really as follows, that the 4 drug platforms, in my opinion, are really here to stay in the longer term, particularly for our younger patients. And I think the question of where transplant belongs in this paradigm is an incredibly important and interesting one. And whilst I think for sure transplant will retain a position for now in younger patients, I think in the future, I wonder if it will be used far more selectively as we go forward, recognizing that the ability to offer a tailored approach now is quite real. So now let's change gears and talk about relapsed refractory disease. And it was really nice of Heinz to introduce this because I think it's terribly important to see here now how many options we now have. And this, I think, is really important as we think strategically about myeloma, because obviously of old, without many options in the relapse setting, we had to really front load all our best therapy, because if our treatments ultimately would fail our patients, then we didn't have much left anyway, and outcome was fairly poor regardless. That has completely changed. And I think what's so important to recognize is the management of relapse disease now results, if it's effective, in dramatic improvements in long-term outcome and improved and enhanced survival. So when we think about relapsed refractory disease, just here I show the definition of this by IMWG criteria. And I just want to make the point that when you see biochemical progression in the relapse setting, be very careful, because it typically is guilty until proven innocent. Make sure that that's not actually underestimating disease burden. And very importantly, if you start to see aggressive relapse, this needs to be responded to appropriately. And I think this is emphasized by this particular next slide. Clonal evolution in the relapse setting is of particular importance, and this is very relevant because response duration with increasing treatment may in fact diminish with each next line of therapy, but I'm going to show you data now that suggests perhaps in some ways that paradigm is changing. Having said that, we now face the challenge that we not only have resistant disease to proteasome inhibition and IMiDs, but we now face the challenge of resistance to antibodies. And this was initial data that showed that outcomes if you're resistant to daratumumab were particularly poor. This is larger scale information, updates from Shaji Kumar, and at the same time a very nice paper by Dr. Gandhi and colleagues from about a year or two ago in leukemia, showing that once 3 and 4 classes of drugs and 5 classes of drugs have failed a patient, outcomes can be particularly poor. That being said, however, we have, as it were, the tools to meet that challenge. So with that in mind, when should we start treatment for relapse? And I just show this to you because it's a useful schematic to think practically. I would argue that high-risk disease needs to be taken very seriously. This can be explosive and very dangerous and remains a very important part of shortened survival for our myeloma patients more broadly. Also, if you see patients presenting with renal or neurological complications, that's particularly adverse. And of course, a rapid doubling of the end spike is particularly important also. Now, in the United States, we're very fortunate because we have so many options to offer patients that here you can see a number of schematics that basically are adapted from the NCCN guidelines and give you a flavor of what we can offer to our patients in the United States. And I recognize in different healthcare systems, this can vary. Nonetheless, I think there are certain paradigms to think about here. When your patient relapses, are they refractory to lenalidomide or are they not? Is this treatment after multiple relapses or just after one? And when you think about the complexity of these combinations, it's worth remembering that we have triplets and quadruplets that we can meet these challenges with. But I want to emphasize perhaps some underappreciated drug classes that if you have access to them, I'd encourage you to think about. We're going to talk in a minute about pomalidomide and the role that that has had. But also I want to emphasize the histone deacetylase inhibitor class, and in particular panobinostat, which there was a very nice paper from my colleague, Dr. Jacob Laubach, published in Lancet Oncology at the end of last year. And what he basically showed in the Panorama 3 study was a median duration of response of 22 months in relapsed refractory disease to the combination of panobinostat, bortezomib, and dexamethasone. Now, that to me was quite remarkable, and this platform proved in this particular trial much more manageable with the use of subcutaneous bortezomib and appropriate supportive care for some of the GI toxicities that we encounter with panobinostat. But these are the sort of nuances in the relapsed refractory space that can be very helpful. And I'm going to talk in more detail about the other drugs in a moment. Now, in terms of agents available to us in relapsed disease, what trials do we have to guide our choices? Well, I want to first focus on the lenalidomide-based treatments because I know in Lithuania, access to lenalidomide in the relapse setting may be where it's predominantly available to you. Obviously, the combination of lenalidomide with antibodies such as in the daratumumab RD platform has been remarkable. And the Pollux trial led by Thanos Dimopoulos, in which we published in the New England Journal some years ago now, showed a hazard ratio that we were stunned by at 0.37, clearly showing the extraordinary role of daratumumab in that setting. Carfilzomib was obviously remarkable in its efficacy in the relapse setting, and this is where I particularly personally like to use it in first, second relapse. Here, the ASPIRE trial being the pivotal trial that led to carfilzomib's approval with a hazard ratio of 0.69. Then we've obviously recognized the role of elotuzumab, an underappreciated antibody in my view, which in combination with immunomodulatory therapy is particularly valuable. And similarly, ixazomib, an oral proteasome inhibitor, very well tolerated, very effective for the frailer patient, in my opinion, also very useful in the context of the COVID-19 pandemic. And in that setting, we were able to show with tourmaline very nice data for the primary endpoint around PFS. And we're presenting actually at EHA in just a few weeks, updated survival data from that study, which are really quite informative. And that's actually synchronized with a publication that will be coming out in the Journal of Clinical Oncology. So an important therapeutic option there. Now, what about PI-based platforms in the setting of relapse disease? Well, obviously we have pivotal data from CASTOR, led by Antonio Palumbo, in which Antonio showed that the combination of daratumumab and bortezomib were particularly active. It's fascinating, really, because that was, we thought, driven primarily by the apoptotic platform that the monoclonal antibodies provide. But we now have compelling data that there is immunogenic cell death triggered by proteasome inhibition. And this lovely data preclinically presented by my laboratory colleague Anna Maria Guglia at ASH last year. And this may explain some of the remarkable activity that Antonio and his team showed with CASTOR, which was basically that daratumumab, bortezomib, and dexamethasone generated a hazard ratio of 0.39, which we really were struck by. Endeavour was particularly striking as well. The combination of carfilzomib and dexamethasone outperforming bortezomib with a hazard ratio of 0.53, so establishing the role of carfilzomib in the relapse setting. I've already touched on panobinostat. This particular study, Panorama 1, which was actually led by Jesus, and we were all part of as a study team, we were able to demonstrate a hazard ratio here of 0.63 in favor of the triplet over the doublet. And of course, the update from Panorama 3 that I just touched on, I think showing the potential value of this class of drug. And then finally, I'm going to spend a few minutes on the Optimism trial. Now, this, of course, is based on the ability to have access to pomalidomide, but we built the Optimism study with the goal of providing a real-world platform combining pomalidomide with bortezomib and dexamethasone in the relapse setting, and here generated a hazard ratio of 0.61. Now, very importantly, in that trial, we were able to demonstrate in a kind of very real-world setting a comparison between the three drugs versus the two. And I'm going to move a little quickly through this data because I want to spend more time on the newer drugs that we have available in just a moment, to just illustrate the key point that the use of pomalidomide, bortezomib, and dexamethasone, particularly in first relapsed, generated very encouraging PFS benefit in favor of the pomalidomide-based platform over the doublet. And these are the response rates, as you might expect. Quite important to recognize in the intent to treat population that in the relapsed disease, pomalidomide plus bortezomib generated an overall response rate of 82% compared to 50% in the control group. So this was really quite remarkable. So this is the overall summary of the Optimism trial, excellent efficacy data and excellent tolerability data, establishing pomalidomide in the relapse setting in combination with bortezomib as an adequate salvage regimen. Now, I want to spend a little bit more time focusing on the monoclonal antibodies before we then dive into the new drugs and talk a little bit more about the immune platforms that we currently have. Now, first of all, let's talk about targeting CD38 and then SLAMF7. In the context of the CD38 space, the most exciting recent data has come in the form of first the CANDOR trial, combining carfilzomib with daratumumab compared to carfilzomib and dex. And what you can see here is a remarkable median PFS in favor of the triplet. In fact, it's not reached for the median versus 16 months for the control, and a striking difference in response rate, establishing this platform going forward as an important new standard. In the same context, these are the various subgroups, and as you can see, the hazard ratios, in particular in the higher risk groups, are quite remarkably in favor of the three drugs versus the two, but this establishing daratumumab in combination with carfilzomib as an appropriate new standard of care. Similarly, when you combine daratumumab with pomalidomide, and the data here are really striking. This is the Darapom-Dex study from Dr. Achai-Chari that led to the accelerated approval of the Darapom-Dex platform. And in that same context, subsequent work has established the role of this particular platform. This is the 014 study led by David Siegel, in which was demonstrated to be clinically beneficial. And then finally, and most recently, the Apollo trial presented at ASH as an oral session by Thanos Dimopoulos last year. And as you can see here, the phase 3 trial using the subcutaneous form of daratumumab, providing a remarkable PFS benefit in favor of the 3 drugs over the 2. And then, not least, to then follow this with data with isatuximab. Now, you may say, what on earth is the difference between Dara and Isa? Well, isatuximab targets a different epitope to daratumumab and has some important preclinical features that differentiate it from daratumumab preclinically. Quite what this means in the clinical setting remains to be defined. But we do think that there is evidence from both Icaria, and I'm coming in a moment to the Akema trial, suggest a real role for isatuximab, particularly in the relapse setting. And I would argue, especially as daratumumab is used up front, that isatuximab can become a CD38 of choice in the relapse setting going forward. In any event, in the Icaria trial, we were able to demonstrate an important combination benefit to the 3 drugs over the 2, compared, obviously, to the standard at the time, which is Pomdex, still remains so. These data are increasingly showing that perhaps triplets versus doublets are the new standard in the relapse going forward. And in that same context, when you combine carfilzomib with isatuximab, you really see very nice hazard ratios here of 0.531 in favor of the 3 drugs over the 2. And the reason I emphasize this is because I do think that as we think about positioning isatuximab in combination, it may be very important as our CD38 of choice in relapse, because a recent paper just published by Joe McHale in Blood Journal, Cancer Journal, showed that if you, unfortunately, if Dara fails a patient, immediately meeting it with isatuximab, whilst well tolerated, doesn't result in meaningful response. Perhaps not surprisingly, because CD38 has already been targeted and saturated, and the target clearly has been exhausted in that sense. However, in combination, the story may be rather different. So with that in mind, this is just response data and MRD data to illustrate the point. I want to talk about other classes of antibodies. I think elotuzumab is important to remind people of in its availability. SLAMF7 is obviously the activator of natural killer cells, and in combination with lenalidomide, we saw clinical benefit with the ELOQUENT-2 study, and with updated outcomes, that survival benefit became clear. But I also want to bring your attention particularly to ELOQUENT-3. This was a randomized phase 2 comparison of elotuzumab with pomalidomide. And in this trial, we saw striking PFS benefit and OS benefit. So updated survival data of this is cooking, but suffice to say, the results are looking very encouraging. And I would argue that elotuzumab has an important role to play, particularly perhaps in the context of CD38 failure, as well as earlier perhaps, if there is some interest in sequencing drugs around each other. So in the last sort of 15 minutes of conversation this morning or this afternoon, I wanted to focus now on novel targeted drugs for relapsed refractory myeloma and give you a flavor of what's approved, and most importantly, focus on immune strategies, which I think are really transformative now in this setting. And very importantly, as a first sort of look at this, this is from a review last year, it gives you a flavor, I think, of kind of where the field is in relapsed refractory disease. As you can see, it's dominated by the immune therapies. But at the same time, I really want to bring your attention to the fact that there are other agents in the space that may be very relevant, including, we already talked about panobinostat. I want to spend a little time on melflufen, selinexor, venetoclax, and CELMoDs, as well as talk to you about immune therapy, and hopefully be able to do this. And I understand from the organizers, I've got a little time over the next 20 minutes or so. So with this in mind, let's start first with an excursion into new mechanisms of action. As Heinz so kindly pointed out earlier, we've done some work with an entirely new approach through the targeting of XPO1. Now, XPO1 overexpression enables tumor cells, and in particular myeloma, to escape tumor suppressor proteins, and by so doing, obviously, there's a failure of induction of apoptosis, so a key protective mechanism is lost. And XPO1 overexpression correlates clearly with poor prognosis and drug resistance. Now, if you can target and inhibit XPO1, this clearly impacts on pathobiology in myeloma dramatically through 3 core mechanisms. First, there is an increase in nuclear levels and activation of tumor suppressor proteins. And second, and this is very important, there's a trapping of oncoprotein messenger RNA in the nucleus, leading to reduced oncoprotein levels in the cell, in the cytosol. And then also equally important is a retention of the activated glucocorticoid receptor in the nucleus. And this, of course, is particularly important. So how is this translated clinically with the first-in-class XPO1 inhibitor, selinexor, an orally bioavailable agent? Well, a very courageous study was led by my colleague, Dr. Achai Chari. And in STORM, we conducted a phase 2 trial of selinexor combined with low-dose dexamethasone in patients who had a median of 7 prior lines of therapy. They were all penta-refractory. And in fact, this was an exquisitely vulnerable population with essentially end-stage myeloma. In this population, we were able to demonstrate a response rate of 26% with a minimal response or better rate of 39%, including some high-quality responses in 7 patients. Now, this was remarkable and generated an accelerated approval on the strength and basis and the durability of this data. Was published by Achai a year or 2 ago in the New England Journal. Now, to support this observation was a critical next study, which has just been published in the Lancet. This we did in the effort to move selinexor quickly into the combination setting, recognizing that selinexor given twice a week is a very challenging drug from a side effect point of view. If you give it once a week and in combination, the side effect profile dramatically improves. In this regard, the combination of selinexor with bortezomib and dexamethasone compared to the standard of bortezomib and dexamethasone, at least for now, generated a significant FS difference in favor of the 3 drugs over the 2. But a critical point about this trial is that bortezomib in the triplet arm was given weekly, and the dexamethasone dose was also less. So the triplet actually had less bortezomib and less steroid, so it generated far less neuropathy, and at the same time was more efficacious. So this is a very important observation, and again, another courageous trial. I think, however, it's important to recognize that selinexor is a challenging drug to give, and you have to manage it very proactively with the antiemetics and so forth to make it tolerable. But the very good news is, on a weekly schedule at lower dose, between 60 and 80 milligrams, for example, I found in practice this drug to be much better tolerated, and it clearly is very active, particularly in high-risk disease, as illustrated and confirmed in the Boston study. Now, other selinexor combinations are worth mentioning, and this in particular is relevant because selinexor combined with pomalidomide, where selinexor is given at low dose, is particularly of interest, and also similarly combined with carfilzomib, the results are particularly striking. So this is a very important future direction for selinexor as it establishes its place. In my view, it's particularly useful in high-risk disease, and equally interestingly enough, it can be effective in the elderly as long as one's very attentive to side effect management. So changing gears again, I mentioned earlier that targeted therapy in myeloma has been elusive. Well, there is one exception. In translocation 1114 disease, the use of venetoclax has been established, and I especially want to acknowledge Dr. Shaji Kumar and his colleagues who've really been on the forefront of the clinical investigation of venetoclax in this setting. However, there is a cautionary tale here, and it's best illustrated by the Bellini study. In this study, the combination of venetoclax with bortezomib and dexamethasone generated a striking PFS benefit in favor of the triplet over the doublet, but survival inverted for the study overall. And what was very clear is that those patients with 1114 benefited, but those patients who did not have the 1114 translocation actually did worse. And this, I think, is very important. So what you can see here is that if you have 1114 status, your hazard ratios for PFS and survival were striking. Conversely, however, if you were between translocation 1114 negative, literally inverted. So this drug, we hope, will be approved for translocation 1114, and we're working very hard to better understand why in the non-1114 patients, the outcomes were so adverse. Having said that, if you're a BCL2 overexpressor and 1114 positive, clearly you're seeing hazard ratios that are very encouraging for the use of this otherwise well-tolerated oral agent. Now, I want to change gears because a lot of people said to me, well, Paul, you're obviously worried about melphalan, then why are you such a fan of melflufen? Well, I explain why, because I think melphalan's a terrific drug. I would just like to leverage the best of melphalan and leave behind some of the bad stuff. And in that simple spirit, I want to introduce you to melflufen, because melflufen is actually a novel and first-in-class drug in its own right. It's a true peptide drug conjugate. It has a novel mechanism. It is particularly important because it's lipophilic, as opposed to melphalan, which is lipophobic, which is why we have to dose escalate it in the setting of transplantation. But very importantly, with peptide drug conjugates, you've got what I would call a Trojan horse. You're able to get it into the tumor cell, and not only does the warhead do its work against the myeloma directly, but most importantly, by virtue of some clever medicinal chemistry, there is actually an opening of the gates, and more melflufen is delivered into the cell as well. So there's a highly targeted approach to the use of melflufen, and this is reflected in patients by the absence of alopecia and the absence of mucositis. In that context, the clinical benefit that we see is quite striking. Here, as you can see, a response rate in our Horizon study, which we just published and led to FDA approval earlier this year for this approach in triple-class resistant disease. And obviously, there's just been fantastic top-line data just coming from the OCEAN trial, showing this approach to have non-inferiority to Pomdex in relapse. This particular study, the OCEAN study, led by my colleague Peter Sonnefeld. So suffice to say, melflufen, an important new addition, and we think the real money here, as it were, with melflufen will lie, no surprises here, in combination, and the use of these drugs together could be particularly beneficial. So in the last sort of 5 to 10 minutes, I want to finish by giving you a very rapid but hopefully informative look at immune therapy. I'm going to spend some time on CAR T therapy, on bispecific T-cell engagers, talk to you very briefly about antibody drug conjugates, and then conclude by looking at cell mods. Now, I'll move through this quickly in the interest of time, but let's start with antibody drug conjugates. Antibody drug conjugates platform BCMA, and in this context, the use of the belantamab mafodotin or auristatin cytotoxic warhead has been particularly attractive clinically, and this has led first in the DREAM-1 study to some very impressive activity. DREAM-2 study led by Sagalonial, clearly showing the benefit of the 2.5 mg per kg infused every 3 weeks, with a median duration of response of 11 months and an encouraging response rate at around 30%. But the challenge is the keratopathy. And so the new direction here will be in combinations. And in that regard, the ability to reduce dose of belantamab mafodotin to minimize keratopathy and synergize with other drugs will be critical. And pomalidomide may be just one such solution. Wonderful data from Suzanne Trudell, where she was able to demonstrate a response rate approaching 100% for the combination in relapsed refractory disease with a VGPR rate of over 2/3, which I think is quite remarkable. Now, what about BiTEs? BiTEs have been, I think, the toast of ASH, I think it's fair to say, last year, and they remain an incredibly exciting platform. Obviously, there's a bispecific nature to T-cell engagement with the BCMA target predominating, but the really good news is that there are more targets, and this, I think, is critical, because once we've failed in terms of targeting BCMA for our patient, we have to have other ones that we can reach for. And the good news is there's terrific data in this regard. This is some BCMA work. Again, in the interest of time, it's all presented. I'll move through it very quickly, but look at this response rates, 80% with very high quality responses. And these are in relapsed refractory patients. So really amazing results. And yet more follows. There are numerous options in this platform with numerous different combinations available. And again, this ability to use the off-the-shelf approach. I do want to emphasize the new targets beyond BCMA. I think these are particularly attractive. And in this regard, we're seeing really nice response rates. And Achai Chari presented a wonderful presentation at ASH using this particular platform with very high quality responses seen in very refractory therapies. Now, what about CAR T therapy? Well, obviously game changers in leukemia, game changers in lymphoma. In myeloma, I believe it is a game changer. I think we've got a bit of work to do, however. And in that context, I'm particularly encouraged by the very recent approval of ide-cel, led by my colleague Nikhil Munshi and just published in the New England Journal. And as you can see here, remarkable response rates and generally manageable toxicities, although CRS is clearly a challenge that we need to better understand. And this is actually from Nikhil's data, and I'm very grateful to Nikhil for providing me with this slide. And as I've emphasized just now, FDA approved on the basis of these PFS data and the high quality responses seen that are dose dependent. Now, really interestingly, it's important to note that we need to obviously maintain these responses. But nonetheless, in this extraordinarily, I think, encouraging phase 2 trial, we see in selected patients an extraordinary outcome in terms of PFS, and most importantly, we see encouraging median overall survival at 19 months. Now, it's important to recognize this is a relapse refractory population who are triple class refractory. So really the relapse space is dramatically changing, and this is very important. And the good news is there's lots more to come. Beyond ide-cel, new exciting technologies being developed that are going forward. We're seeing remarkably high response rates with these new platforms. This is just one representative example. And so when we think of what's next for cellular therapy, it's really remarkable. Novel constructs, suicide genes, NK CARs, and others. I mean, it's quite extraordinary to me. Don't consider myself in any way a CAR T expert, so I defer to brilliant colleagues in this space. But having said that, I think this represents an absolutely dramatic new frontier. But I do want to emphasize we need durability from these approaches. And one such approach might come from an entirely new strategy, cell mods. Now, cell mods are in the protein degradation space. They are the highly targeted ability to degrade Icaros and ALOS, and they do so at magnitudes of difference compared to the immunomodulators. And you can see this as illustrated here. This is iberdomide, beautiful work preclinically that led to the pivotal phase 2 work led by Sagalonial. And what you can see here in triple class refractory disease is a response rate just from a pill, 3 weeks on, 1 week off, of 30% with excellent tolerability. Now, what's really interesting is that when you then combine this with other drugs, even in the refractory setting, seeing responses, despite the fact that these patients are refractory to bortezomib and daratumumab, you're seeing responses that are very encouraging, recognizing that this is early. Now, 480 is even more powerful than iberdomide. Iberdomide is 220, 480 is a step forward. And as you can see here, the ALOS degradation efficiency is dramatic. Apoptosis induction kinetics are formidable. And when you combine the drug into model systems of lenalidomide and POM resistance, it's uniquely consistent in its ability to overdrive resistance. Our first data with 480 have been very encouraging. We've performed a phase 1 into a phase 2 and established a recommended phase 2 dose, 3 weeks on of a 1 milligram tablet, 1 week off. Very simple and easy to give, dexamethasone as its partner. In triple class resistant disease, 55% response rate, the pill. And in that same context, if you look at very high risk disease, this is one of our patients in the study, you can see extramedullary disease in this patient's liver. This image actually is courtesy of the patient's physician, Dr. Nizar Balisi, who's one of my superb partners in this trial. And as you can see, after 3 cycles of 480, oral therapy, complete remission. So this is remarkable and quite unprecedented. So my conclusions are here. The integration and impact of novel agents in myeloma therapy have completely transformed the landscape. Immune function, I think, is a new barrier that we are now overcoming meaningfully. And I think we have an array of options that we can use. And new insights to mechanisms of drug action are further expanding our ability to truly provide functional disease control for decades for some of our patients. And I think that's an incredibly important conclusion. And in that same context, the further refinement of prognostics, immune profile, and MRD will arguably guide therapy going forward. I want to close, if I may, with one last pictorial. Oh, I'm sorry. I apologize. I think I've got through here. Let me just try and get back if I can. I'm sorry. Sorry, the seemingly lost the platform there for a second. I don't know if this will let me do it. Just an important thing I wanted to drive back to. Sorry. Hello? I'm sorry, guys, I can't go. I was simply going to say there was just one last. Oh, here we are. This is simply, I won't dwell on this. This just describes a journey of a patient in a new era of novel therapies. It's just a beautiful story of the efficacy of Dara in the setting and just how this patient has done remarkably well with this approach. But in the interest of time, I want to get to the next slide, which is this one. And I'm so sorry, Heinz, if I may. Oops, it's jumping around on me. Sorry about this. My fault hit entirely. This was my final slide, just to say thank you very much, and I really appreciate your time. Thank you.
Thank you, Paul. This was probably surely the highlight of this meeting, of this symposium. An excellent lecture on the present status of management of patients with myeloma. with a special emphasis of novel developments. Fantastic. But I'm sure there are several questions. At this point of time, there are no questions from the audience, but maybe if you have still some minutes available, there are some pertinent questions which are relevant for clinical practice, for instance. What about maintenance therapy? Maintenance therapy, let's put it, maintenance therapy with LEN should be done until progression or intolerance, but you will show whether that is really needed, because IFM done a Tava Cancer Center study has two arms, namely one with maintenance therapy limited for 2 years, and you will run the study with maintenance therapy indefinitely. So what is your guess? Do you have any guess at this point of time?
Oh yes, well, thank you, Heinz, and it's a great opportunity because we have a good 10 more minutes. We could go through these. It's brilliant. I think we do have clear evidence that maintenance until progression is resulting in a superior outcome from other studies. But in our own work, the French study stopped maintenance at 1 year. And then in our trial, which is directly parallel to the French study, we continued until progression. Now, in our trial, we cannot report you data yet, even though we've been going for 10 years and our median follow-up is way in excess of 5 years. So that tells you we're not meeting our primary endpoint for survival or PFS, and that tells you that maintenance until progression is making a very big difference. Now, obviously, we'll have the data hopefully by the end of this year, if not beginning of next. I think beginning of next is probably when we'll report it. I suspect we'll have data to report hopefully at ASCO next year. But the very fact that we're in 2022 reporting on a study that started in 2010, I think we will show, Heinz, that maintenance until progression makes an enormous difference. And the ability to give maintenance that's uninterrupted is important, because what I can tell you is that on the transplant arm, we've seen more dose reductions and we've seen more infections. And that has led to more discontinuations or interruptions. On the non-transplant early on, we've been able to dose continuously much more consistently. What's so interesting is that the PFS endpoint is built around a primary endpoint of a 9-month improvement in progression-free survival in favor of transplant. What I can tell you right now is we've not made that. So the fact that we're not there yet tells you something. And I think what it tells you is the power of maintenance is huge. So if a patient is not going to transplant, for example, for whatever reason, I would advocate to clinicians, please do not unmaintain their remission because clearly the data support that. Now, obviously that's predicated on tolerability as well. And what we can say from a tolerability point of view is that we have not seen the same kind of worry around second primary cancers that had been a worry 10 years ago from lenalidomide. It's real, that's for sure, but it's a very small number. And what we do see is that there's more AML MDS with the melphalan exposed patients than with the not, but it's a very small number. Now, the good question here is, well, what about other data? Because other data sets are suggesting that there's long-term MDS and AML that pops up with longer follow-up from other trials, and I think that's very true. So I think we have to be careful about that, but I don't think it's a dramatic change to what we observed previously, but it's a consistent change that appears not to diminish over time. So I think, Heinz, that's why we need to think very carefully about how we will in the future use high-dose melphalan, because at the end of the day, if our patients are living 20 years and maintenance is making all the difference, we have to then say, well, how can we protect patients who may be at risk of MDS AML, and at the same time, in those patients who don't need high-dose melphalan, we can spare them that, but there are definitely those patients, in my view, who do. And that's the interesting group, Heinz. That's the group of patients in whom we need to target stemness, and we need to do that effectively because in high-risk disease, they can truly explode and become unmanageable very quickly. So I think there's definitely a role for the high-dose melphalan. There's definitely a role to think about how we position it. And then I would suggest to you that high-dose melphalan achieves this targeting of stemness, Heinz. Are there better ways of doing that? Is, for example, melflufen an option, or a melflufen-like approach an option to do that? Or are there other strategies such as BCMA, BiTEs, CAR-T that we should be bringing much earlier to deal with this question?
But coming back to the continued maintenance approach, isn't it very likely that you will experience or see the same, let's say, results as have been obtained in the first study, showing that patients with excellent response benefited most from continued therapy? So if you have a very good remission, a very deep response, probably you will benefit from prolonged maintenance therapy. But if your response status is less favorable, let's say only partial response, those patients probably, at least when you go to the first study results, probably are not likely to benefit so much than the excellent responders from maintenance.
That's a great question, Heis. I appreciate you raising it, because in the Griffin trial, we've shown that with maintenance, response improves over time. And especially now as we're looking at better forms of maintenance, in other words, maintenance that go beyond just lenalidomide alone. For example, lenalidomide combined with a proteasome inhibitor, and now most importantly, lenalidomide combined with monoclonal antibody therapy. As we're looking at these, those approaches are now taking us to a new spot in terms of efficacy. For example, in the Griffin trial, the MRD negativity over the first year of daratumumab and lenalidomide increased significantly, irrespective of the transplant effect. So this is, I think, really interesting data, because it tells you that maintenance and continuous therapy is an area we should continue to really explore, not simply just as a continuation of prior therapy, but as a means of overcoming resistance and targeting clones of disease that may have escaped that initial induction remission phase.
Just a few brief questions, hopefully with brief answers, because probably we need to stop at some point of time. So just one question, because of the MRD hype, MRD, minimal residual disease negativity. So if the patient is not in MRD negative status, let's say after 1 year of therapy, is it really useful to continue the same treatment forever? Isn't it very unlikely that this very patient does not benefit from additional therapy unless you change the treatment protocol?
Well, it's such a good question. And I think, frankly, this is the important point about understanding how your drugs work. Immunomodulatory therapy is immune therapy, and you see a continuum of benefit over time. So I love to use MRD in the context of research. I think that's very appropriate. As a tool that I use at the bedside in the clinic, I'm very careful, because I have many patients, and I'm sure you do too, Heinz, who are VGPRs, who have a small amount of M protein, and you maintain them on a lenalidomide-based platform, and they do well for a decade. And then I have patients in whom I strive for MRD negativity, achieve it, and then within 6 months to a year, they explode, and I lose them within a year. So I think it's a complicated question. I personally think that immunomodulatory therapy as a backbone of maintenance is key, and then you can add to it judiciously with appropriate strategies. For example, I have patients who are translocation 11-14 positive. They don't want intensive therapy, especially during the pandemic. This has been critical to use outpatient oral therapies. And because we're able to in the United States, I've had patients on lenalidomide and bortezomib maintenance doing very well, and their M protein has clicked back a little bit. We've dropped in venetoclax, for example. They've done very well, and they've gone back into complete remission. So there are lots of ways of strategizing this. I think the important way to think about it is to not be kind of one size fits all, because the bottom line is that we need to have the ability to tailor therapy for our patients, and we now have the tools to do it.
So now we have established that 4 drug combinations are probably the optimal induction therapy for young transplant-eligible patients, meaning a 3-drug combo plus an antibody. But now, isn't it time to include cellular therapy in first-line therapy in order to exploit everything what we have, because we want to win the war and not the battle?
Exactly. So the question is, do we have the evidence to support that? And I think that that is the new direction to explore. Absolutely. I think we have to just be a little bit careful, because at the end of the day, CAR T therapy isn't without its toxicities. There are neurological toxicities that are acute, and there may in fact be toxicities in the longer term that we need to be aware of. Having said that, I think the promise around cellular therapy is bringing it early for exactly the reasons you allude to. So I think if we can deploy CAR-T safely early, and I believe we probably can, this will be a whole new direction. And then the next question would be whether or not we can use other strategies such as bispecific T-cell engagers, and can we also, as a more off-the-shelf type approach, and also we have to be a little bit careful here because cost matters, doesn't it? And I think at the end of the day, these are very expensive platforms. So we have to be very thoughtful about how we deploy in various healthcare systems what we do.
Paul, I'm afraid we need to stop here. Also, I would like to continue this discussion and learn from your experience and your intelligent, let's say, approach to myeloma management, which is very important to exploit everything and for the benefit of our patients. I think this was a real highlight of this meeting. And on behalf of my co-chair, Professor Len Nietzsche, I would like to thank you for this outstanding presentation, very outstanding. Thanks so much. I would like to thank our attendees for listening to this presentation for quite some time. And there's good news. You have now 15 times for the relaxation. You can take your coffee, but the meeting continues after a 15-minute break. Please come back. The next session will be, I think, on stem cell, probably stem cell transplantation anyway. So it will be an interesting session. Please come back in 15 minutes. And again, applause to Paul for this presentation. Thank you very much. And
thank you very much.
Thank you. And I assume you go back to your clinic now, Paul.
Thank you, Sandra. Thank you so much. Thank you, guys. Bye-bye. Bye-bye. Wonderful. Thank you. Thank you very much.
Okay, so we probably can start. Hello, everybody. On behalf of Professor Dirger Niederwieser and myself, I would like to welcome everybody for this last session of the excellent meeting on hematology and oncology, held for the 6th time in Kaunas, Lithuania. And we have changed a little bit program. So the first speaker of today will be Dr. Ruta Dombrowskiene from Kaunas. Ruta normally works on primarily on myeloproliferative neoplasms, but today she will lecture us on the experience on autologous hematopoietic cell transplantation in lymphoma in Kaunas. Ruta, the floor is yours.
Thank you very much for so nice introduction about me, and it's a great opportunity to present our simple data about lymphoma patients. It will look a little bit simple compared with all other presentations today that were so impressive, but we started lymphoma transplantation 2 years later than multiple myeloma. It was in 2017, and we transplanted 17 patients. I will start with a few slides with introduction. Autologous hematopoietic stem cell transplantation, according to bone marrow transplantation registries, accounts about 58% of all transplantation in Europe and similar percentage worldwide. And almost half of these transplantations are for multiple myeloma patients, 30% for autologous for non-Hodgkin's lymphoma, about 11% for Hodgkin's lymphoma, and the least part, only 3% for leukemias patients. High-dose chemotherapy and autologous transplantation for lymphoma treatment are mentioned in the literature in 1959 and 1960, so we a little bit late for this treatment modality, but we will still are happy to have this possibility in our hospital for our patients here in Kaunas. Chemotherapy remains the first-line standard of care for aggressive lymphomas, and about 20 to 30% of patients with non-Hodgkin's lymphoma will not be able to achieve a complete remission with standard induction, like CHOP chemotherapy, and about 5 to 10% of Hodgkin's lymphoma patients are primary refractory, or about 10 and 30% of Hodgkin's lymphoma patients relapse after achieving an initial complete remission despite the highly active frontline treatment. So during these 4 years, from 2017 the data was in this at the end of 20s, we transplanted 17 patients, and the median age of these patients were almost 52 years. The youngest patient was 18 years and the oldest 66. We have almost double more male patients than female patients. And looking at lymphoma types, almost half of all lymphoma patients were diffuse large B-cell lymphomas, as you can see here in the chart. 29.4% were diffuse large B-cell lymphoma CNS patients, and 17.6% diffuse large B-cell lymphoma patients. So these are the most frequent lymphomas type in our sample. And the second most frequent mantle cell lymphomas, 3 patients, 2 patients with anaplastic T-cell lymphoma, and each 1 patient for small lymphocytic lymphoma, angioimmunoblastic lymphoma, and peripheral T-cell lymphoma. According to lymphoma stages, 58% of patients, 7 patients were in the 4th stage in the disease, and 41.7 with the 3rd stage of the disease. Disease status before autologous transplantation, 51.2% of patients were in first complete remission. 1 patient was in second complete remission, 29.5%. 4 patients were in first partial remission, and 29.4% patients were in partial remission, second partial remission. And these patients who were in complete remission first, first complete remission, were mantle cell lymphoma patients, were anaplastic T-cell lymphoma patients, 1 patient with CNS diffuse large B-cell lymphoma, and 1 patient with peripheral T-cell lymphoma. Patients with second complete remission, 1 patient with angioimmunoblastic T-cell lymphoma, 3 patients with CNS diffuse large B-cell lymphoma were in partial remission, first partial remission, and 1 patient with follicular lymphoma. And 3 patients were in second partial remission with diffuse large B-cell lymphoma, and 1 patient with small lymphocytic lymphoma and CNS lymphoma patient. So most of them were in complete remission first, and median time from diagnosis to transplantation was 17 months in the range of 3 to 65. First line treatment and as consolidation was for 10 patients, 58.8%, and as a salvage treatment, it was for 7 patients. Conditioning protocols, most of conditioning protocols were with or without rituximab and beam chemotherapy, and for rest 5 patients were carmustine for patients who were with CNS diffuse large B-cell lymphoma. Disease status after autologous transplantation, 88.2% of patients were in complete remission, and 2 patients were in partial remission, 1 patient with peripheral T-cell lymphoma and 1 patient with CNS diffuse large B-cell lymphoma. Median CD34 was 9.15 millions per kilo in a range of 2.2 to 33. And white blood cell engraftment, leukocyte engraftment mean was the 10th day. So compared to, for example, I looked at Rolanda's lecture with multiple myeloma patient, we had median was in 14 days, so a little bit earlier leukocyte recovery, and platelet engraftment mean was the 13th day. We had a few complications. The most frequent from them were bacteremia for 29% of patients. Most of them, 4 of them, had staphylococcus infection, epidermidis. 1 patient had both staphylococcus, epidermidis, and hominis. 1 patient E. coli, and 1 patient pseudomonas. 1 patient with septicemia, and 1 patient with fungal pneumonia, 1 with Clostridia difficile infection, 2 patients with bacteriuria, and 1 patient with neck cyst infection. Our overall survival curve, I understand that this is maybe too less to the patients, and sample is only 17 patients, but nevertheless, median overall survival is not reached, and 4 years overall survival is 94%, and median event-free survival is 40 months. We had 5 patients who experienced events, and 4 of them had disease progression, and then they responded to salvage treatment. At the moment, they are in complete or partial remission, and we lost 1 patient because of disease progression. So my conclusion from this small analysis of our patients, that autologous transplantation for lymphoma patients is feasible and effective as a consolidation as well as salvage treatment. Complications are manageable, and of course we need more data, more patients for overall survival analysis. And I want to share my few photos from the very first patient transplantation that was in 2015. This was the first patient with multiple myeloma, UPN number 1, and the most difficult job was for our medical biologists that should bring these cells in such big bucket with nitrogen And of course, at the meantime, we have improved, and now we are improving. So thank you for your attention, and I will be ready to answer your questions.
Thank you very much, Ruta. I have one short question at the beginning. Essentially, the question hinges, what is the protocol that you have been using as bridging treatment prior transplantation?
Prior transplantation, of course, they are different on lymphomas type. For T-cell lymphomas, we used CHOEP with etoposide. For diffuse B-cell lymphoma that were relapsed, we used our rituximab with DHAP. And for CNS lymphomas, we used the matrix protocol with tiotepa. And I think for what else was small lymphocytic lymphoma, R-CHOP was for these. So these are pretty different protocols, but I didn't show this in details because pretty small sample of the patients.
Yes, I definitely need to congratulate you on this result, because they are really excellent, particularly that there was not very big, but still considerable group of patients with central nervous system involvement, which is, of course, a group of very risky patients, and I believe that this they were conditioned with calmustine, I believe, yes.
Correct. Yes.
So this was probably the factor. Didger, can you comment on this actually? On this management of this patients with central nervous system involvement?
Yes, these were patients which we treated according to a protocol of the OSHO, and I think this was the only chance, because they were not actually getting in remission with the usual chemotherapy, and some of them were in complete remission. But I think we are happy with the results, because they turned to be in complete remission after autologous transplant.
Yeah, okay, so thank you very much. I will now hand chair to Didger, Professor Didger Niederwieser, to introduce the next speaker. Please, Didger.
Yeah, so I'm happy to introduce Jaroslav Bilinski. Jaroslav is working at the Department of Hematology, Transplantation and Internal Medicine at the Medical University of Warsaw, and he is CEO and founder of Human Biome Institute. So he is already known because of his work on the biome and on an interesting question, which is dealing about the fecal microbiota transplantation as a novel approach to treat steroid-resistant graft versus host disease. So thank you for joining, Jaroslav, and you have the stage.
Yeah, hello. Thank you, chairs, for inviting me. Thanks to the organizers for inviting me to this distinguished conference. And yes, today I will talk about some novel topic about fecal microbiota transplantation as a approach to treat the steroid-resistant graft versus host disease. So when we look generally at the population of patients with oncohematological diseases undergoing allogenic transplantation, we could see that the relapse is attributable to about 55% of deaths after allo-HCT, and the infection and graft versus host disease is about 45%. And as the relapses are decreasing, the infection and graft versus host disease increases during last years. Globally, of course, in numbers, the incidence of acute graft versus host disease has decreased. And according to EBMT and CIBMTR, we can say now about 35 to 80% of the incidence of graft versus host disease. And the grade 3 to 4 acute graft versus host disease has decreased from about 56% in the mid-20s in 2000 years, and about 12 years after, we have about 37% of incidence of severe graft versus host disease. However, the proportion of the gut acute graft versus host disease has increased during last years to 62% in all the cohort of acute graft versus host disease. And what we know now about the second, as we say right now, organ being immunological organ as the gut is, because we have to imagine that 80% of our lymphocytes are located temporarily or for a long time in the guts, in the gut-associated lymphoid tissue, and they're stimulates in our guts. So we need to look at the gut microbiota to reveal some of the immunological phenomena and on the infectious diseases, as the our guts is the colonization place for pathogens, and most of all the translocation to blood and other sites are from the guts. So when we look at this picture, we can see that about from the start, from the conditioning regimen, the gut intestinal diversity of microbiota radically decreases, being the lowest about 10-20 days after the transplantation. And when we look at the composition of the gut microbiota by the sequencing, next generation sequencing, we can see and we can divide the patients with the lower diversity of gut microbiota, intermediate or high diversity of microbiota. And look at this graph, and when we see the proportion of surviving after the stem cell transplantation in the higher diversity of microbiota, after 24 months is about 75%. The lower diversity microbiota group has survival about 50%, and this is attributable to the cumulative incidence of transplant-related mortality, but not relapse. The relapses in this group are the same, but the lower diversity microbiota group has higher transplant-related mortality. And we have performed our studies beginning in 2014-15, and we looked at the colonization of the guts before the allogenic transplantation with antibiotic-resistant bacteria. And what we saw that colonized patients, after 24 months of the transplantation, the colonized group had over 2 times lower overall survival, only 34%, compared to the non-colonized with guts antibiotic-resistant bacteria group, which lived in 74% after 2 years of observation. So the colonization was correlated with over 2 times lower survival in this patient. And what we saw the same results, that colonization and non-colonized patients had the same rate of relapses. However, the non-relapse mortality were different. The colonized group had a really higher non-relapse mortality, which means infectious and graft versus host disease deaths. And we saw significantly more often positive blood cultures in this group. And what was our not so expected finding, that they had more often clinically relevant acute graft versus host disease and more often gut graft versus host disease. And the colonization was the only factor in the multivariate analysis correlated to the deaths after the transplantation. So we can imagine that the broad spectrum antibiotics used in the transplant regimen after the neutropenia causes the loss of the commensal bacteria, loss of the antibiotic antimicrobial peptides, which leads to the dysbiosis, which means the improper gut microbiota, which, as we can see here, can predict the acute graft versus host disease. So looking at the gut microbiota, we can predict the intestinal acute graft versus host disease after the stem cell transplantation. And the Regensburg group showed very important data that using antibiotics before day -1, so using antibiotics as a prophylaxis of infection treatment before the transplantation really caused a really high probability of transplant-related mortality. So no antibiotics group before and after stem cell transplantations has transplant-related mortality about 5 to 10%, but antibiotics-treated group from 30 to 50%. So as we may know, of course, the incidence of the graft versus host disease or the infection is the cause of the transplant-related mortality. The antibiotics and the gut microbiota disruption can lead to the clinically relevant GVHD and infections. And what is the most important day or time for looking at the microbiota after transplantation? One group of researchers showed that the neutrophil recovery is the predictive moment for severe acute graft versus host disease after HCT, because neutrophil recovery, neutrophil engraftment is the moment when our immune competent cells interacts with gut microbiota in the gut or mouth and stimulate. So the gut neutrophil, the neutrophil recovery moment is the most important moment to have really good gut microbiota, and if not, it predicts the severe acute graft versus host disease. And during last years, the fecal microbiota transplantations have evolved from treatment of Clostridioides difficile infection to the treatment of other diseases, gastrointestinal and non-gastrointestinal, also in the treatment of graft versus host disease. And there are published several works, 5 papers with some patients, about 50, 60 performed of FMTs in these patients, and we can see that the response rate to the fecal microbiota transplantation to treat the graft versus host disease as immune modulation has really great responses, only from 50 to 75% of complete responses. And our group also is one of the first in the world which performed the fecal microbiota transplantations in the group of graft versus host disease. We have now more than 15 patients, 17 probably patients treated with acute graft versus host disease with FMT. And our overall response rate is 57%, and we achieved CRs, complete responses, in 42% of patients. So 42% of patients with steroid-resistant or steroid-dependent graft versus host disease, which has very fatal and poor prognosis because 70% of these patients dies within a year, had CR. So probably we could preserve the lives of this patient in 42% of patients. And what we see in the responsive patients to the FMT, we saw statistically significant percent of survival in these patients. And this has also some adverse events, and we could show clearly that if we perform the FMT too late, so when the gut is damaged, we can have more adverse events, and the ECOG group higher than 2, so the severe status of the patient is the significant prognostic factors of possible adverse events after FMT. However, really, this is really a safe procedure, even if such a group of patients as immune suppression patients. And what we have now, and we are publishing the paper with another evolvement on our approach to the GVHD patients, and we combine ruxolitinib, which has published in 2020, first after a long time works and paper suggesting that ruxolitinib works in acute graft versus host disease in patients steroid resistant. And the second most emerging treatment is FMT in our opinion. So we combine ruxolitinib with FMT right now in sessions of 3 FMTs or repeated every 3 FMTs. And we have excellent results even in very severe cases of graft versus host disease. The last 3 and 4 case was really severe, with over 20 stools per day, with very severe performance status, and after implementation of Ruxo and FMTs, they obtained complete remissions, are now very stable. So this is an emerging option, and I think we need to think about the clinical trials with Ruxo and FMT to show the efficacy of such treatment. Thank you.
So thank you so much for this very interesting presentation. Are there any questions? Please use the chat module. Let me start by asking you, do you know which kind of bacteria are the one, or do you have a special spectrum of bacteria in the GVH patients before treatment?
Yes, it was found that there is some specific groups of bacteria correlating with also GVHD and correlating with the success of treatment of GVHD. And I can name it. It's, for example, Blautia et al. It means that the anaerobic bacteria, which are the most important producers of the short-chain fatty acids, which are also the epigenetic factors and which can cause the preservation of the gut, is the most important. And some antibiotics like piptazo, for example, kills the most important bacteria. And it was shown also by the German group of Professor Holler that the piptazo and imipenem are the worst correlation with GVHD, because it kills some good gut bacteria. So it is something which we can see. We need more data, but we know now that preserving gut microbiota can preserve the patients from the GVHD.
Okay, thank you. I don't see. Question, what about FMT in patients with active CMV infection? Do we need to treat CMV first?
Yeah, very good question. We do not have such more data about such patients, but we know that there is something like gut-lung axis when our guts control the immune process, even if we have some other sites than the gut. So I think that we need to start treat CMV, and in the same time we can perform FMT, because proper colonization of the gut microbiota with normal gut flora can enhance the resistance to the CMV infection.
And these are all histological proven GVH, correct?
We do not have data with CMV and FMT, so I don't know, but it's I think it is emerging treatment, so maybe we will know in short moments.
Okay. Good. So thank you so much, Dr. Belinsky.
Thank you very much.
For sharing the data, and I hand over to Wieslaw again.
Yeah, thank you very much. Our next speaker is Dr. Domas Wojciekus from Kaunas. He is head of hematopoietic stem cell transplant sector in Kaunas University, and he will lecture us on low-dose TBI conditioning, HCST, for severe aplastic anemia. Domas, this is your turn.
Thank you so much for the kind invitation and possibility to present our data, very little data, but quite interesting data. Firstly, I would like to thank my co-authors who helped for me to prepare this presentation. Very shortly about our hospital. It's the largest hospital in Lithuania. We have more than 2,300 beds. Our unit of transplant has 11 beds with the HEPA filtration. In our hospital works 1,300 doctors, more than 2,000 nurses. We have 9 intensive care units, 2 emergency rooms, so it's a huge hospital. And since 2015, we have started performing hematopoietic stem cell transplants and autologous. And last year, during the pandemic and lockdown, we managed to start allogenic transplant program. So mainly, we have done transplant for the multiple myeloma patients. It's most of our patients. And till today, actually, we have done already 12 allogenic transplants. We are the only center in Lithuania that are able to perform total body radiation. We are doing low-dose TBI and also myeloablative TBI with any need of doses, with a very sophisticated dose calculation and realization. So you can see our transplant activity is increasing. We had a little bit plateau during the lockdown, but we didn't decrease our activity. And this year we don't have a half a year, but we are doing better than last year and increasing with the numbers of transplants. Most of our patients are multiple myeloma. Just very shortly, you have already seen this slide. So our survival of patients with multiple myeloma after transplant is quite good and comparable with the data from the literature. So about severe aplastic anemia. There is a general rule that the patient younger than 40 years old who has a sibling donor and the diagnosis of severe aplastic anemia should undergo hematopoietic stem cell transplantation. So that's quite clear, and nobody asks what is the treatment plan for this kind of patients. But there is a patient who has no siblings and are older. So standard of care is ATG with cyclosporin, but there is part of the patients who are refractory for this treatment, and then we have a lot of problems with these patients. For younger patients, usually it's younger than 30 years old, we can try to do unrelated bone marrow transplantation if we have a matched donor. But in other cases, the new standard of care is L-Trombopac and no major breakthrough was done for the treatment of these patients. There have been many trials to incorporate many other substances for treatment of these patients, but none of these has made a breakthrough, and there's still a standard of care that I already showed you in the previous slide. So first line treatment, what we have now in 2021, for the younger patients with the siblings, it's a transplant. For other ones, ATG with cyclosporin and L-Trombopac would be a quite good option in this setting. But for the refractory patients, there's always a problems. Who are younger and have a matched donor, there is a possibility of cure with the transplant. And L-Trombopac, the new treatment options could be also considered. But maybe there is more options for these patients. And what we have done, and I would like to present that case. It's a non-myeloablative transplantation with 2 or 3 grays total body radiation with fludarabine. So, as you see, prognosis for the patients after transplant vary depending on the age of the patients. From this nice EBMT study, we can see that the patients who are younger than 20 years old, sibling transplant has a great outcomes. But for the patients who are older than 40, transplants, even after sibling donor, survival is not very encouraging, and it's only 55%. So, our case. We had a 51 years old male who was diagnosed with severe aplastic anemia in 2020 February. He was diagnosed by criteria of Comita. He had normal karyotype, and also we found a positive immunoglobulin G folk parvovirus. Patient was treated with prednisolone, cyclosporin, ATG, intravenous immunoglobulins, but he had no response for this treatment. Until he reached the transplant, he was already received about 45 units of red blood cells and about 30 units of platelets. You can see the picture of the diagnostic, one of the first bone marrow biopsies, then in which you can see that the bone marrow is aplastic. But in 2020 October, patient had COVID, and it was the biggest problem for them because COVID was very severe for him. He was in a critical condition. There was major damage to his lungs. Patient also had complication with the bacterial and fungal superinfection. He was treated with the remdesivir, broad-spectrum antibiotics, many antibiotics, fungal medication, and also he needed high-flow oxygen therapy. And somehow he succeeded with the COVID, and after repeating 2 PCR tests, and they were negative, patient at the end of November was admitted to our department, hematology department, transplant ward, and we also were very happy that we found that he developed immunity against COVID-19. He got IgG, and his condition was a little bit improving, and he was allocated for the bone marrow transplant. Here you can see the CT scan, which was done at the end of the COVID infection, so it was a little bit, not a little bit actually, it was much better than there was a most severe CT scan. And after the transplant and all the period of that, his CT scan was much better. What was approach taken for this patient? We used non-myeloablative conditioning. We gave him 3 grays of total body radiation with fludarabine, 90 milligrams per square meter. The donor was also not a young one. He had a brother. He was 16 years old. He was HLA identical. We checked the leukocyte Kreuz match, and he didn't have any anti-HLA antibodies, despite many transfusions he had before the transplant. We didn't apheresis. It was not the easiest one for the harvesting cells. We needed 2 apheresis. We harvested 3.2 CD34 cells per kilogram per recipient, and also because it was non-myeloablative transplant, we collected additionally lymphocytes to maintain more than 3 times 6 CD3 positive cells in the graft. And just after New Year, in January 5th, we did a bone marrow transplantation, and it was very joyful for us actually that period of the post-transplant period was very uneventful, and it was very smooth without major complications. So here you see from this slide, the day of transplant, he started to become independent from the platelets transfusion about 3 weeks after that, and also erythrocytes transfusion independent also about 3 weeks after that. Leukocytes engrafted in a little bit more than 2 weeks after the transplant. And the chimerismus test that we have done in March, it was 95% of donor CD3 leukocytes. And the bone marrow picture, just most recent picture of his bone marrow. Now we have a cells, it's not anymore aplastic. So this patient is in remission despite his very, very complicated path of his disease. So what we know about non-myeloablative conditioning for severe aplastic anemia, what we have find out that it's about 11 patients has received this approach in severe aplastic anemia. Age is ranging from 30 till 78 years old during the transplant, and they all were given total body irradiation with fludarabine. We have data, very scattered data from the USA. From Seattle, they have 6 patients who received unrelated donor. 5 of them got 3 grays, 1 of them got 2 grays TBI, and all get fludarabine 90 milligrams. And we know that there were no treatment-related mortality, 100% engraftment, and survival at 3 years also was 100%. There is some data from Kaunas, from our patient, and also few patients from Leipzig, from Germany. So what can we see that there were a few patients from Leipzig with much unrelated donors. Conditioning was more prominent in Germany, 2 grays. Reasons for the reduced intensity non-myeloablative transplant approach, it was age. One of the patients was 63 years old at the time of transplant. Another one, the oldest one, is 78 years old. So it's very elderly person with a transplant. And the survival is a day to day. Our patients is 133 days after transplant, and we have no rejection, no GVHD, no major complication, and we have remission in the severe aplastic anemia. Other patients from the Leipzig, survival is 38 months we have, another patient 77 months, and the oldest one patient with the 70 years old, he was survival is 33 months. So it's quite dramatic improved in the prognosis for these patients who are not able to tolerate the standard and classic conditioning for the severe aplastic anemia. So non-myeloablative conditioning with the 2 or 3 grays total irradiation allograft is feasible, and also in a heavily transfused patients with the comorbidities and with the excellent treatment-related mortality profile and long-term survival. So thank you so much from Kaunas team, and I'm happy to answer any questions if we have.
Thank you very much, Thomas, for excellent presentation. We do not have much time, but one short question is whether do you have access to a horse ATG in Lithuania? Because my impression is we do not have right now, and my experience is that actually effects with rabbit ATG are unfortunately inferior to horse ATG.
In our hospital at this moment, we have rabbit ATG.
Yeah.
Unfortunately.
So I mean, I have long history of doing this treatment of aplastic anemia, and my impression was that horse was better, and actually that right now we probably have to revise indications that age limit for transplantation, because also aplastic anemia frequently is not really truly aplastic anemia. In some cases it's borderline with MDS actually. And the PNH. So this is actually more complex story, which will be elaborated when we introduce more molecular analysis to these patients.
Thank you for comments.
So thank you very much, and I now handle chairmanship to Professor Dietger Niederwieser to introduce the next speaker.
Thank you.
Thank you. So I'm very honored now to introduce Rainer Storb. And actually, I don't have to introduce him very much because everybody knows Rainer Storb. He's professor and head of transplantation biology program at the Clinical Research Division at the Fred Hutchinson Cancer Research Center and professor of medicine at the University of Washington. So I think it will take 10 minutes to explain all the new things he introduced in stem cell transplantation. The last one is just a 200 dBi, but I think I just give you the word, Rainer, and I would like to thank you for being able to speak to us. So thank you so much for your time, and I'm looking forward to your lecture.
Thank you, Dietger. Can you hear me?
Yes, we can hear you and see you.
Thank you so much for the invitation. It's a pleasure to be able to share some of the data that we have with you. Good afternoon. Here it's morning. So today I'm going to talk about principles of conditioning. And oops, I can't move my slide forward. Let's see. These are my disclosures. The era of modern bone marrow transplantation began in 1945 with the atomic bomb explosions in Japan. It was realized that the bone marrow was an exceptionally radiosensitive organ, and so a lot of research went on afterwards trying to figure out how to overcome this irradiation damage. And out of this emerged the transplant procedure. So the principles of marrow transplantation are depicted here. You take high-dose chemoradiation therapy to get rid of the diseased bone marrow. It suppresses also the patient's immune cells so that a marrow graft will be accepted. And then the idea was to stick in a healthy marrow graft to replace the diseased marrow. And the first thing that was done was figuring out appropriate conditioning regimens. Total body irradiation was very big early on because of that experience in Hiroshima and Nagasaki, but then also other agents, chemotherapeutic agents were examined, like cyclophosphamide, busulfan, thiotepa, melphalan, and others, as well as anti-thymocyte globulin. We first looked at all the variables that may alter the effect of total body irradiation. So we looked at total doses, we looked at dose rates, we looked at fractionation, stimulated by some conversations I had with Rod Withers, a well-known radiobiologist. So we used work in experimental animals and dogs to look at various dose rates and various single and fractionated doses. And you can see here that in the rates between 2 and 10 centigrade per minute, the total tolerated doses between fractionated and single were equivalent, but at higher dose rates, clearly the fractionated dosing was advantageous. Moreover, when we watched these animals for life, we noticed that the single dose animals that had survived the high dose irradiation with the help of autografts began dying off from late radiation damage, while the fractionated dose dogs survived almost 100%. So fractionation was introduced in the late 70s in order to minimize late issues with irradiation damage. Also, cyclophosphamide was examined largely initially by George Santos at Johns Hopkins. He and Al Owens published a paper in '68 that you can actually get grafts in mice. We published a year later similar data in dogs, as well as another year later in rhesus monkeys. And the monkey studies told us a number of things. Here you see, for instance, the white cell and platelet changes in a monkey given 180 milligrams of Cytoxan per kilo. You notice that it is not a lethal dose. The monkey survived with rapid recovery. But if we stuck in an allogeneic graft, unrelated monkey, no matching available at the time, you notice that the grafts also, the counts recovered, but the animal died of graft-versus-host disease with a largely donor graft. We then explored what the highest doses were in these rhesus, and you noticed here that without a bone marrow graft, monkeys given 200 milligrams per kilogram also promptly recovered. But if we got to a higher dose of 240, we lost the animals with heart failure, regardless of whether they got a bone marrow graft or not. So this became then the standard of care in patients. And here is one of our first patients with aplastic anemia. He was transplanted in 1971, Cytoxan 50 times 4, a bone marrow graft. At that point, we only had methotrexate as the immunosuppressive agent. The patient recovered and in fact is now still alive 50 years later with entirely donor type engraftment. Unfortunately, things didn't go always that smoothly. We noticed that patients who had multiple transfusions tended to reject their graft. The rejection rate was approximately 36%, while untransfused patients in the upper line here did far better. We had actually predicted this to happen because of studies in experimental dogs showing that transfusions sensitized the animals to minor histocompatibility antigen disparities with their donors. And so we postulated that untransfused patients would do far better. In subsequent years, we did further studies. We noticed that leukocyte-poor blood products reduced rejection in experimental animals. We realized that dendritic cells in the blood sensitized the recipients against the donor. Accidentally, we found that irradiating blood products was very helpful and dramatically reduced rejection. And then we developed a conditioning regimen where we alternated an alkylating agent with ATG, which also reduced rejection. So we first tested this in a second transplant, and when this looked promising, we began introducing it in first transplants. Here you can see some early data with approximately 83% 17 or 18-year survival. And the last 34 patients transplanted with a reduced dose of marrow cells has shown 100% survival. Patients' ages here range from 1 to 63 years. So this has remained the standard. We also recently looked at all patients who had received this Cytoxan regimen and were concerned about late malignancies. We noted that if you include basal cell and squamous cell carcinomas of the skin, we saw an 11% cancer rate at 26 years. If we excluded those, it went down to 7%, and we had a 5% mortality. Analyzing the data further, we noticed that basal cell and squamous cell carcinoma, as well as oropharyngeal carcinomas, were the main reasons for cancer, and they were highly significantly associated with chronic GVHD. We couldn't find any other associations in these patients. So clearly, Cytoxan is actually a fairly safe conditioning regimen. It has a low incidence of cancer, and the cancers we saw are largely related to chronic graft-versus-host disease, which seems to be the major issue in this patient population. As for unrelated transplants, we are using currently the regimen that was published by Andolini a few years ago in the Lancet Hematology, a BMT-CTN study, where we use Cytoxan ×1, fludarabine ×5, 2-grade TBI, as well as ATG, and survivals are actually rather excellent with this approach. I was interested hearing a moment ago the approach taken in Lithuania, which is also very promising, it looks. As for age, we have no age limits here in Seattle, and here's a paper by the group from England, Judy Marsh's group, showing that patients who are older than 50 years also have really excellent survivals with the regimen consisting of fludarabine, Cytoxan, and alemtuzumab. As for patients with leukemia, we initially used single-dose total body irradiation. And here's a patient transplanted in 1972 with Cytoxan 1000 centigrade, 10 gray, and methotrexate post-grafting. You see the patient's blood counts recovering. This is a patient with primary refractory AML. She developed graft-versus-host disease, which we then treated with homemade anti-thymocyte globulin. She recovered from that. She lived until a few years ago when she died with metastatic breast cancer, most likely a consequence of the upfront conditioning regimen, including total body irradiation. Early patients were all, without exception, advanced leukemias refractory to therapy, chemotherapy then available, which includes drugs that are still being used today. As you can see here, our early results leveled off at about 20%. We lost patients with graft-versus-host disease, cytomegalovirus infections, for which we couldn't do anything, and relapse. So we thought we'd transplant patients earlier when they were in first remission of their underlying AML or ALL. And this was, of course, based on morphology. And results seem to be looking up. We then asked, since relapse turned out to be the major issue, we asked whether we can actually improve outcomes by increasing the upfront total body irradiation dose, and did a randomized study involving a little over 70 patients, where we compared 12 gray fractionated radiation to 15.75 gray fractionated radiation. And you can see here the relapse rate was clearly lower, but the non-relapse mortality was higher. Patients simply didn't tolerate the post-grafting immunosuppression as well. And so in the end, outcomes were very similar. We had about something like 58% long-term survival at 12 years after transplantation. So it shows the limitation of the high-dose conditioning regimen with TBI. Busulfan was introduced very early on, and you can see here in the 1950s and early 70s. Santos in 74 published a paper in mice, and we published a paper in Biomedicine. A little later, we published another paper looking at the use of dimethylbusulfan, which is simply an injectable agent that was available through the NCI, in DLA identicolidomates. And we looked at 16 dogs where we just gave busulfan, and noticed that 8 of these eventually rejected their grafts, while 8 had sustained grafts. And when we added immunosuppression with anti-thymocyte globulin, most of these animals actually engrafted. So clearly, busulfan is not a terrific immunosuppressive agent and requires additional immunosuppression. We used busulfan here, DMM and Cytoxan, to condition the first successful transplant for thalassemia major. This patient was transplanted in 1981, and as far as I know, is still alive and well. A little later, the group in Johns Hopkins, George Santos, published a paper on busulfan Cytoxan in AML. And you can see here that there was something like close to 45%, 50% long-term survival when patients were grafted in first remission. We compare, and this is a regimen that was also then used for sickle cell disease. This is a publication from the 1990s, I believe, and that we published in the New England Journal. And this has remained sort of a staple conditioning regimen for that disease. We explored in the 90s, also in the late 80s, early 90s. We compared Cytoxan TBI to busulfan Cytoxan in a prospective randomized trial. Patients all received methotrexate cyclosporin afterwards. And we noticed that there were really no significant differences in outcome, neither in the relapse rate nor in the mortality rate. And I recently looked at the data again, something like 35 years later, and again didn't find a major difference that was significant. However, we saw that busulfan Cytoxan was far better tolerated. And so it became our staple conditioning regimen, standard treatment plan for patients with myeloid leukemias and myelodysplasias. This was not without controversy. In the 90s also, we looked at measuring busulfan blood levels to be able to better deliver this agent. And you can see here that survival in patients with CML was very much dependent on whether we had more than 917 nanograms per ml blood levels on the various days of the conditioning compared to less than that. And the big difference was relapse. So we are still using monitoring, even though we now use mostly intravenous busulfan. Now, as I said, this acceptance of busulfan Cytoxan as the standard of care in, say, AML isn't entirely without controversy. There was here a meta-analysis published by Saucier in Blood showing the superiority of Cytoxan TBI. And this contrasted with a CIBMTR analysis of Bredesen, also published in the early 2000s, where seemingly busulfan Cytoxan came out ahead of Cytoxan TBI. So it shows you that in order to really address these kind of questions, rather than retrospective analyses, you probably need prospective randomized trials. Another paper from the 2000s, published by Stephanie Lee et al. In JCO, looked at a number of, it's a prospective randomized trial looking at patients with leukemia and MDS, comparing BuCy to BuFlu, asking the question, can BuFlu, which is better tolerated, replace BuCy? And apparently the answer in this trial was no. Cytoxan seems to contribute in some way to the leukemia recurrence control. Another paper, also from our group here, a multi-center paper, asked the question, how does treosulfan, fludarabine, and 2-grade TBI deal with AML and MDS patients? And it seems like this might be an approach that is perfectly fine to use. Randomized trials with this drug have as yet not been done. So the high-intensity conditioning regimen, and I would suggest to ignore the myeloid malignancies in the title there. Currently, Busulfan or treosulfan Cytoxan are our standard of care for myeloid malignancies, while Cytoxan and fractionated total body irradiation are our standard of care for lymphoid malignancies. There are other regimens, VP16 TBI, Melphalan TBI, ARC TBI, which do not seem to be better than Cy TBI or Bucy. So our standard of care is Bu or Treocy for myeloid and Cy TBI for lymphoid malignancies. And here you can see some data from the Thomas book. I think this is our patients transplanted at City of Hope, if I'm not mistaken. These are ALL patients in first remission. High intensity TBI-based conditioning gives excellent results. More recently, in 2020, a paper was published by a childhood ALL multi-center group, which randomized patients with childhood ALL between VP16 and TBI, and fludarabine, VP16, busulfan, or treosulfan. A total of over 400 patients who were transplanted. And you can see that in blue here, the VP16 TBI regimen clearly was significantly better than a busulfan-based regimen, and that was largely due to the increase in relapse seen after the busulfan regimen, while the non-relapse mortality was also perhaps a little better with the TBI regimen. So clearly, this study clearly recommends a TBI-based regimen for ALL patients. Adding ATG to myeloid regimens has been a question that has been around for quite a while. There was a meta-analysis recently published by Kumar in leukemia, and they looked at 7 prospective randomized trials, and they found a reduction in grade 3 to 4 acute GVHD, but no change in NRM or overall survival. So you can add it or not, it doesn't seem to matter. In the late 90s, we began reaching the limitations of myeloablative regimens. And I'm looking here at data at Fred Hutch, I think a total of more than 2,500 patients. When we look at the median ages at diagnosis for the various indications, with the exception of Hodgkin disease, they are between 60 and 70 years. While for related donors, our median age was 40, and for unrelated donors, the patient age was 35. So clearly, we didn't serve the majority of patients. So we went back to the laboratory, actually, and developed a regimen that I will actually discuss in a moment. And here is sort of the landscape currently. There are non-myeloablative regimens, reduced intensity regimens. I don't want to read them all here. And then, of course, the myeloablative regimens that we just discussed. And depending on the aggressiveness of the malignancy, you want to increase the intensity of the regimen. Now, we went back to the lab and looked at a number of variables and used TBI as our conditioning regimen. And when we dropped the dose down to 4.5 gray without post-grafting immune suppression, we had about 16 out of 39 animals showing sustained engraftment. The remainder rejected their grafts, but they did survive with autologous recovery. When adding prednisone didn't help, but adding cyclosporin, short course, all of the dogs engrafted. So we went down to 2 gray, and the cyclosporin didn't work anymore. Methotrexate cyclosporin worked somewhat. MMF cyclosporin was actually pretty good, as was rapamycin cyclosporin and rapamycin MMF. While at 1 gray, we didn't get engraftment. So we began looking at MMF and cyclosporin for patients with HLA-matched related and unrelated grafts. And we added fludarabine to the regimen in order to eliminate the risk of or reduce the risk of graft rejection, and then gave 2-grade TBI. We gave cyclosporin for about 180 days, MMF for 28 days, and in the unrelated, we extended the MMF somewhat, and the cyclosporin was also discontinued ideally at 180 days. This regimen allows for the purest determination of graft versus tumor effects because the conditioning regimen is so weak that we didn't really expect to see much reduction in tumor burden. And it's the best determination of graft versus host disease that's not augmented by regimen-related toxicities. When we looked at the first close to 1,100 patients, we were able to determine patients with low risk, standard risk, and high risk disease. And these are the relapse rate per patient years. You can see that a patient with CLL in remission had a very low relapse risk, as did patients with non-Hodgkin lymphoma at any grade, at low grade, and mantle cell lymphoma at high grade. When we look at other patients here, the AMLs in first, second, or third remission risk, standard risk. And then you can see here, if you have high risk patients like high grade NHL or AML not in remission or evolved from MDS and so on, you had fairly high relapse rates. When we looked at this also in conjunction with comorbidities, patients with low comorbidity scores who were in the low relapse risk group had 60% 5-year survivals, while this dropped down to 42% if they had comorbidities. Patients with standard relapse risk had 50% 5-year survival and 35% if they had high comorbidities. And in the high relapse risk patients, the survivals dropped down to 30 and 25%. So overall, non-relapse mortality was 24%, very much dictated by the comorbidity risk, and overall relapse risk was very high at 34%. Looking at the CI-BMTR, a paper in BMT, we see here that with non-myeloablative, these were retrospective analyses, whether they received non-myeloablative reduced intensity with bone marrow or peripheral blood or myeloablative, their relapse rates were actually pretty equal. At 5 years, some were in the order of 45%. I'm sorry, the non-relapse mortality. So a little higher than what we see in our patients. The relapse risk was clearly lowest in the group with myeloablative conditioning, while it went up in patients with non-myeloablative conditioning. So overall, they saw some of the same problems we saw. Perhaps their non-relapse mortality was somewhat higher than ours. Here's another retrospective analysis from the NMDP, and these are 3-year data. Non-relapse mortality with myeloablative was 42%, and with RIC 34%, and with non-myeloablative 34%. Again, somewhat higher than what we see. With myeloablatives, it was lower, and with RIC and NMA, 37%. And survivals were actually not quite as good as what we have seen, but this is again a collection of data from multiple centers. Here's again another NMDP analysis from 2009, where they show that in patients with AML, MDS, CML, or ALL, the overall outcomes were the same regardless of what conditioning regimens the patient received. Some were the 3-year survivals were on the order of maybe 38%. The best data, but 2-year observation time only, came from a French cooperative group with multiple RIC regimens, AML in first remission age-identical sibling transplants, ranging from 38 to 64%. Adding ATG or alemtuzumab to the RIC regimens, and again, these are two retrospective analyses. One is the CIBMTR. They show an increase in relapse and a decrease in survival. So they didn't recommend, I think, giving either ATG or alemtuzumab. The EBMT showed a decrease in GVHD, but comparable relapse, NRM, DFS, and overall survival. So their data are sort of equivalent. Overall, we don't really add ATG or alemtuzumab to our reduced intensity regimens. Stanford came up with the total lymphoid irradiation regimen, which is somewhat cumbersome to deliver. It takes a number of days to deliver the total dose, and yet a fair number of body parts are actually exposed to the irradiation, and their survivals weren't really all that great. And so this regimen has not really found many people adapting it. Here is a BMT CTN study that was published by Bart Scott from our group here in patients with matched related and unrelated donors, and the patients had either MDS or AML, a total of, and this was a randomized prospective trial comparing a number of myeloablative regimens to a number of different reduced intensity regimens. And the conclusion of the study was that the reduced intensity regimens had a higher relapse rate than the myeloablative regimens, but a lower non-relapse mortality. As a result, the overall survival wasn't really all that much different. But I think it speaks for the fact that in patients who have MDS or AML, higher intensity regimens are probably favorable. Now, this is contrasted by a British cooperative study that was just recently published a year ago or so, where they looked at allogeneic transplantation in a similar way, AML or MDS. They had a control and a Flamza busulfan regimen. That is, they treated the patients very intensely with, well, the RIC regimen was fludarabine, melphalan, alemtuzumab, or fludarabine bu times 2. And here's the more intensive Flamza busulfan regimen. And they found that there was no difference in relapse rates and no difference in overall survival. So again, we have two contrasting experiences. And I think the only way to really know this is to compare, say, this regimen with do a more, what do you call it, more controlled comparison between the regimens used here in the United States and the ones used in Britain. Now, coming back to our own data, where we conditioned patients with fludarabine and 2-grade TBI, looking at the first 1,100 patients, we noticed that we lost 20% of the patients from concurrent or preceding graft versus host disease, 34.5% from relapse at 5 years, and then 4% were other causes. Now, we addressed graft versus host disease, which was mainly a problem in the unrelated recipients, by carrying out a prospective randomized trial that was published either last year or the year before in Lancet Hematology. We looked at MMF cyclosporin, which was our standard, and compared it to MMF cyclosporin and sirolimus, which was a new combination. It was a conclusive phase 3 trial. It was stopped by the Data Safety Monitoring Board early because one group had a significant advantage. And when you look here, the triple drug regimen had only 25% acute GVHD compared to 53%, and grade 3 to 4 was only 2% compared to 8%. As a result, the non-relapse mortality in the triple combination at 5 years was only about 8%, and the relapse rates were comparable, and as a result, survival was far better. So I think graft versus host disease of the acute form has become a far lesser problem in Seattle. We are currently carrying out a study comparing this triple combination to a post-transplant Cytoxan MMF sirolimus combination, and that study is accruing rapidly and no endpoint has been reached. When looking at our data over the last, between 1997 and 2017, our survivals overall have increased, even though our patients have actually worsened. We have more patients now older than 60 years, that's 56%. More patients with unrelated grafts. We take patients with all disease forms, and a number of patients had actually failed prior transplants, and more than almost 50% of the patients had comorbidity scores of more than 3. So overall, things have begun improving. The major relapse, the major reason for failure is still relapse, number one. And so we had focused actually on an approach of radiation immunotherapy. We have taken an antibody to CD45, which is expressed on all hematopoietic cells except multiple myeloma. We have coupled it to a powerful short-lived radioisotopes, and we hope to kill cells with few or no off-target effects. And the idea is to intensify the pre-transplant conditioning, similar to what Bart Scott's study had shown, that if you give more intense conditioning regimen, you decrease the relapse risk. Of course, with systemic therapy, there are limitations simply because the patients are older and don't tolerate these high-intensity regimens. So we hope to get around this by utilizing this approach. And we initially worked with beta-emitting radioisotopes, iodine-131 and yttrium-90. The problems with them are long half-lives, relatively low energy, and fairly long path lengths measured in millimeters. We now have focused over the last several years on a homemade isotope that's generated here at the University of Washington cyclotron. Has a half-life of a little over 7 hours, very high energy, and importantly, a path length of only 0.06 millimeter. We carried out intensive animal studies, and here are some data on DLA identical littermate grafts, and showing you the blood cell changes in neutrophils, lymphocytes, and platelets. And here the solid line is what happens with 2 gray of irradiation. You can see that the neutrophils drop down to a little over 2,000, and here the platelets into the 50,000. Actually, no, it's over 100,000. The lymphocytes, actually, the platelets drop down to 20,000. If we give the antibody isotope, you can see that we killed cells with a more than 3 times, actually 3 orders of magnitude higher intensity. So it's a very intense regimen that we're giving. So after doing animal studies for approximately 8 years, exploring toxicities, exploring how to give this, we decided to embark on human trials. We choose older patients with myeloid malignancies who are not in remission, who have exhausted chemotherapy. We use HLA-matched related or unrelated donors, and we precede the conditioning regimen of flu and 3-gray TBI by an antibiotic infusion here on day -5, then fludarabine, total body radiation, and immediately thereafter the PBSC infusion and post-grafting immune suppression. The trial has accumulated over 40 patients so far, And it's a dose escalation study as requested by the Food and Drug Administration here in the United States. And I'm just showing you some data as to the effectiveness of this approach. These are patients who have actually peripheral blood circulating. And with the exception of patient number 1, where we had to give a very low dose of astatine, you can see that in all the other patients, as we give the astatine here, we see a precipitous drop in circulating blasts, indicating elimination of these cells very, very rapidly. As I said, this trial is accruing. We have not reached yet the maximum tolerated dose, and a little over 40 patients have been entered. In order to approach HLA haploidentical patients, and here's the regimen that we published with the Hopkins group in 2008, cyclophosphamide, 2-grade TBI, post-grafting Cytoxan, MMF, tacrolimus. We saw in these patients a fairly high relapse rate, which decreased the overall survival. And so we also have initiated a regimen for haploidentical transplants, where everything here is the same as before. The only difference is the addition of the antibody isotope approach. And this trial has so far accrued approximately 8 patients and is continuing to accrue. So we hope that by adding a targeted approach to this standard regimen, we will be able to decrease the relapse rate, especially in patients with acute leukemias and myelodysplasias. For patients with multiple myeloma, we have begun using an antibody to CD38 coupled to astatine 211, and are focusing on the development of an antibody to BCMA. So we think that the future of conditioning regimens for unrelated donors is in the radioimmunotherapy targeting specifically the tumor cells. And with that, actually, I've come to the end of my presentation, and I thank the patients, my former mentors, Donna Dottie Thomas, transplant teams, my lab, and all my clinical and laboratory collaborators listed here. Thanks for your attention.
Thank you very much, Rainer. This was a highlight for the symposium. Thank you so much, not only for this presentation, but all the protocols you have established in the last 40 years or 30 years. I remember this to the younger colleagues of me, that they are using 12-grade TBI or 2-grade TBI without knowing how much work it was to identify the right dose, and also immunosuppression. So, and all the new ideas which you brought up for our patients also. So thank you so much. Any questions? So I was impressed about the radioimmunotopes, the antibody conjugated radioimmunotopes. So this is the next step in treating patients with AML. And I think that this is urgently needed because we still have 40% of relapses in AML, and especially in elderly patients. So I'm looking forward to these new protocols, even if it's a little difficult probably to have the regulatory stuff in place. Can you comment on this?
Well, we actually had not much trouble getting the FDA to approve the protocol. I think they were impressed by the enormous amount of preclinical data that we had. We worked for about 8 years, Brenda Sandmeyer, myself, and then the radiation chemist Scott Wilbur, in dogs. And when we submitted the protocol, the first protocol to the FDA, which was in December, they approved it over the holidays, actually. But they insisted on a dose escalation study. So we started actually at a very, very low dose of astatine 211. And as a result, I remember the first patient had bone marrow full of disease, and he relapsed, I think, within about 84 days after transplantation. He got the lowest dose, and he's the one whose peripheral blood blast even didn't clear. But now the protocol is up and running, and we are expanding it now into patients with AML in first remission, because again, there we still have a relapse rate that's quite substantial, in part because patients who have MRD by molecular technologies or by flow cytometry have fairly high relapse risk. So we believe it's a really good approach. It's very well tolerated. There are no side effects except it's a murine antibody that we still have. Occasionally you see antibody reactions, but that's exceedingly rare. So I think it's an approach that's worthwhile looking at. And we hope, for instance, in unrelated transplants for aplastic anemia, to be able to replace the small dose of total body radiation that's being used there. So, yeah, I think it's an interesting approach.
Okay. We do not have any questions from the audience. Yes, questions?
Yeah, I would ask a question. Actually, what would be your suggestion? Because there's more and more frequent approach to outpatient transplantation. You're as a pioneer of low dose conditioning. Which regimen you will suggest to use for this setup?
Yeah, we routinely transplant these elderly patients as outpatients. So all of the conditioning is done in our outpatient unit, which is on the Fred Hutch campus. And we noticed that 50% of these patients actually never get hospitalized. So they're all outpatients. And 50% get hospitalized with a median duration of hospitalization of 6 days. They get hospitalized because of fever. Sometimes it's engraftment syndrome. Sometimes it's a real infection. They get hospitalized sometimes because they come in with comorbidities requiring, cardiac monitoring, et cetera, et cetera. So more than close to half of the patients never get hospitalized. So I think it's overall far cheaper a procedure if you have the appropriate facilities. Our clinics are open every day of the year.
Okay. Any other questions? There are no more questions. So thank you again, Rainer, for this highlight of the symposium. And we are looking forward to the next symposium, to next news from Seattle.
All right. Well,
thank you.
Good seeing you all. And
okay.
Thanks for listening.
Thank you.
Bye-bye.
Bye-bye. So now we have the summary, and if Vyacheslav agrees, I will just make a very short summary. I think everybody is tired, but I think it was an excellent meeting today, and we are happy that, or at least I am really happy that I'm living in a time where we have so much news. And I just want to start with the new drugs in MDS and AML and the different combinations which we have today. With not all of them are, of course, approved, but we are making studies on this. And I think at least in one special subtype, we are chemotherapy free. It will take a very long time to have it in AML or MDS overall, but I think we are getting there. And this topic is actually one of the topics in all the diseases which we heard today. We didn't reach it, but this is it's an aim to reach in the next 5 or 10 years. By the way, I never saw so many New England Journal of Medicine paper as today. So the citation was just extremely good. The presenter were extremely good and in time. And we touched a lot of important questions like the CML, where Andreas Hochhaus discussed the 3 or 4 options we have for first treatment and also when to stop. We had a very interesting presentation from Tiziano, which looked at the importance of interferon alpha, which is at least for some subtypes of myeloproliferation syndromes or diseases, neoplasma, is better than phlebotomy alone. And he looked also at the different problems which we have with COVID. The presentation from Greinacher was excellent. Unraveling the problems which we have of thrombosis after the vaccination with the AstraZeneca the drug or vaccination is really something which I like very much, and perhaps it would be very easy to go rid of this problem just by purifying or by deleting or by taking out the human proteins and the ADTKA in the drug. Professor Klimenko spoke about alterations after Chernobyl. I think this will be not only, this will give us a lot of experience in the evolution of a study, in the pathophysiology of a study. So this is, I think, something which we're looking forward also to comparing not irradiated with irradiated patients with the same disease. Now, one of the most exciting things about medicine today is the RNA technologies. We experience this all by our vaccination products from BioNTech and from Moderna. So this has helped us to understand much more about how we can use mRNA technology not only to vaccinate against virus, but also to treat patients with solid tumors and also with probably hematological malignancies. We understand that it may be a problem to infect hematological stem cells with gene therapy, and I guess that RNA technology will actually probably replace the gene therapy, at least in stem cells, because there you can make gene editing, and gene editing is also done with messenger RNA technologies. We have seen in sickle cell disease very interesting data, and we actually realized that haploidentical transplants in sickle cell diseases, especially in younger patients, are really referred at the moment. We have done also some studies here with gene therapy in Leipzig when I was the head at the university. And in parallel, we did also a transplant study with the same disease. So this is the data which has been presented by Kühl. I think this is also showing us that at the moment we will have probably stem cell transplantation in front, but we don't know for the future. Now, about GIA, GIA already showed that we have a chemotherapy-free world. We have now a third generation of BTK inhibitors, and what we still need to know is a continuous or intermittent treatment of the disease. Heinz Ludwig spoke about COVID vaccination in multiple myeloma, and we have to make attention to that, because some of the patients which are treated, which are vaccinated, probably need more vaccinations, multiple vaccinations. Paul Richardson has actually shown that we have much more options than we think, and I'm excited to see that we have now peptide formulation of melphalan. We have new drugs, new concepts which we bring in the treatment of our patients. MRD, it's making a big issue in stem cell transplantation, but also in other diseases, not only stem cell transplantation. But I think by improving the technique to measure minimal residual disease, by knowing how the pathomechanisms are of the disease, we can also have much more drug to cure our patients. So I'm very happy about this meeting, and I think suggestions for the next meeting next year you can send to either Rolandas or Thomas. I'm not sure if we can hold this excellent quality also for the next meeting, but I was wrong also the last year or the year before. So I guess the next meeting, or I hope that this will be an in-person meeting. We had more than 400 participants, I guess, from more than 20 countries. And I would like to thank the people from Kaunas and give a remote applause not only to the physicians from Kaunas, but also to the people from Eventus, which did a great work. So thank you very much from my side.
Thank you, Professor. And from our side, we are thankful for you, for your efforts, for a lot of work, everyday work, and amazing speakers which you joined all together in our meeting. So without you, this meeting would not be a meeting like this. Thank you so much.
Yeah, I also joined for this, and I would say what we are standing on the giants, on the shoulders of giants of hematology, stem cell transplantation, and it's a great honor to us what we are together. And thank you, Dieter, and thank you all speakers, and also would like to thank our sponsors for helping us to organize conference, and I just also would like to invite you all in Kaunas next year, Peter, I think, yeah. Yeah, thank you very much.
Okay, thank you, and goodbye.
Bye-bye. Thank you so much for everybody.